start with Dr. Mariam Abdallah. Dr. Mariam Abdallah, she's graduated from Kuwait University College of Dentistry in 2011. She received her MFDS diploma of Royal College of Surgeons in Ireland in 2014. She completed her first part certificate of Kuwaiti board in the same year. Followed that, she completed her Kuwaiti board of pediatric dentistry in 2023. Dr. Mariam Abdallah has actively participated in numerous lectures in many conferences at national and international conferences during her residency at Kuwaiti Board of Pediatric Dentistry, enhanced her knowledge and skills in pediatric dentistry field. Dr. Mariam Abdallah is currently works at Al Jahra Dental Center and it's in pediatric dentistry department. Dr. Mariam, all the stage is yours. Thank you.
Thank you, Dr. Sarah, for the lovely introduction. Good morning, everybody. Thank you for being here so early in Friday morning. Inshallah, you will find it interesting and you will enjoy this presentation. As Dr. Sarah mentioned, I graduated from Kuwait University and Kuwaiti Board of Pediatric Dentistry, so made in Kuwait and abroad. Why did I choose this topic, Risking Young Smiles, Vital Pulp Therapy for Immature Traumatized Permanent Teeth? Because every time I see or heard immature incisors teeth in young children traumatized, and the clinician, whether it's GB, endodontist, or pediatric dentist, jump into root canal treatment and non-vital pulp therapy, and the prognosis of the tooth will be poor for the long term and survival. I feel sorry for this. So I think we should raise the awareness about the management of traumatic dental injuries, raise the awareness about the evidence base behind vital pulp therapy, the new investments and the new materials that have been used in vital pulp therapy for better management and better outcome for these young children. Sorry. I think there is something wrong with the pointer. Okay. For today outline, it's divided into two parts. First part, I'll be talking about the traumatic dental injuries. Okay, thank you. So the first part will be talking about the traumatic dental injuries, the sequelae, and a general introduction about it, and we'll focus on complicated crown fracture and how the wound heal. And the second part will be about vital pulp therapy, evidence-based, success rate, materials that have been used, and I'll end this presentation with a few cases that I treated during my residency in Kuwaiti Board in pediatric dentistry. So I'll start my presentation with this case. It's irrelevant. It's a trauma to a primary teeth, but this was the first trauma case was assigned to me during my residency, and I was supervised by Dr. Mohammed Hassan and Dr. Anfal Faraidun. This 5-year-old child was presented to our dental clinic during the pandemic lockdown, and he was hit by a car while he was crossing a street. He was in a hospital overnight to do investigation and observation to exclude any serious injuries and head injuries, and after all the results came normal, they sent him in the morning to our dental center to manage the dental trauma. I feel sorry for him. He had swollen lips, injuries in his extraoral, intraoral, many laceration, many extrusion. Parent was panicking, and the child was so anxious. We did invasive treatment as a first dental treatment. We extracted, as you can see, many teeth. He had laceration in his intraoral. We did suture. After finishing the treatment, I discussed it with Dr. Anfal, and I told her I feel sorry for this child. The healing will be very difficult for this child. She told me something. She told me, growing children has an amazing ability to heal, and you will be surprised next visit, in the follow-up visit. Yes, I was surprised. After 1 week, you can see pinkish intraoral soft tissue. You can see normal lips. You can see everything goes back to normal within a very short time. So from this case, I learned my lesson that growing children has amazing and incredible ability to heal, including their soft tissue, hard tissue, and also pulp tissue. So traumatic dental injuries, according to Anderson, it's injuries to the teeth, periodontium, and sometimes the surrounding soft tissue. It can be classified into injuries to hard tissue and injuries to soft tissue. I'll just mention it very quickly. Trauma to hard tissue, including enamel infarction, fracture, uncomplicated crown fracture. What we'll focus today about complicated crown fracture, which is enamel dentin fracture, involving the pulp crown root fracture, and alveolar bone fracture. While dental trauma to soft tissue, including concussion, subluxation, intrusion, exclusion, lateral luxation, and avulsion. Traumatic dental injuries and permanent dentition, as we all know, crown fracture injuries to hard tissue is more prominent than injuries to soft tissue in permanent dentition, and the most affectedly teeth are the maxillary incisors. Literature guidelines, when they are talking about the reason for traumatic dental injuries, they're discussing that it's unintentional full collision and engaging in contacting sports such as boxing, football, soccer, basketball. Unfortunately, our sedentary lifestyle and nowadays and our addict to screen can also be one of the main reasons for traumatic dental injuries. So how many times it happens to you, your child, your friends? I had a patient, adult patient, that had dental trauma for her, both central incisors due to laying down and the mobile full on her face. And also unattentionfuls due to talking on your phone or watching your phone. Actually, I was a victim of video call while going down the stairs, but alhamdulillah, I didn't have any fractured teeth, but I have a fractured leg with a cast for 6 weeks. So even our sedentary lifestyles and addictive screen can be a reason for dental trauma. So if you see a red flags, you should warn your patient or the parent. Why it is important to know about trauma and treatment and management of traumatic dental injury? Because it has serious sequelae on the child, on a parent, and on a healthcare system. Any physical hurt will cause pain and discomfort. Even after the appropriate management, patient will suffer from pain and might need taking painkiller for a long time. Functional alteration. Patients with fractures, patients with suffer from mobility will have alteration to function for sometimes. Aesthetic, and it's because we know most of the trauma happens to the anterior teeth, and it has aesthetic impact that will affect on the psychological being of the patient. It will affect the social interaction of the patient. Patient will stop talking, smiling, and laughing, and we should address this chief complaint. Phenotics, if it happens in early ages, yes, trauma to the anterior teeth can affect phenotics, and even the simplest trauma won't be treated in one visit. It will need at least one follow-up visit. Multiple visits means missing working hours for parent, missing hours for a child, and increasing the cost on a parent and on a health care system. Sometimes the treatment is too complicated. It will need the input of more than one specialty, and this will increase the cost of treating the traumatic dental injuries. What are the goals of managing traumatic dental injury? As I mentioned, addressing aesthetic, phonetics, functional, mastication, and sometimes even with poor prognosis for long-term tooth due to traumatic dental injury, we should preserve this tooth, either to preserve the bone or to preserve the teeth. Any dental trauma patient should have immediate, intermediate, and long-term treatment plan for better outcome for a long-term for the patient. Since I'm talking about risking children's smiles, I should talk about how to prevent these dental injuries. According to the study, 7 to 25% of all dental injuries because of sport contact can be prevented if the appropriate preventive devices was used, such as helmet, face guard, mouth guard. This is on you. As a first visit, when you take history, you should take a proper history. If the patient is engaged in contact sport, what kind of contact sport, provide the parents with mouth guard. For example, if the patient is practicing football or boxing, and even if you feel that the patient is a high risk for dental trauma, you should educate the parents how to manage this trauma, what to do when this trauma happens, where to seek a treatment if this trauma happens. It's all on us, pediatric dentists. Now I'm going to talk about the complicated crown fracture. As we mentioned, the maxillary incisor is the most commonly affected teeth, and it's more prominent in permanent dentition than in primary dentition. The prevalence of complicated crown fracture, according to the study, 2 to 13% of all traumatic dental injuries. Clinically, you will see hemorrhage or exposed, but sometimes it's a pinpoint. You cannot visualize it or see it with your bare eyes. So please pay attention to the exposure and pay attention to this. Sometimes patients will suffer from sensitivity to thermal stimuli. Sometimes patients will come complaining of pain while eating. Patient will be tender to percussion, palpation, and radiographically it will only provide us an estimate of pulp exposure dimension. And keep in mind, our radiographs are 2D, two-dimensional. So sometimes the radiograph will show you that the fracture line on the pulp and it's exposed, but clinically it's not, and the opposites might happen. So please pay attention to the radiograph. Since we were going to talk about vital pulp therapy, I'd like to talk a little bit about wound healing to understand how the pulp tissue healed and what is the idea behind the vital pulp therapy. So wound healing, according to Anderson, it's a reaction of any multicellular organism on tissue damage in order to restore the continuity and the function of this organ or tissue. The healing of mineralized tissue or soft tissue is a very sensitive process. Any minor changes in the management and treatment will affect the outcome, will affect the quality and the rate of the healing. So what's happening in a cellular level? The steps in wound healing, first of all, the bleeding will be controlled by two actions, by the vasoconstriction and by coagulation and declotting. Then the inflammatory response by the migration of the leukocytes. It will come to the site of the wound and it will prevent infection in this wound and let's say cleansing the wound. And then the connective and epithelial tissue will migrate and proliferate. This to obturate the defect in the wound and also to give it a mechanical strength. And finally, reorganization of the tissue by a remodeling process with an organized collagen fiber. Healing of a wound in a traumatic dental injury, it's either regeneration, which is a process where the original architecture and function of the disrupted lost tissue is completely restored, or repaired, where the continuity of a disrupted tissue will be restored by a new tissue that doesn't have the same or original structure and function of the original tissues. So what happens for the pulp dentin complex? It's attempt of regeneration by generating a hard tissue, which is a dentin, a closure to the exposed pulp after applying the appropriate pulp capping material. This will induce uncommitted pulpal cells to be differentiated into differentiate into odontoblast-like cell to produce the reparative dentin, and all this process will be regulated by many growth factors. So what we understand that pulp tissue after the reproduction of the reparative dentin, it has the ability to heal even the inflamed tissue. And from here, the vital pulp therapy gets the idea. So what is a vital pulp therapy? It's a management strategies aimed at maintaining the health of all or parts of the pulp. It is a conservative approach when the pulp is exposed either by accident, such as in trauma cases, accidentally while you are excavating the caries, or by caries. In the last 20 years, many advancements changed profoundly our thinking about the vital pulp therapy area. First of all, the advancement of the bioactive calcium silicate cement group, and improvement in our thinking of how the pulp tissue healed, and finally the technical and biological improvements in wound lavage and tissue handling. Also the advancements in loops and microscope that will give us better visualization of the pulp tissue. All these encourage many clinicians to shift from conventional treatments such as root canal treatment into a more conservative, minimally invasive procedures such as vital pulp therapy. Why? It's a quicker, faster, less technique sensitive and complex and invasive. It will reduce the unwanted effects such as discoloration, fractures, and the residual periapical infection. And the most important thing for us as a pediatric dentist, it will facilitate ongoing root development and apical closure, especially that when the trauma happens to 7, 8, 9 years old children, to the maxillary incisors, it will be immature. The root will be short, the canal will be wide, and jumping into non-vital pulp therapy and root canal treatment will compromise the prognosis of the tooth. And doing a vital pulp therapy and give it a chance for more development, it will give it a better prognosis and a better survival rate and a function. So vital pulp therapy include indirect pulp capping, or what we call it selective caries removal, where all the caries will be removed from the wall and only some of the caries will be left on pulpal floor to prevent exposure, and then biocompatible dental material will be applied. Direct pulp capping, where we put direct pulp capping on the exposure of pulp tissue. Partial pulpotomy, part of the coronal pulpal tissue will be removed, while full pulpotomy, the full pulpal tissue, coronal pulpal tissue will be removed, and then apply direct pulp capping material. So vital pulp therapy, we can use it on a normal pulp or reversible pulpitis pulp when the pulp is diagnosed as a normal or reversible pulpitis. But why? Why we do vital pulp therapy for normal pulp? As I mentioned, if it's accidentally exposed, such as in a trauma or mechanical exposure, the tooth will be symptoms-free, and there will be normal response to pulp sensibility test. Just a quick revision. Any trauma case in a baseline, first visit and the follow-up visit, we should check on a color, response to percussion, palpation, if the mobility is physiological or has abnormal mobility, the response to thermal test or cold test, and finally the electrical pulpal testing. While to diagnose a reversible pulpitis preoperatively, it's based on subjective and objective finding to know the ability of the inflamed pulp tissue to heal totally. It will be depend on a clinical and radiographic parameters. Clinically, the patient will have sharp and provoked pain by thermal stimuli, no soft tissue changes, no abscess, no sinus tract, normal response to percussion and palpation, and finally, physiological movement only. While radiographically, no changing in the periapical region. Sometimes Sometimes with all subjective, objective sensibility tests, it will be difficult for a clinician to make sure whether this is reversible or irreversible pulpitis, and the clinician will go to open the pulp, expose it, and check the quality and the presence of vital pulp tissue, and after irrigation to check the hemostasis, whether we reached a vital pulp or we should go deeper and take more tissue to reach a vital pulp. And then we apply the pulp capping material. So what are the pulp capping material? Calcium hydroxide was the gold standard for many years. It used for many years after, before the investment of the group of calcium silicate cement. So let's talk about calcium hydroxide first. What are the advantages? Biocompatible, antimicrobial. It will stimulate dentin formation. It has high pH, radio-opaque, and finally, it's very easy to use. What are the disadvantages? Some authors suggest that after applying calcium hydroxide, it will be disintegrated, it will be disappear, and some suggest it will be disappear totally. Another thing, that the quality of the dentin that will be reproduced after applying calcium hydroxide, it will be porous, it will has a hollow effect. So the inability to provide a permanent seal plus the hollow effect and the porous dentin, eventually microleakage will happen, bacterial invasion and infection in the pulp canal. Calcium silicate cement group. It includes tricalcium silicate, dicalcium silicate, hydraulic calcium silicate, and finally bioceramics. Advantages of calcium silicate cement: it's totally biocompatible. It have an amazing and perfect seal ability, will prevent any bacterial invasion. Low shrinkage after setting. It will prevent again the microleakage. It has microleakage. It has a very high compressive strength, which make it very suitable to be used for endodontic treatment. Radio opaque. We can visualize it in radiograph. Hydrophilic, it can be set in wet environment, and finally regenerative. It promotes healing and production of dentin. What are the advantages of these silicate cements? Setting time. Sometimes it's very long, and it will compromise the dental treatment. Cost, it's very expensive comparing it with other dental material. Sometimes it's difficult to handle and manipulate, and it will be challenging to some practitioner. MTA, especially when it will be used in anterior teeth, it will cause discoloration. And moisture sensitivity. although it's hydrophilic, but excessive wet environment, excessive water will affect its handling and setting. So what to use, calcium hydroxide or the silicate cement group? This meta-analysis was done in 2015 to compare between the MTA and calcium hydroxide for direct pulp capping, and I think only 13 studies were met their inclusion criteria. And they concluded that MTA has a higher success rate and less pulpal inflammatory response than calcium hydroxide, and MTA appears to be a suitable replacement for calcium hydroxide when using in pulp direct pulp capping. This is the American Association of Endodontic statement, position statement 2021 about the vital pulp therapy. They stated that when MTA and calcium silicate cement are used, the success rate was 85 to 100% at 1 to 2 years, while when calcium hydroxide and other material used, the success rate was lower, 43 to 92%. Not only the AAE, also the European Society of Endodontics 2019 and many other guidelines and International Association of the Endodontic recommend to replace the calcium hydroxide with calcium silicate cement. What are the success rate of vital pulp therapy? According to this systematic review and meta-analysis of randomized controlled trial, when MTA and calcium silicate cement was used, in vital pulp therapy, the success rate was 93%, and the only adverse effect was discoloration associated with the use of the MTA. Another systematic review, 2 years ago, it was done in Qatar. They did it to, they compared between the vital pulp therapy for a traumatized permanent teeth, and the success rate for partial pulpotomy was 82 to 100%, while the success rate of complete pulpotomy was 79 to 85%, and finally, the success rate of direct pulp capping was only 19%. So, these meta-analysis and many other meta-analysis and systematic review or randomized controlled trial are very promising about vital pulp therapy management for a traumatized young permanent teeth. Now I'll discuss a few cases, 3 cases that I treated while I was resident in Kuwaiti Board Pediatric Dentistry. For traumatized anterior teeth, I treated with Bati Bioceramics, vital pulp therapy, and the supervisor was the amazing Dr. Sharif Al-Mkhazim, the one and only endodontist in KBBD. And all the 3 cases were not a fresh trauma. At least 2 or 3 days, the trauma happened 2 or 3 days before presenting to my clinic. The first patient is 8 years and 2 months. She had a trauma in the park, and she presented to my clinic 3 days later. She was complaining of pain while eating. Upon clinical examination, it was complicated crown fracture, and we can see here how short is the root, how wide is the canal, and a very huge, large apical apex, and jumping into non-vital pulp therapy will compromise the outcome. So what we did is a partial pulpotomy with Bati Bioceramics, and this is the tooth after 1 year and 2 months. And the tooth is symptom-free. My next case, she's 9 years old. She presented to dental clinic after a weekend. She had a trauma during the weekend indoor in her room. And again, she suffered from sensitivity. And we can see here the open apex. What we did is a vital pulse therapy with body bioceramics. And this is the tooth and root completion after 1 year and a half, almost 1 year and a half. My third case was 8 years and 9 months. Again, she was in the farm with her family during the weekend. She had a trauma, and she came to my clinic on Sunday after the weekend, and we can see open apex. And it was complicated crown fracture. What we did, partial pulpotomy with body bioceramics, and this is the tooth after almost 1 year, 1 year and 1 month. And all the teeth are symptom-free. And in the last conference, IADT conference in Tokyo, July 2024, our director, Dr. Anfal Faridun, presented this poster with a few cases of the residents treating traumatized teeth with vital pulp therapy, and all the cases were success. As you can see, in Kuwaiti Board Pediatric Dentistry, we manage many trauma cases and vital pulp therapy, and we treat it as a vital pulp therapy, and we have a very high success rate. So, in conclusion, we all know that traumatic dental injuries has a negative impact on the child. Either it's psychological, it's functional, it's aesthetic, it's social. That's why it is very important for the early and appropriate management, for very essential by a trained dentist for a successful outcome. And sometimes it will need a multidisciplinary team. So take a second opinion. Consult other specialty. Sometimes you will need endodontist, you will need pros, you will need ortho, sometimes oral surgeon. We should work as a team for the better outcome of this trauma. And in the first visit, you should explain to the parents how important is the follow-up visit. Explain all the sequelae and the complication they might face, and how to overcome these complications. Explain to them trauma cases cannot be treated in one visit. Sometimes, according to the IADT follow-ups guidelines, we need a follow-up of 5 years. Their compliance is very important. Even you, in your center, in your workplace, you should have a tracking system for trauma patients. If you don't have one, create one, because trauma patients are our children, and our children deserve the best. These are my references. Thank you so much, and please, if you have any questions, let me know.
So thank you, Dr. Mariam, for your insightful presentation and informative lecture and the great performance today. I think she made our morning, and we are now, I think it's a time for any questions that come from audience. Yeah?
Thank you, Doctor, for the amazing lecture. I'm asking about what you prefer, the layer above the bioceramic putty. What you prefer to put, glass ionomer or dical, or what's the material?
Usually we use a glass ionomer and then the final restoration.
Thank you, that's it.
Thank you, Dr. Mariam, for the amazing presentation. We are all so proud of you.
Thank you.
I just wanted to ask you, in traumatic dental injury in anterior teeth, do you prefer to use a gray or white MTA? Also, or not any, or do you prefer to use the putty?
I don't prefer to use MTA, whether it's white or or gray, because it's, according to the literature, eventually it will discolor the tooth, especially in this aesthetic zone. So bioceramic spotty is much better option in these cases. Any more questions?
Thank you again. And on behalf of KDA and all of us, we would like to thank you. And we would love to handle you a little present that comes to today. And thank you for your presence, which is make our conference so special. Thank you, Dr. Mariam.
Thank you for this opportunity. Thank you, Habibti. It was a pleasure.
comfortable wearing it the whole.
Hello.
Good morning, everyone. Let me start to introduce for you Dr. Shahid al-Shumali. Dr. Shahid is double board certified pediatric dentist with a strong commitment to evidence-based practice. She completed her residency at the University of Illinois at Chicago and holds a master's degree in oral sciences. As a dedicated member of the AAPD Evidence-Based Dentistry Pulp Therapy Committee for over 9 years. Dr. al-Shumali has co-authored 3 award-winning systematic reviews and 2 clinical-based guidelines published in the Pediatric Dentistry Journal. Her conclusions have significantly impacted the field of pediatric dentistry worldwide.
Thank you for the introduction. Again, my name is Shahid Shumali. I'm a pediatric dentist. I graduated from Kuwait University, and then I wanted to pursue pediatric dentistry. I had a great role model in Kuwait University, Dr. Abdulaziz Hassan, Allah yarhamah. He was the one person that motivated me, and I wanted to be exact like him. And I want to get my education in the state. So this was the drive. I wanted to be in the state, and from that, I started applying. And unfortunately, I was not accepted at the beginning. The first time I applied, I was not accepted. Yet I was offered a 1 year at University of Maryland as an externship year. Subhanallah, this year اللي كانت أسوأ year حقي لأن ما اختاروني من البداية turned to be the best year in my career. فكل تأخيرة فيها خيرة وعسى أن تكرهوا شيئا وهو خير لكم. I did this year in University of Maryland, and there, within 3 months, Dr. Jim Cole, he's the head of the AAPD Bulb Therapy Work Group. He selected me to be part of their committee, and 9 years forward, we did 3 papers, we did 2 guidelines, working on publishing the 4th systematic review. I did my residency in University of Illinois and then returned back to Kuwait. I practice in Amiri Specialized Dental Center. The goal today of my presentation is to show you what happened during the 9 years and what is the latest evidence. So the goal of my presentation is to provide a comprehensive overview of the evidence-based guideline for pulp therapy in primary and permanent teeth, focusing on the work of the AAPD Pulp Therapy Work Group. As you know, the American Academy is a huge academy. It has already their policies, their guideline. But 10 years ago, they started a section called evidence-based, where they want a group of clinicians or academic to look and focus mainly on developing best evidence studies, summarizing all the literature that is there, and to conduct a systematic review that from this systematic review we can create a clinical-based guideline. And we did that. So this is the main focus. Why did they do it? Because they want to ensure optimal patient outcome. They want to reduce variability in clinical practice and to promote a continuous improvement in care. So when doing the systematic review, we are standardizing everything. So all the papers are standardized in terms of success, follow-up, everything, so we can draw a conclusion. The outline of my presentation will as follow. First, assessment of the pulp status, vital pulp therapy, non-vital pulp therapy, and vital pulp therapy and permanent teeth. To start with, it's just a quick overview of the assessment. As any patient come to you, you have to have a thorough medical, dental history. You gather all the information of the patient, complete your subjective evaluation, objective by doing the intraoral, extraoral exam. Make sure you take your radiograph. I know we work with challenging a group. 0 to 6 is very difficult to get radiograph, but you have to take a radiograph. And then complete your clinical assessment. Do not rush into it, oh, this child have pain, let's send him for x-ray and that's it. No, check, there is mobility, there is any swelling, you have to do a proper clinical exam. So for the EPT and cold testing, generally we're not doing it for primary teeth, although in Jordan they do for primary teeth, but honestly, for me, doing like percussion test on the kid, he will freak out, so I wouldn't try it. Here I'm just showing the importance of taking radiograph. This is an actual patient of mine. I don't know, there's a pointer, it doesn't show. Anyhow, on the bite wing, you can see the 8-5 deep caries, recurrent caries. When we took a PA, you can see she's 9 years old and a half. She's missing her premolar. So I'm putting this slide to just emphasize the importance of taking proper radiograph, a radiograph that you can see the apex, you can see the furcation, and you can see the developing permanent tooth. Now moving into the diagnosis, in primary teeth we have normal, reversible, irreversible, and necrotic. For the sake of the modality of treatment, we're putting both the irreversible and necrotic together in one category. For normal pulp, they are the teeth without any sign or symptoms of irreversible pulpitis or reversible pulpitis. They are classified as having a normal pulp. For reversible pulpitis, they are the teeth with provoked pain of shorter duration of time, and there is no signs or symptoms of irreversible pulpitis. These teeth are relieved when you remove the stimuli, removal of the stimuli, and they are relieved when you do brushing. And remember, closed lesions progress way more faster. So when you have a interproximal cavity that is closed, these lesions will progress way more faster than the lesions that are open. For the irreversible pulpitis and necrosis, as I said, we put them together because at the end we have the same treatment modality, but they are different. We will not have irreversible pulpitis with sinus tract, okay? But just to, in a way to summarize the non-vital therapy. So spontaneous unprovoked pain, sinus tract, soft tissue inflammation, internal or external root resorption, furcation, and apical radiolucency. I graduated from KU, so there, everything's changed now. But we had the thing that when we do a pulpotomy and the bleeding doesn't stop, we will immediately say this tooth has the irreversible pulpitis. We based our diagnosis on only the bleeding. We cannot do this. After there is a study by Mutalai, I'm quoting from it, controlling bleeding at the exposure site or canal orifice does not provide accurate assessment of the inflammation at the canal orifice and may be misleading for diagnosing vital pulp treatment in primary teeth with a carious pulp exposure. So you cannot diagnose only because of the bleeding. You have to have another sign or another symptom for diagnosis, but only using the uncontrolled bleeding, this is not accurate anymore. Now, the second part of my outline is talking about vital pulp therapy. As Dr. Maryam, she mentioned, roughly, it's the same. Vital pulp therapy for primary teeth include protective liner, IPT, direct pulp cap, and pulpotomy. For protective liner, you remove all the caries, complete caries removal, and you apply your medicament. For indirect pulp therapy, you leave caries, but this caries is affected. You remove all the infected dentin and keep a layer of affected dentin and then apply your medicaments. For direct pulp cap, it's whenever you have a pinpoint exposure, mechanical exposure, or after trauma. Of course, it happened to me in the most challenging situation. during my residency with the most challenging mentor. يعني the one that you don't want to make a mistake. In the state, we have a prefabricated SSC crowns for canines. I know you will say it is a Dracula teeth, but whenever there is multiple surface and we're putting the child under GA, we will put the primary SSC on the canine. So there is prefabricated ones. So I removed the caries, mesial distal, everything is fine. Now I'm doing my incisal reduction, and she said it, take care, do not expose. And I was like, of course, running fast. I did the incisal reduction and I exposed the bulb. يعني ما بقول لكم وياها شنو كان. يعني درس ما عيده. The idea, you need to check the radiograph, check where is the pulp horn. Sometimes it can be deceiving. It might be very up high. So what we did, we just placed a putty, ceramic putty, and then covered it up with the SSC. The last one is pulpotomy. When you do a complete caries removal, and you have to do a full deroofing. Something I need to mention, you need to make sure when you do the pulpotomy, you have to remove the caries, and then change your burr. Get a new one. We don't want to introduce the bacteria from the caries to the pulp chamber. And then here you can see I highlighted in red the materials we have: MTA, biodentin, ferric sulfate, formicrozole, and calcium hydroxide. The one in red, do not use. We are recommending against their use. This is just a case of mine. Patient, I saw her at very young age, but mashallah, every time she comes with interproximal caries, we treated her with 2 MTA pulpotomy on the lower E's. And then this is her follow-up after 3 years. Now talking about the vital bulb therapy work group. These are the people I have been working with for the past 9 years. We originally started as only 5 members. Dr. Jim Cole, he's on the top. This is your right or left? Left side. Left side, Dr. Jim Cole, he's an amazing. He's down to earth. He have the name tag in University of Maryland as a student Jim because he believes every day we are learning. So مو بس إن تخرجنا وصرنا specialists. We know everything. No, it is an ongoing process. بعدها دكتور عبد الله المرغلاني, he's mashallah, he's a statistician, and he has a PhD in statistics, and he's a pediatric dentist. He's a faculty in القرى. Then of course me. بعدها دكتور Vinit Dar, he's a vice dean at University of Maryland and head of the department. Dr. Yasmi Crystal, she's a professor at NYU. Dr. Jayu Chen, she was in Maryland and now she's practicing in Washington, Seattle. Dr. Marcio Gilman in the middle, he's a faculty, actually he's a faculty in the University of Florida, and he is the vice of the American Board of Pediatric Dentistry. So whenever you get your diploma, his signature is there. Then Dr. Young, she is the program director at University of Washington, Seattle. And then lastly, Dr. Jerry Glickman, he's the endodontist. He's a past president of the AAE, and he started with us this project 3 years ago to initiate the joint AAPD AAE guideline. To start, first, we worked into doing a systematic review that got published in 2017, and we won the best evidence-based paper in Hawaii, and we were awarded, this is me and Dr. Cole in Hawaii. And then following that, the American Academy of Pediatric Dentistry, we have to do renewal of the guideline every 5 years, so we have to do another updated systematic review. We did that last year in December, and we also won the best evidence-based paper, and they awarded us, we were awarded in the last meeting in May, but honestly, unfortunately, I didn't go. There was a reason. بعد أحداث غزة صراحة it was a very very challenging for me to go back to the state, and after all what happened صار فيني شعور I cannot spend $1 there. hopefully things change and get better, but this is the reason I didn't go, and I think 2 times we had a meeting and I couldn't do it. I feel we need to raise awareness more, صراحة. When we do the systematic review, we go through a process. I'm going to show you just a 2-minute clip of how we do the systematic review, how do we develop the systematic review, and from there we do the clinical guideline. There is a website called Covidence. It's a great tool for people who want to do a systematic review. It is very organized. We work with a librarian in Maryland that we give her the keywords for our search, and then she will provide us with she will search all the databases, and from there she will import it to Covidence, and hopefully it will work. Okay, so this is Covidence. We are entering the primary systematic review. Here you can see we import the reference, then we go through a process of screening, title and abstract screening, then full text review, and then extraction of the information of each paper. And the great thing about Covidence is we can upload our questionnaire, and we work in pairs. As you can see, like Dr. Marcia and Dr. Jim are together. When we do for each paper, you will go back to complete to check if somebody is missing, it will show. And here is one of the papers that I chose to show you. You will see what do you mean by doing systematic review. We go into the depth. We ask all the questions, general characteristic. Is this paper done randomized control trial? Where was it done? Any fund? Then we go into the depth of each tooth. How many teeth were included? And then the procedure itself. Is it indirect, direct, pulpotomy? What medicament? The restoration? When did they do it? All of that. And then we go into the result section. We go through the clinical, radiographic, and then overall. And then I'm going to try to make it a little bit faster. بصراحة مو قادرة. عندنا 1 minute. After doing all of that, you will check the dropout. So because this makes a difference. Because if there is too much dropout, we have higher risk of bias here. And after we completed, we did the data extraction not only for in vivo studies, but also for in vitro studies. So there is at the end section for that. And here, the quality assessment, where we categorize the paper. Is it a high risk? Is it a low risk? And depending, is it a randomized control trial? We have a different path. If it is non-randomized control trial or in vitro, we have different path. So this is just to show you how each article go through. And then we have to have two doctors making sure that their data is correct, and then they have to resolve their conflict. And from that, we developed the clinical practice guideline that was published this February. And from this, now my presentation will be all based on the clinical guideline that was published in 2024. So we ask a question. The goal here is to help the clinician. Our goal is to help you when we are in the clinic with the best evidence. So, in vital primary teeth requiring pulp therapy due to deep caries lesion, what vital pulp therapy treatment has a better success? IPT or bioceramic pulpotomy is likely to increase success and is preferred over other vital pulp therapies such as direct pulp cap and all other pulpotomy medicament. This is a strong recommendation. So whenever you have a deep caries, you have to do either IPT or bioceramic pulpotomy. Now, for IPT, does the choice of medicament make a difference? We found that the type of medicament does not affect success of treatment, and this is a strong recommendation. But pay attention here. We're saying it doesn't make a difference, but you need to know that you need a proper seal. So a good final restoration. For direct pulp cap, does the choice of medicament affect success? We found that the type of medicament used does not affect success of treatment, but the evidence here is very uncertain. We had a very low quality of evidence here. The papers that we had at the high risk of bias, so we cannot withdraw like a good recommendation for the direct bulb cap. Now for pulpotomy, does the technique and choice of medicament affect success? Yes. The use of the bioceramic pulpotomy increases success and is recommended over any pulpotomy medicament. This is a strong recommendation with high certainty. So what I mean by bioceramic, you can use the MTA, the putty, the biodentin. And here I'm just showing a case. It's one of my patients. Now I'm treating. He presented, he did a GA like 3 years ago, and they did for him ferric sulfate. As you can see here, unfortunately ما عندي البوينتر, but as you can see here, percussion involvement, internal resorption. So kids, when we are seeing the patient, we are seeing them at age of 3 and 4, and they need these teeth for till the age of 10 or 12, sometimes with the boys. So let's make sure that we're putting a good medicament that will last for a long period of time. Now, in the instance of pulp exposure, which pulp treatment is better for a caries vital primary incisors? Is it a pulpotomy or a pulpectomy? When I have an incisor that is carious, should you do a pulpectomy or a pulpotomy? The recommendation is to do a pulpotomy because it is likely to increase success compared to pulpectomy. I've seen it a lot in Sarahab social media. Everyone is like, some of the teeth are gum level and they're doing pulpectomy and doing post for that. These patients are coming back with failure. So choose wisely. If the tooth is vital, go ahead with pulpotomy. Do not do pulpectomy. If the tooth is not restorable, just extract. It's easy rather than putting the patient into 2 times treatment. Now, is pulpotomy equally successful in anterior versus posterior teeth? We found that the success rate of pulpotomy is not likely to differ for anterior versus a posterior teeth. This is a conditional recommendation. Now, which caries removal method is recommended for deep caries requiring vital pulp therapy? For primary teeth with deep caries requiring vital pulp therapy, selective caries removal and IPT, these are the ones that you should do. You shouldn't do a stepwise excavation, or you shouldn't leave caries. So the best recommended, the best evidence shows that you should do a selective and do not do a stepwise excavation. Now moving to the third section, which is non-vital pulp therapy. The non-vital pulp therapy, we have 2 modalities of treatment, either to do a pulpectomy or doing a lesion sterilization tissue repair. For the pulpectomy, it's basically a root canal where you do instrumentation, you remove the pulp tissue, you do some filing, and you do instrumentation with files, irrigation, and then you fill it with resorbable material. For the lesion sterilization, tissue repair, it's a procedure usually like you're doing a pulpotomy. You remove the coronal pulp chamber, and then you do pulp tissue, and then you place a mixture of antibiotic. This was a very hot topic in 2016. During residency, there is like a Facebook IPTO, everyone is talking that we don't need to do a pulpectomy, it's easier, just mix, put it. Saraha, you will see the result, but it's not successful as the pulpectomy. So for LSTR, there is 2 mixture, either the traditional or the alternate, and here's the definition. Traditional have minocycline, metronidazole, and ciprofloxacin. The alternate, you're just removing the minocycline, which is tetracycline, and replacing it with either clindamycin or amoxicillin. Here is the non-vital pulp therapy work group. The only difference is Dr. Karen Fargus. She's the past president of the AAPD, and she's an amazing pediatric dentist working in Iowa. In 2020, we did the systematic review, and sorry, but yes, we won the best evidence, best paper, but it was during COVID time, so it was a virtual. From that, we developed the first ever guideline for non-vital pulp therapy. There was nothing in the AAPD. So this is the first guideline for non-vital bulb therapy. And here, the idea of it, and I love it for the non-vital, we ask a specific question to guide the clinician during the visit. So we ask, the first question is, when should a clinician choose extraction over non-vital bulb therapy? Non-restorable teeth. So if the patient presents to me like this, I wouldn't attempt to restore it. This is for extraction. Child's ability to cooperate, I think this is number one for everyone. Dealing with very young kids, it can be challenging. So do not put the child under the purpose to do a pulpectomy. You shouldn't. A complex medical condition, patient who are immune compromised, patient who are in cancer, or patient who are cardiac. So you need to know, sometimes patient is perfect, behavior, everything is good, but he cannot do it due to the medical. Inability to achieve local anesthesia of the tooth, limited mouth opening or severe gag reflex, facial swelling, oral pain with an unclear diagnosis, and complication from prior. This is a case that I've seen in private practice. Patient, they did for pulpotomy, but it's not saying it's because of the clinician, it's because of the parent. They didn't return for the final restoration. So it was leakage and it failed. And a parent and patient preference, age, and cost of treatment. This is one of the main points also. Doing a pulpectomy and SSC crown in government is like 10 kd versus a 2 kd extraction. So this is one of the things that parent will tell you. Also, some parents, they have this mentality of, I have many kids. The previous one, I extracted for him. So it was done. He's out of pain. So for his other kid, I don't want to try anything new. He's coming with a mentality, I need to extract so I can go back to sleep. And there was also an incident with Dr. Aziz, Allah yarhamah. He told us this. He was in Farwania, and this is definitely one of the things that the patient is perfect, everything is perfect, but the patient, it was a kid, needed 2 pulpotomy and the crowns. The patient was cooperative. The doctor explained, but the mother said, I want extraction. But he convinced her to do the treatment. Done with the treatment, patient is F4. And the following day, she's knocking the door and she told him, I told you to do extraction. I extracted the teeth. So just less than a day, like 24 hours, she extracted the teeth. So here, يصير فينا, okay, wake up call. Sometimes what we want, we cannot do. But we do what we explain ourselves, explain our rationale. Now, next question. Does pulpectomy have a better long-term success in teeth with or without root resorption? We found that pulpectomy should be considered for non-vital primary teeth without preoperative root resorption. And here's the first plot showing, أنا شوية مع التكنولوجيا يعني. One second. Okay, so I know we are all clinicians, not researchers or statisticians, me too. But I'm just going to explain to you what is the idea about the first plot. Here we have on top the studies that have root resorption. On the bottom, they don't have root resorption, and you can see everything is moving toward the center, favoring the no root resorption as a success. Now, we looked into factors that might affect the pulpectomy. So, in primary teeth treated with pulpectomy, what factors influence success? Obturation material. Yes, the evidence suggests that zinc oxide eugenol, the combination of zinc oxide eugenol, iodoform, calcium hydroxide, and ZOE may be a better choice for pulpectomy success compared to iodoform at 18 months. So these two are the better. You should do it. The other materials we have calcium hydroxide only, or Vitabex, which is iodoform. The best ones is the ZOE, and the combination is called end-of-LAS. Number of treatment visit, we found that the overall success after 12 months was not impacted by number of visits. The method of root length determination, we suggest that clinician may choose any of the root length determination method, tactile, radiographic, or even apex locator, based on the clinical expertise and individual circumstances. Instrumentation, hand instrument versus rotary. We found that the two instrumentation, they had comparable success, while the occurrence of flush fills were more associated with the use of rotary. Also, we found that the rotary were significantly 2 minutes faster than the hand instrumentation. Here's just showing that it's favoring the rotary and it is faster. Now, removal of smear layer, does it affect the success? We didn't find, so the clinician can choose either way of managing the smear layer based on the clinical expertise and individual circumstances. Now, the choice of irrigant, also for primary teeth, it didn't have an impact. So the choice of irrigant, sodium hypochlorite, diluted or not diluted, water, saline, and chlorhexidine had no impact on pulpectomy success. The timing and type of final restoration, we found that the limited 24-month data suggests that teeth restored with stainless steel had a better success than composites. Now for the obturation technique, the quality of fill and the pulpectomy success using Lantulo spiral, hand plugger, or syringe were not statistically different, but we found that the use of Lantulo spirals were associated with increased incidence of overfill, and the overfill is associated with less success. Also, we found that the use of Lantulo spirals also associated with creation of lots of voids. Now, for the isolation, the use of rubber dam is a must. You need to have a good isolation when you're doing any pulpal therapy, and it is critical. Now, these questions were mostly for the pulpectomy. Now, moving into the LSTR questions. So we asked, in primary teeth treated with LSTR, what factors influence success? The use of traditional versus the alternative 3 mix. We found this is very strong evidence that the clinician should choose an alternate 3 mix without tetracycline over traditional 3 mix. This is the first plot showing in favoring of using the alternate 3 mix. Now, should we use a file or approach when doing an LSTR? The studies, mostly in India, they prefer to do, honestly, the extra step, 2 visits, extra work, but we didn't find a difference. So again, as the evidence shows that the clinician may choose whether or not to file approach the canal, since both methods were not significantly different. This is the first plot showing there is no statistical significance. And now, in primary teeth with no root resorption, now we want to know, is LSTR better or pulpectomy is better? So when there is no root resorption, clinician should do a pulpectomy, and because the pulpectomy success was higher than the LSTR for teeth with no preoperative resorption. But if the tooth has external or internal root resorption and you want to do the treatment, here we have to make sure that you are following the kit. So if the clinician decides not to extract the tooth with significant preoperative root resorption, LSTR should be the choice over pulpectomy. But you need to save such teeth for up to 12 months and should be monitored periodically. You shouldn't do it and then leave the child. So you have to take radiograph, do a clinical assessment. Now, the adverse event for both procedures. The first point is pulpectomy filler resorption. Resorption, as I said, we said some of the obturation material is ZOE, and ZOE doesn't resorb, resorbs slower than the primary tooth root in some cases. So when this happens, this might lead to the permanent tooth, change the path of eruption of the permanent tooth. It might deflect it. In some cases, it will create a crossbite, anterior crossbite. Second, the exfoliation after non-vital bulb treatment. We found that two different groups. Let's talk about first the LSTR. In the LSTR, we found that some studies found that there is an early exfoliation, early loss of the teeth that were treated with LSTR. On the other hand, a Gruel, which is the longest randomized control trial for LSTR, 36 months, they found that the teeth treated with LSTR, they didn't exfoliate as the other teeth. So we cannot draw a conclusion. So yes, if you are treating a patient and you're doing LSTR or even pulpectomy, you should explain to the parents. Explain to them that the exfoliation might differ than the other one, either earlier or it might be delayed, just to be on the safe side. Now, succedaneous teeth enamel defect, they always blame pulpectomy for the enamel defect, but we need to make sure we understand why did we do a pulpectomy. There is a preoperative inflammation. There is an infection going on. The tooth bud is very close to the apex of the primary teeth. So the infection might be because of that. The enamel defect might be because of the pre-existing infection. This is number one. And we found that it is related to the child. Whenever there is a treatment younger than age of 4, 4.5, these are most likely to see an enamel defect if there is an extreme or big infection going on. For the cyst formation, this was in particular for LSTR. That's why we are telling you everyone, just make sure that you are following the kid. So again, Gruel, which is the longest randomized control trial for LSTR, found that there was bone loss, intraradicular bone loss, and formation of keratocyst. Okay, this one is the decision tree that we created in the latest guideline to help the clinician. So whatever I said just now, this is the whole summary of it. And the idea is we divide it into vital and non-vital, and I'm not gonna go over it again, but I'm just gonna highlight whenever you see the green color, this is a strong evidence, this is what we want. We want for vital pulp therapy, we want you to do a pulpotomy with using bioceramic materials, MTA or biodentin. And for caries removal, we want you to do a selective caries removal, i.e. IPT, and then restore the teeth. And this is the first time we have a conditional recommendation against the use of ferric sulfate. So from now on, everyone knows that ferric sulfate shouldn't be used for doing a pulpotomy. Now for the last section. This is the vital pulp therapy in permanent teeth. And as Dr. Maryam mentioned, we have indirect, direct, partial, and full pulpotomy. She explained it very well, so I'm going to go over it really quickly. Pulp cap, partial pulpotomy, and the full pulpotomy when you remove everything. And this is case of mine, patient with deep caries. We treated with IPT and followed up. We used the bioceramic. And now, again, I love to put my photo every عاد الست ما كنت حطتها. Okay, so now this is the highlight, honestly. For the past 3 years, we have been working with an amazing Dr. Cole, the leader, to establish a joint guideline with the American Association of Endodontists. So we did that. We worked for the past 3 years. You know this group. This group, Dr. Jerry Glickman, Dr. Amber in VCU, Amber Arthur, and Dr. Mike Sabeti. She mentioned him, Mohammed Sabeti, the MTA systematic review. He has two names, Mike or Mohammed. He's an endodontist at the University of San Francisco. So for the past 3 years, we have been working to do a systematic review that include vital bulb therapy for permanent teeth, سواء mature or immature. The challenge was real. Endo people are not easy. Like I've seen them. ما شاء الله بالكويت احنا يعني we're lucky صراحة. I'm lucky to have my best friend with me in every single step, دكتورة عايشة تيفوني ودكتورة نائلة بجامعة الكويت صراحة they believe in vital bulb therapy ف they made it easy. بس لما جينا حق الأمريكان صراحة الميتينجز إذا كان 1 hour بيصير ساعتين، إذا 2 hours بيصير 6. They are very شنو أقول لكم؟ They are very proud of their position paper in 2021, but unfortunately, this is only an expert opinion. This is not based on evidence. This is just expert opinion. They wrote it. So this is the systematic review we submitted for publication last week. This is the title, and this is the abstract. I took permission from Dr. Cole to share this information with you guys. And I'm not going to go over everything. I'm just going to give you conclusion. So we're going to read one by one. For the conclusion, success rate of vital bulb therapy, the overall success, there were similar success, 91 to 97% for all vital bulb therapy, indirect, direct, partial, and full pulpotomy after 24 months. For the long-term success, at 36 months, indirect bulb treatment success was 94, and it was higher than the direct bulb cap. However, the difference disappeared when you use calcium silicate-based materials. The material of choice, the success of IPT did not differ significantly among GIC, calcium hydroxide, or calcium silicate cement after 24 months. For partial pulpotomy and direct bulb cap, they had the same success after 24 months only when calcium silicate-based material were used. Now, for pulp diagnosis and treatment, I'm sorry, I forgot to mention something. For vital bulb therapy, we're not only treating normal reversible, we're also the irreversible pulpitis. I forgot to mention because you will see it here. So the management of for vital bulb therapy, it falls under the umbrella in permanent teeth, also including irreversible pulpitis. So for pulp diagnosis and treatment, teeth diagnosed with normal reversible pulpitis and treated using calcium silicate cement for partial or full pulpotomy showed no difference in success after 36 months. So when they are normal or reversible. Now, the 24-month success for teeth treated with calcium silicate cement for partial or full pulpotomy diagnosed with normal or reversible pulpitis was much higher than 97% than teeth diagnosed with irreversible pulpitis, 90%, but the difference was not statistically significant. Now, teeth diagnosed with irreversible pulpitis and treated using calcium silicate cement for partial pulpotomy versus full pulpotomy showed a full pulpotomy would be preferred due to its higher success. So whenever you have a reversible pulpitis, you should do a full pulpotomy versus partial pulpotomy. For teeth diagnosed with irreversible pulpitis, complete caries removal should be performed in the likely event of pulp exposure. The success of partial or full pulpotomy is higher when the hemorrhage can be controlled within 6 minutes. Now, finally, already Dr. Maryam explained that when we had additional consideration for aesthetic in teeth where aesthetic are a concern, it is recommended to use calcium silicate cement without bismuth oxide for vital pulp therapy to prevent discoloration. For caries management, and this was the hot topic, AAE, they don't believe in indirect pulp therapy. Really, the struggle is real. So they don't believe. all other يعني العالم كله عندهم there is something IPT except the American Association. So that's why we had a struggle, but alhamdulillah we are on board now. So for deep caries in teeth with normal pulp or reversible pulpitis, selective caries removal is recommended over stepwise to minimize the chance of pulp exposure and has the advantage of being completed in a single visit. For trauma management, a tooth with a traumatic pulp exposure is recommended to undergo a partial pulpotomy using calcium silicate cement. Sodium hypochlorite irrigation and hemorrhage control are recommended for vital pulp therapy where the pulp is exposed. For root development, I'm sorry, it's not showing. For root development, it has been shown that teeth with immature root have a higher success than the mature ones, but these findings were not statistically significant. Yes, it's higher, but both are successful. And by this, I conclude my presentation.
Thank you, Dr. Shahab. It was an interesting topic, and thank you for broadening our understanding and helping us to master our clinical practice. I'm sorry for shorting in time, so I don't think so that we're gonna have the question. She's more than happy to receive the question if you just ask her in the break. And now we are more than happy to handle you a little gift from the KDA and express our feeling, how proud of you we are today. And thank you.
I don't see a clock.
See your clicker?
Yeah, just see if it works.
Not working?
Yeah.
I think this one is in. Oh, okay, it's working, yeah? There is one here.
ستة.
They're controlling.
That's working too.
سكر المايك تبعها، سكر اياه. Check, test, mic. Hello. Full screen. Put on the full screen.
Good morning, everyone. I hope you're all enjoying the conference so far. I'm Dr. Shayma Nazar, the chairperson for this session with Dr. Sarah Juwayhil. So I'm honored to present and introduce the speaker for this session, Professor Shivon Bari. And we have a great opportunity to hear from a distinguished expert in the pediatric dentistry. Professor Shivon Bari attended the Leeds Dental Institute for her pediatric specialty training. She completed a clinical doctorate in pediatric dentistry through the University of Leeds. After an additional 2 years consultant training, she was appointed as a consultant in pediatric dentistry at the University of Manchester in 2014 and promoted to professor in 2020. She is the Director of Graduate Education and also the Academic Lead for Undergraduate Pediatric Dentistry for the Division of Dentistry and Clinical Lead for Pediatric Department. Today, Prof. Bari will be speaking on caries management in the pediatric dentistry and pediatric dental trauma. Please join me to welcome Prof. Bari.
Thank you so much, Shayma. It's lovely to be back in Kuwait. This is my second visit. And it's especially lovely to see all my lovely Manchester graduates here, undergraduate and postgraduate, including Shayma, who of course was one of our first. It's lovely to see you back. So, yes, my background, of course, is University of Manchester. I've just completed my 10-year anniversary this year. It's a very beautiful university in the north of England, and at the moment, it's very cold and autumnal and lovely. So you can see here, it's a beautiful, beautiful old building. So I'm the Director of Graduate Education, so I look after all of our postgraduate programs, both taught and research, as well as our undergraduate program. And despite my affiliation with the north of England, of course, my background is actually Irish, and my undergraduate degree was in another very beautiful university, University College Cork. And then I completed all of my training in Leeds, Leeds Dental Institute, 10 years ago. Very, very good training program. It was known as one of the best in the world at the time, until we opened Manchester. And I'm often asked, why pediatric dentistry? And certainly, I think it's a fantastic specialty. I've devoted the last 24 years of my life to it. Wouldn't have it any other way. But when did I first develop my interest? And actually, it was at a very young age. So when I was 3, and I know people like to show their photos, so here I am, I developed an interest in pediatric dentistry when my younger sister Kate was born. And I didn't like her at all. But here I am, and I'm just about to undertake my first pediatric dental exam. And I got into a little bit of trouble at this stage because then I put my whole fist into her mouth. But I was able to confirm my hypothesis that the neonate has no teeth. So that was my first exam. You'll be delighted to hear that I've significantly enhanced my examination technique of the neonate since then. But I really took 2 learning points from this photo. First is, I think long hair is better. And second, I wouldn't be caught dead in that dress now. So fashion sense has improved a little bit since then. Okay, so looking at today's lecture, we're going to look at high caries risk children. And of course, where we live in the UK, we certainly have a huge, huge caries risk for our paediatric population. So do we have a problem? Do we need to do anything about it? How can we do something about it? And what advanced techniques might we have? So first of all, is there a problem? And I suppose that's a good question, because if there isn't, do you need to do anything? And we certainly know when we speak to our parents, we hear stories like this all the time. So patient, he's been awake for the last 3 nights, we went to A&E, we got some antibiotics, he's still in pain. That's not uncommon in our clinic. This is her 3rd antibiotic in 2 months, and she's still in pain, because of course antibiotics aren't dealing with the problem. And again, he can't eat or drink, he's been off school for a week. So certainly we know this is a huge problem. And the papers have picked up on this. So in the UK, 2/3 of extractions are due to tooth decay, and it has cost the NHS 40 million a year to deal with dental caries. And because it's an almost entirely preventable disease, this is to our shame as paediatric dentists. And if you look at this figure here, in 22-23, we have undertaken over 47,000 extractions, and that is under general anaesthetic. So again, it's something that we need to intervene and manage. And we know from our national surveys that we have a huge problem. So this is our survey of 5-year-olds in the UK, and it's looking at the percentage of 5-year-olds who have decay, so any decay in their mouth. And if you look at the x-axis, you can see the percentage of children who have a caries experience. And on the y, we have all the different areas in the UK. So here in orange, we have England in general. So we're looking at about 27% of 5-year-olds have caries. So over 1 in 4, which is a very, very high rate. If you look at us here in the Northwest, we're taking first prize, and actually we're close to 40%. So it's a huge, huge problem for us. And again, if you're reading the papers in Manchester, so this is the Manchester Evening News, almost half of 5-year-olds have teeth so bad they could need fillings. And when we say fillings, of course, we know that in the majority of cases, they're requiring extractions. We don't have enough dentists to go around, we don't have enough specialists, we certainly don't have enough consultants. And within Greater Manchester, this is a place called Oldham, and actually this is the highest decay rate in the country. And the reason for this, it's multiple, but it's to do with social deprivation, it's to do with not having fluoridated water, it's to do with not having access to dentists. And this is the reason that we are seeing children with extensive caries every single day in our clinic. So yes, there certainly is a huge problem in the UK, but do we need to do anything about it? So we know we have a huge amount of caries, and as dentists, do we need to intervene? So it depends on who you ask for that opinion. How often have you had parents come and say, well, they're only baby teeth. There's no need to do anything with them. They're going to just fall out and not cause a problem. And that's why as pediatric dentists, we don't like the term deciduous teeth. You'll never hear us say that because it gives the impression that it's like a leaf on a tree and just floats off, not causing any problem. And I tend to say to parents, yes, they're baby teeth, but they can certainly cause problems before they exfoliate. He won't allow me to brush his teeth. This is another statement I hear quite a bit from parents, and you know, what can I do? And the answer is, okay, that's fine, but he's 3. I would argue it's not his choice. It's not his choice whether he has a bath. It's not his choice whether he brushes his teeth. It's an essential. And when I worked in Leeds, this was a classic. I'll have nout done with those baby teeth. Nout to do with them. Let them just exfoliate. And again, all well and good if they're not causing any pain. So why treat them? And as pediatric dentists, of course, we're saying, yes, we need to treat them. And by treat, I mean restore or extract. So both are valid methods of treating. And we know, of course, from the literature that there is a significant increase in oral health-related quality of life when decayed primary teeth are treated, be it by restoration or be it by extraction. And we can measure this in terms of socialization, child eating and drinking, sleeping at night, smiling, attending school. We also know that children who have extensive caries are likely to be lower than their growth centile. So growth is affected. And that's to do with children not sleeping at night when all their growth hormones are secreted because of toothache. We also know when we treat these caries that children will exhibit what we call catch-up growth. So they will actually catch up to their growth centile. And that's very, very important when you're talking to parents and explaining to them the reason why we need to do something about this. And of course, we know if we have caries in the primary dentition, we're more likely to have caries in the permanent dentition, and that will lead to orthodontic issues. And sometimes parents will say to us, well, I don't want to take my child out of school. And that sometimes can be an issue in the UK. We know from the literature that children who leave school regularly for dental checkups do not suffer in their attainment. There's no difference. However, it's not the same for children who have to leave school due to toothache, due to facial swelling, those who are hospitalized, etc. So when you say to parents, actually coming regularly for a dental checkup does not influence your child's success at school. So we know we have a problem, we need to do something, and what are the instruments we have to help manage this? Well, there is one issue, and I don't know if you have this here in Kuwait, but certainly in the UK, my dentist won't see her until she's 5. And we have a big push through British Society of Paediatric Dentistry for dental check by 1. So that dentists will see a child before their first birthday with the idea that we're seeing them quite soon after their primary teeth start to erupt. And not that we think we're going to intervene hugely, but that's your chance to instigate your prevention, to acclimatize the patient, and of course to give the parents the advice that they may not know that they needed about feeding, about brushing, about toothpaste, etc. So how do we manage the problem? How often have you had a parent come in and say, oh, he won't let you look? You know, I brought him in today, possibly he's in pain, but he won't let you look in. Not terribly helpful, and the answer is, oh, I will. Don't you worry about that. We will certainly have a look. He kicked the last dentist in the leg, that's very helpful. I've had that in referral letters sometimes. Please see this patient, he kicked me. I said, well, you know, children are equal opportunity kickers, aren't they? So if he kicks you, he'll probably try to kick me, and I don't want him to do that. So we know that up to the age of 5, we're always able to get a look at patients. And that's by lap to lap or knee to knee exam. I'm sure you're quite familiar with this. This is Laura, who's one of our clinical lecturers, demonstrating. And the idea is the patient is sitting facing the parent with their legs around the parent's waist. And then you're in front, ideally on a chair with no wheels, or you will be head-butted backwards. The parent can support little hands, and the child can maintain eye contact with their parent. As soon as they lie back, if they're upset, I always warn parents, well, they'll probably cry, but if they do, that's good, I get a look in. Okay, so it's not hurting them in any way, but it's important to have a look. And as soon as they open, I'll put a little prop in and get a look at everything. Now, if you enjoy having your 10 fingers and you'd like to hold on to them for the rest of your career, I would suggest you use a little Betty prop, which is a little silicone bite prop that stops the patient from biting into you, and a little plastic mirror as well. So, how often have you heard this? So I've had dentists write back to me and say, I don't believe in fluoride varnish. And I suppose it's not about belief. And I've written back and said, well, this is not the tooth fairy. It's not about believing in it, because it exists. And we know it works. So actually, it's one of the most important things you can do for your child patients. And it's a very simple and effective way of managing caries. And prevention, of course, is better than cure. It would be much better as pediatric dentists if we can prevent all this caries. And then we don't need to worry about whether pulpotomy is better than a pulpectomy. We just won't need them. It'd be fantastic. And I'm sure you're familiar with Flanders, and he's very anxious, like a lot of our parents are, about a lot of things. And just see what he says.
They're controlling our minds with flu shots. I knew it. Well, kids, now aren't you glad we don't believe in inoculations?
Yay!
So yeah, you don't believe everything you see. We know fluoride varnish is very effective and it's very safe. And it's about having that conversation with our parents. Very simple to apply. Some of our dental nurses are trained in this and they're able to place fluoride varnish for us. It's just drying the teeth and painting it on regularly. And we know that it works. So here we have a systematic review, and this is from Cochrane, our Manchester group. And we know that we will have a 37% prevented fraction in the primary dentition, and even higher, 43% in the permanent, and that is by placing fluoride varnish regularly. And then it's all about behaviour management, because children often don't like to have their fluoride varnish placed, so you can offer them their choice of taste, really. What would you like? Sometimes banana cream is quite nice, but not all children like banana. What flavour would you like? I'd like kiwi, no problem. You can have whatever flavour you like. And we only have one, of course, but if you offer a choice and they choose, they'll be quite happy with that. And on our undergraduate clinic, our patients often leave looking a little bit like this with fluoride varnish. It's very sticky, but of course you want to be quite pragmatic about how you place it. Fissure sealants as well as a preventive mechanism, absolutely important. We know that depending on the caries risk, we'll get a 50% caries reduction when we seal our permanent molars. And that is to say, if we maintain them. Okay, so as long as we see our patients regularly and we maintain the sealants, they work very, very well. And when we look at the research comparing fissure sealants and fluoride varnish, there's no real difference in the success rate. However, traditionally, fissure sealants will prevent caries occlusally, whereas fluoride varnish will prevent proximal caries. So a combination of both is essential. And I would urge a little bit of caution with sealant, and of course we have a big undergraduate population in Manchester, and placing sealants is something that they have to do to graduate, and we encourage them to do that. Just be aware of the etchant, and every time our students come on clinic I say to them, be so careful, it only goes on the tooth, you know, make sure you put your cotton wool roll in, it will burn skin. Now last year, this happened. This was one of our undergraduate students who was sealing a lower 6, and we don't know how it happened because she had a very experienced dental nurse and a DCT with her, but I think she must have got some etchant on the fingers of her glove and somehow massaged it in, and it led to quite a severe burn. So it's just being very, very careful, particularly when students are doing that. It's healing up quite nicely now because children do heal very quickly, but the risk is it could scar. This is another issue we have with shared care. So we will see our patients for courses of treatment and then they're followed up regularly by their general dentist. And we had a patient referred in and parents said to me, yes, he's seeing his own dentist regularly, he saw him last week and he said his teeth are all okay. And this is what we saw when we looked in, and it's not my definition of okay. Okay, so I would call this severe early childhood caries. And it's one of the issues because it depends on the treatment philosophy of the general dentist. And if they're of the opinion that we can leave primary caries to exfoliate, we're going to see this supervised neglect on a regular basis. And it's quite difficult for us to then explain to parents, your dentist said there's one tooth or that your teeth are okay. Actually, there are 20 caries teeth and we're going to have to extract some. And they're saying, well, why didn't my dentist tell me that? So what can we do? Silver diamine fluoride has been an amazing improvement to our practice in the UK. Now, I know it's been around for years. We didn't routinely start to use it until just before COVID. And this is a headline from one of the papers. So, a new liquid treatment stops tooth decay painlessly. And that sounds really good to the public, of course. It sounds like you don't need to do anything else. And recently approved in Canada, it can repair cavities without the use of a dentist drill. So, to some extent, that's true. In the UK, Rivastar is the product we use. It's the only one that we have licensed. In Manchester, we actually bought this back in 2017. So one of our lecturers went to America to do an attachment. She saw it, she said, why don't we use it? We thought, why not? And we bought it. So we were actually the first unit in the UK to use SDF. And then it came into widespread use over COVID, of course, because it was a non-AGV. So Rivastar is licensed. It's a colourless alkaline liquid. So alkaline means it will burn, much like etchant, and it contains silver and fluoride. So you have a complex of silver and fluoride in ammonia. It's 44,800 parts per million fluoride, so much, much higher than fluoride varnish, and you have about 250,000 parts per million silver. And overall, that gives us 38% SDF. So this is the SDF in the grey. And then here you have a green, which is potassium iodide, and that really is just to help reduce the staining, because silver diamine fluoride will stain carious teeth very dark. It won't affect non-carious tooth. So this was developed actually a very long time ago in the 1960s by a researcher in Japan, and it's been in use there for a long, long time. And it's been used in many other countries, and it's not yet available in every country. But as I said, in the UK, we've had it licensed since just before COVID. It's been spoken of as a silver bullet, so we always look for something, a paradigm shift in dentistry, and the idea of a silver bullet is something that will, dramatically improve our outcomes. And of course, it is silver. And Rosenblatt has stated it's safe, and actually, despite being such a high percentage of fluoride, SDF is extremely safe, and we know that. It's effective, it means it works, and yes, it works really well. It's efficient, it works well, it works quickly, it is not expensive, and it's equitable, so it's something that can be used quite easily for all children. Okay? It's accessible. And the good thing is the World Health Organization has endorsed it. So back in 2021, WHO has included SDF in a list of essential medicines for children that they feel all children should have access to. And that is absolutely amazing for us. So how does it work? So you've got the combination of silver and fluoride, both of which work separately. Silver has been used for years in medicine. You probably know it's been used on wounds and things like that to help healing. So it's antibacterial, and it's difficult to form resistance. So silver will kill bacteria in many different ways. So it will continue to work, which is fantastic. It will interfere with bacterial metabolism, with enzymatic function. It inhibits proteolytic activity, so it prevents the tooth being broken down. Inhibits biofilm, and of course, will reduce bacterial adhesion, so they can't stick. And we know what fluoride does. We know it enhances remineralization, it reduces demineralization, it prevents degradation of collagen. So they both work really well separately, but then you also have the synergistic effect. So together, they work even better, like pediatric dentistry and orthodontics. But one of the issues we have in the UK is that silver diamine fluoride is off-label. And it's a bit of a barrier. So what it means is it's licensed, but only for sensitivity. Because it works really well for sensitivity, but it's not licensed for caries prevention, it's not licensed for caries arrest. And we know it works really well for that. And the reason is probably financial, that was the easiest way for the makers to get it accepted into the UK. So we use it off-label. So off-label means it's not licensed, but there is sufficient evidence to ensure safety and efficacy. And we do have that. We know it's safe, we know it works. And of course, it's supported by expert consensus. So So when that happens, as a doctor, as a dentist, you're entitled to prescribe off-label or off-license. It's a bit of an issue in some of our community settings, and it's certainly an issue for general dentists who feel a little bit anxious about prescribing off-label. In hospitals, we're quite happy to do that, and usually we just have it run past our legal team who are happy for us to use it. And success rate, it depends what paper you look at, but it's highly successful, so over 80% in the primary dentition. And we know from systematic reviews, when we apply it to caries primary teeth, it will dramatically reduce caries in those teeth. And even compared to fluoride varnish or a placebo, it will reduce caries in the entire dentition. So it's like fluoride varnish, it's not just the teeth you place it on, which is very, very important. And we also know when you place it compared to fluoride varnish, it's comparable in the primary dentition. Okay, once you place it semi-annually, so we place it probably every 6 months. So we know it will work really well for desensitization for teeth with MIH. And it's an issue with MIH, the teeth are very, very sensitive. So we can use it for desensitization, and the only slight issue, of course, is it will discolor them. And if you're then using a smart technique, like silver modified, you will probably have a little bit of discoloration around the margin, but I would say that's not the worst thing, once it reduces sensitivity. So what are the applications? Well, early childhood caries. Once you have an open cavity that's asymptomatic, you can place it and it should arrest the caries quite quickly. It will work for root caries, and of course it will prevent secondary caries. So if you're just restoring these teeth in a high caries risk patient, unless you're using a crown, the teeth can decay again. So using SDF will prevent that. It will remineralize hypermineralized teeth, and it will, in some cases, prevent erosion because, of course, it's hardening the teeth. So there is some evidence that you'll get a reduction in erosion with it. We need to be careful about our choice of tooth. Okay? It's not suitable for every tooth. It needs to be a cleansable lesion that the patient can get in and brush. It has to be asymptomatic. So if you're placing SDF on a tooth that's already symptomatic, it's not going to work. Okay? So you need to get in there early. So you can use it for non-restorable lesions, and sometimes we will use it to try to prevent the patient going on to have a general anesthetic rather than extracting the tooth. And of course, MIH. From a patient point of view, it's very, very useful for children who are pre-cooperative. Now, pre-cooperative is before the age of 3, and that is the child who just cannot manage despite, wanting to. Children over the age of 3 who won't manage are uncooperative. So 2 different things. But for pre-cooperative children, you can see here, this is a knee-to-knee or a lap-to-lap exam. This is the parent's fingers, not ours, by the way. And you can just brush it on really quickly, really easily. And this is a patient who her parents desperately wanted to avoid a GA. So high caries risk, limited options for other treatment. So this here is a patient who wouldn't manage restorations while she's on the chair, for sure. You do need a patient who's willing to brush. Okay, so you need them to keep the tooth very clean afterwards. It can be part of your acclimatization, and the most important thing for us is this buying time. So children who are on a list for GA, we can put this on and prevent the caries progressing and hopefully prevent pain. Now, it doesn't mean that we would then save the teeth. And we're very clear with parents, if they're having a GA for extractions and we place SDF, we then extract them. Okay? Because we don't want to take the risk that they will progress. But certainly, when we have waiting lists of up to a year, it's very, very useful. Contraindications would be deep caries, pulpal involvement, any symptoms, and oral ulceration or mucositis. So patients who have recurrent stomatitis, any sort of breakdown of their mucosa is going to just inflame that. Of course, periapical pathology, you have missed the boat. Too late. Anybody who's allergic to silver, pregnancy and breastfeeding, of course, and because of the potassium iodide, anybody with any thyroid issues. But otherwise, it's pretty useful for everybody else. I said it's very safe. We know this from the literature. We've had no significant complications reported, no reports of severe reactions. You can get a transient gingival inflammation sometimes, but it does resolve very quickly. And the risk of toxicity is really low. Even in very young children, if you have treated 20 teeth, the toxicity is extremely low. So that's very important to know. It's generally biocompatible. So you can get a little bit of staining. You can see here there's some dark staining around the gingival margin. And as I said earlier, because it's alkaline, it will burn, and you can get a soft tissue burn. And here, again, these are two specimens from our undergraduate clinic, where we've had a little soft tissue burn and a little discoloration. And it will also discolor your instruments, and it will discolor clothes. And it's very difficult to get that out, by the way. From a gingival point of view, the discoloration will only last maybe 2-3 weeks, and then it will disappear. This is another example of SDF, where one of our students has just put a little discoloration on the lower lip. And it doesn't look nice, parents don't like it, it's unaesthetic, but it will disappear completely. So if it happens, it's not the end of the world. So the advantages of SDF, it's very simple, it's very quick to apply, and I'll show you how in a moment. No local is a big plus, particularly in our younger population. No drilling, which is something they don't like. Very cost effective. It's a little bit more expensive if you buy the capsules, but you can buy 2 bottles instead, which is a lot cheaper. You're retaining primary teeth, so you've got a natural space maintainer in that case, and you may avoid a GA. So some of our younger children, if we see them every 6 months and we continue to apply, those teeth may remain asymptomatic and exfoliate. Best case scenario. Disadvantages, like everything, it doesn't always work. And I always say to parents, there are no guarantees in dentistry. I never say never, I never say always. It's difficult to monitor success. So how can you tell if a tooth has arrested? And yes, we look at the color and we expect to see it becoming darker, but really you're monitoring symptoms and you're monitoring the tooth clinically and radiographically. Aesthetics is often said to be the big disadvantage. Certainly in the UK, I found it's not too much of an issue. It does discolor teeth very, very dark. I would say to parents, well, they're already brown. It's already not a good aesthetic look, and actually having them a little bit darker isn't too much of a difference. But when they hear that they're going to avoid a GA or avoid treatment, then usually they're quite happy with that. And of course, remember, as the child gets a little bit older, you can then restore them. And you can improve aesthetics quite easily. With the original Riva Star, you can have a metallic taste. Because it's ammonia, it doesn't smell very good, it doesn't taste very good. So that's one of the downsides. And chemical burns, if you're not careful. It's recommended by all of these people, which is fantastic. And from the British Society of Paediatric Dentistry, if you're interested, there are lots of resources online. So they have this consent form, and this is what we use in our clinic. And you just print it off and use it. It gives the patients risks and benefits, and just informing them about the fact that the teeth will become darker in colour. And with that, you have an information leaflet telling them about all the alternatives. And there's some lovely resources on the BSPD website for children if they want to log on and hear about SDF in their own childrenese language. So how do you place it? Well, it's very, very simple. Step 1, remove necrotic infected dentine. You don't have to do that. Okay? If you want to, that's fine, but actually it will work really well even if you don't. Apply some sort of barrier. So petroleum jelly to lips and gums, just to stop the staining. Just make sure your teeth are clean and dry, and isolate them. So here we have a nice open cavity on an E, which is asymptomatic, so that's ideal for an SDF. You can see here we've isolated with cotton wool. And then you just take the silver brush and pierce the silver capsule, and you will get a clear liquid. and you paint that onto the decayed tooth. Leave it for about 3 minutes if you can to dry. And if you want to, you can then take the green, which is potassium iodide, if you're worried about staining, and you paint that on top. Honest truth, we rarely do that because it doesn't work hugely well and it takes more time. And if you have a wriggly toddler in your lap you're trying to brush it onto, it's not so easy. But you can do. And it will turn white, so you know it's worked at that point. And then you just leave it. And this is me with a wriggly toddler placing it on anterior teeth. She's not terribly happy about that. And you can see it's gone white. So that took me about 20 seconds, and now just leave it alone. And when I saw her back, it had turned nice and dark. And actually, she was just fine. We're following her up, and she hasn't needed a GA. She's asymptomatic. Her parents are very, very happy. And as she gets a little bit older, of course, we can restore these teeth with composite. So follow-up, 3 to 6 months, depending on caries risk. Usually in this cohort, it's high, as we can tell. We reapply it every 6 to 12 months, and we're looking at the colour of the lesion, how hard it is. And of course, photographs are very useful. We always take before and after for comparison purposes. And with MIH, you're assessing symptoms, and it depends on what your plan is. Are you planning to wait for the ideal time to lose the teeth or not? This is a little video. It's actually available on the BSPD website. I'll just let you have a look. It's very useful because it shows you in real time, step by step, how you apply the SDF. And this is by a lady called Laura Timms, who's one of the trainees in Sheffield.
Okay, so first things first, after you've got informed consent, what you want to use with SDF is some Vaseline. Now that's because it stains the soft tissues. And although it's a temporary stain, it can last from 1 to 3 weeks even. So you just really want to avoid that wherever possible. And it looks almost like an ink stain on the skin, so you'd want to get that on the lips. And even on the skin around it, depending on how wriggly the kid is. And it also stains the gingiva if it comes into contact with them. So you also want to use that Vaseline as a soft tissue barrier on the gingiva. Now the RevaStar kit does actually come with a gingival barrier, which is like a blue paste that you syringe out onto the soft tissue next to the gingiva, and then you light cure that. But that requires a bit more cooperation, so if you've got a little kid, this is sufficient if you can't manage with something else. And once you've got all your Vaseline on there, you just want to add a cotton wool roll as well before you start to apply it. The next step is you want the teeth to be as clean and dry as possible. You don't need to remove caries, but if you're removing any debris, like bits of bits of food, or some really soft caries, you might want to do that with an excavator. And then if you're able, just dry them with a 3-in-1. And if you're not able, just a bit of cotton wool roll. So they're the areas that I want to do. And then the next step is to pierce the SDF liquid. So it's stored in the fridge and it comes in this little single capsule, and it's 1 capsule per patient. So you just pierce that with a microbrush, and you can see there it's just like a liquid. It's not a paste or a varnish. A bit more the viscosity of something like Bond, but less sticky. And then just really carefully, because you don't want to get it onto the soft tissues, you're just going to paint it onto those teeth. And just into those cavities there. And you want to do this and let it soak in for up to 3 minutes, but at least a minute. And if we just paint it on there.
It's as simple as that. And there's a newer SDF now. It's called Aqua, RevaStar Aqua, and it has some advantages over traditional SDF in that you don't need to keep it in the fridge, and the base is water, not ammonia. So it's much less likely to burn, and it's not going to taste or smell bad. But actually, it works just as well. And it has a shelf life of 2 years. So we've bought this in Manchester, and now we're using it, and it's working just as well, and it's a lot safer. So I would recommend that if you're going to invest. And this most recent systematic review, a meta-analysis, tells us SDF is more effective in denting caries, in fact almost double the effectiveness to fluoride varnish. And we talk about the SMART technique, silver modified atraumatic restorative technique. Again, this is quite useful. You can use SDF before you place a pre-4 metal crown or before you place a glass ionomer, and it won't affect bonding. Okay, so you can bond your glass ionomer, you can bond your composite, absolutely fine. And it will improve your outcomes. Okay, so we know success rate is much higher than atraumatic restorative technique alone. And it's the same for crowns. So a smart Hall crown is just adding silver diamine fluoride to improve your outcome. And of course, you're getting a very good coronal seal. And speaking of pre-4 metal crowns, Hall technique is our gold standard in the UK. Okay, we did, when I was a trainee, I trained in Leeds, so we were quite American-based, and we did lots of pulpotomies and pulpectomies, and my previous training in Dublin was very similar, but we move with the times, and we all change our practice as evidence increases. So now we're using the biological technique, and for our children, we're telling them you can have a princess crown or you can have a superhero crown, and they buy into it really well. I'm sure you're all well familiar with the Hall technique. We know from Norna Hall, who was the first lady who invented it, that it's a biological technique. We're not removing caries, we're just pushing a crown over the top. And when we first started to do that, we were horrified. Oh my gosh, how could anybody do that? We're pediatric dentists. But it works. Okay? And we know for years and years it works really well. It works 98% of the time if you choose your tooth correctly. So Norna Hall was the dentist who first did this in Scotland, where she had a population of children with a very high caries rate. She placed crowns over carious teeth, no local, no rubber dam. It sealed the caries in, the caries arrested, and it worked really well. Very simple to do, because you're not placing local, you're not placing a rubber dam, you're just creating a little bit of space with some orthodontic separators. So for example, the lower E's. Okay, so a little bit of floss on both sides. You can leave them for an hour or so, but with the way our clinics are set up, we tend to leave them for about a week, and it will create space mesially and distally as needed. Okay, and we know our crowns come size 2 to 7. Because we're not placing a rubber dam and the crowns are very slippery, we have the child semi-upright with a throat plaque. And you can use a little bit of tape to make a handle. And then it's like Goldilocks and the Three Bears. It's like, is it too big? Is it too small? Is it just right? And it's a little bit of experience and trial and error. But you want to choose a size that won't seat fully, because if you seat it fully, it's very difficult to get it back off. And once you know it's going to seat, you place your luting cement and you just push it on. You very rarely need to crimp. Okay? You can do if you need to, but it's quite unusual. And you don't need very much glass ionomer. It doesn't taste good. So the books will all show you, you fill the crown. You don't need to do that. So about half the crown, push it on. And at this point, that's when you tend to lose the patient when they taste it. Okay, so be conservative. This is a DPT in a bite wing setting, and it's just showing proximal caries, upper D's and E's. You can see here, you probably wouldn't have seen them clinically, and they're perfect for using the whole technique. And I think they look really nice. Okay. Maybe I'm a little bit biased. And if you're doing two side by side, you need to do them 2 weeks apart. So if you're treatment planning for upper D's and E's, you would need to separate your E's first, both sides, get the patient back, crown the E's, and then place your separators for the D's, send them off for another week, and then you place both together. If you try to separate D and E at the same time, you're going to run out of space to put them on. So using whole crown, of course, it's early caries. We're not looking at pulpally involved teeth. At that point, yes, you are doing a pulp therapy if you want to maintain them. No pulpal involvement, and ideally, you have some bite wings to confirm that. And when not to do it? Well, when the tooth is beyond it. Okay, I think we can all agree these teeth are beyond a whole crown. If you can't restore it, of course, you can't crown it, and those patients who are immunocompromised will also not be appropriate. So the heart patients will be avoided. Everybody likes them. So if you ask children, what do you prefer versus conventional, the whole, parents as well, and dentists, when they get used to it, also prefer the whole technique. And we just need to warn parents that the teeth are going to feel high, and you will always get gingival blanching. That's part of it. Tooth will fall out with the crown and will not be a problem in airports. And that's often a question we get asked. Will it go off as I go through? It won't. It's absolutely fine. What can go wrong? Well, if it can, it will, unfortunately. We need to be careful that the teeth aren't, or the crowns aren't swallowed or inhaled. And we've had that a few times. In our peds clinic, when our undergrads have tried them on, they're a little bit big, and then they leave them there. And when they turn around, they disappear. And the child was seen to take a big swallow, and the crown is gone. So we need to be careful of that, and sometimes they go off to have a chest x-ray to make sure their crown isn't inhaled. You need to be careful of allergies, because if patients are allergic to silver or nickel, they get this horrible kind of rash. And when you're placing your separator, be very careful with the floss. So again, on one of our student clinics, we had this very nasty abrasion when somebody was concentrating on where to put the separator and didn't look at the floss. So, poor seating is not usually too much of an issue, because as long as it covers the tooth, it tends to work. Even if it looks like this on radiograph, I wouldn't go back in and replace that. I think that's absolutely fine. And we know we can deflect press permanent molars if we're not careful. Just to say that in Manchester, we tend to use inhalational sedation quite a bit, and it's very useful for placing whole crowns, or even SDF if needs be. For those, parents who say, oh, he won't have anything, he won't have treatment, he won't sit on the chair, she needs gas and air. And this is not very useful, but parents quite often say that too. I hate the dentist, so she does too, even though she's 2, and she doesn't know who you are. So nitrous oxide, very useful, and one of our postgraduate students actually did her dissertation on this and found that in Manchester, it works 81% of the time. So it's quite a good success rate. And we can use it in young children. Last option, and I've put this in because it's another silver option, it's my forceps. Okay? And, in some cases, it's the first option. And as the last speaker said, if the tooth is shut, extract it. It's going to go. And we wouldn't try to place post and cores and build up teeth, particularly for our population who often need a general anesthetic. Okay? So extracting a tooth will guarantee you symptomatic relief. Again, in the UK, we know this. This is one of our kind of tabloid papers telling us children as young as 3 are having mouthful of rotting teeth removed. And not terribly helpful, but unfortunately, it's true. Okay, we have 2 full-day extraction-only GA lists a week with 20 each on it, and that's apart from our complex care list. So we are extracting thousands of teeth every year. And it's patients such as this, very young patients, they're in pain, they won't manage on the chair, and quite often they have teeth which are beyond restoration. It's a bit like that. So this is his DPT on a bite wing setting. And particularly under GA, we wouldn't try to restore anything like that. So here's the silver treatment. And that's our outcome. Yeah, and again, this is why we need prevention. We need to get in there before this happens. It's not a nice outcome for our patients. So that was a very quick overview of caries prevention. Yes. Yeah, absolutely. So you can place fluoride varnish on the SDF, which will help mask the taste. A very useful thing to do. Or you can place some toothpaste. Some people will place toothpaste on the teeth or a little bit of toothpaste on the tongue. Once you placed it, will mask the taste. Yeah, absolutely. Oh. Usually I don't place it the same visit, but I'll place it the next visit. It depends on the cooperation, really. But there's no reason you wouldn't place it quite soon. A lot of our patients are having the SDF initially because they won't tolerate the restoration. And then as soon as they get a little bit older, we will restore, ideally with composite. Yeah. Somebody's got his hand up back here. Okay. Yeah. Yeah, you can place it right on top. And while it's great to wait 2 to 3 minutes, in practical terms, you often don't get that from children. Quite often it's lie back, quickly floor, SDF and up. So yeah, you can. No, and I know some people do talk about that, and they say it improves effectiveness, don't they? But to be honest, it's another time constraint, isn't it? So no, we don't routinely cure it. Yes, yeah, there is. It's not as strong as primary teeth, but it certainly does work in permanent teeth and will reduce caries and it will arrest it. Yeah.
Thank you, Prof. Barry. I think we're going to continue with our second lecture. And later on we can have all the questions for the Prof.
Yeah, what time am I finishing? 30 minutes. Okay, so we'll get started in our next lecture, which is pediatric dental trauma tips and tricks. So really the aim of this lecture is to give an overview of traumatic dental injuries that can occur in the child patient. It's to discuss different management options and give some tips and tricks on how to manage it, because it can be a very difficult thing to do. Looking at epidemiology, we know in the primary dentition we tend to have periodontal ligament injuries, more commonly than not, and in the permanent it's hard tissue injuries. And of course, in often, many cases, we have a combination of both, so PDL and hard tissue. And in the child, we know head and neck injuries account for 40% of injuries, and they present very particular problems. And we have the double dentition, we have the triadic method of communication, so we have parents and children, and we have young children who are dentally naive and who have never been to the dentist before, and then you may need to intervene. So management in most cases is not the same as the permanent dentition. So etiology, we know it tends to be falls, bumps into things, sports when they're a little bit older. And I'm sure you're all familiar with the nursery rhyme of Humpty Dumpty, and he sat very carefully on a wall and all of a sudden he just fell because he wasn't doing anything to precipitate it. And it's not like that, is it, in children? They're not sitting very carefully. Just see what he does.
Humpty Dumpty sat on a wall. Humpty Dumpty
yeah. He wasn't sitting very carefully. He was prancing around like that, and then, of course, he was going to fall off. And that's what happens to children. They fall, and they don't know when to stop.
Have you been waiting?
Let me get this guy. This is a little Irish boy who goes to the airport to meet his uncle, and it just shows you children don't know to stop running or not to run into things. So he's getting very excited when his uncle appears, and just look what he does.
Have you been waiting a long time? Too long.
His excitement got the better of him when his uncle did arrive. Little Jamie was...
Unfortunately, he was fine, but that's what children do, you know, they don't know to stop. And it's not very often we see our own patients sustaining trauma, but this boy here is one of our patients, and he's in nursery, and just see what he does. He's just walking along quite calmly.
I did it from now.
And again, he wasn't looking where he was going, and he fell over, and these two are just sitting there, not helping him at all. So, in the primary dentition, just don't forget to consider safeguarding if you don't know how it happened. That's one top tip. And try to take radiographs. It's very important to tell where the permanent tooth is underneath. And I quite often get referrals saying I can't take them, the patient's too timid. And I suppose the answer is, if you can use a PA to take an upper standard occlusal, that will work really well. And it doesn't have to be a perfect radiograph. It just needs to show you the root of the tooth and the permanent tooth underneath. Something like that. And you can see here, we've intruded upper right A, upper left has been lost. If you didn't take the radiograph, you wouldn't know whether that was intruded or not. So we know we rarely see hard tissue injuries in the primary dentition, and if we do, you can literally just smoothen them over. And you can just use a handheld soft-flex disc to do that. When we have complicated enamel dentine fracture, yes, we can do pulp therapy if needed, but it's rare that a patient will allow us to do that on the chair. So I would say for the most part, we're extracting. As the previous speaker said, if you're going to do a root canal treatment, you need to use something that will resorb, such as Vitapex or calcium hydroxide. And if it's a crown root fracture, you can extract the coronal fragment and let the apical fragment just resorb. So you don't need to go digging for that. We do see some root fractures, and this is a little patient of ours. He fell at school, he has this horrible degloving injury. And when we took radiographs, we found he has actually 2 undisplaced apical third root fractures. And we don't need to do anything about it, but it's just to tell parents and to warn them, of course, there's a risk to the permanent dentition. If you have a vertical root fracture, prognosis is it's absolutely poor, and actually that would have to be extracted. So this little patient fell, he's got a vertical root fracture, he's upper left A, got a pulp polyp. We extracted that, and because of his age, he had a magic sleep for that. So vertical root fractures, hopeless prognosis. PDL injuries are what we commonly see in the primary dentition. Concussion, subluxation, we don't need to intervene, but we need to be aware of the risk to the permanent tooth underneath. And we know there's a 1 in 4 risk, even with that mild injury. Lateral luxation, a little bit more severe. You don't need to intervene if the patient can occlude. Okay? If they can bite together, the tongue will push the teeth back to where they came from. If not, then we're considering extraction. And I know the guidelines suggest you can reposition and splint, but in general, it will be extremely rare that we do that. So you can leave a monitor if no occlusal interference. Intrusive luxation, they will re-erupt. Very good result for the patient. And this is a patient who intruded his upper A's. And you can see the importance of taking a radiograph, and we saw the teeth are in there and they're going to come back down. And here they are, a week later, making an appearance. And parents sometimes are very worried about this, and I had a parent recently who said, don't you need to extract them? How are they going to come back down? And the answer is, remember when they erupted when he was 6 months old? Yeah, well, same. That's it. Very good eruptive potential. So, yes, intruded primary teeth will re-erupt. No need to do anything. Not within 6 months. Extrusive luxation, Tooth will be a little bit mobile. Again, we have a risk to the permanent successor. And in most cases, unless it's extremely mild, we're going to extract that. And here's Charlotte. So she came to see us about a year ago. She fell, she extruded upper right A. And you can see on the radiograph, you have that widened PDL space. It's very mobile. It's difficult for her to eat. We were waving goodbye to that tooth. So extrusions usually need to be extracted. Avulsion in the primary dentition, the key is we do not reimplant them because it's already caused damage to the permanent successor at the moment of avulsion. You don't want to increase that risk by reimplanting it. So we have a 50% disturbance to the permanent successor. And this is the little boy who fell in the video earlier at nursery. He avulsed his upper left B, and it was here in his hand, so we knew that it was avulsed. And he had laterally luxated and intruded his A. So again here, we didn't need to intervene, we just observed, and that A came back into position. Not into an ideal position, but pretty good. So don't reimplant an avulsed primary incisor, and you can often be under a lot of pressure to do that from parents. We know that it will make things worse. What not to do, and this is a case I saw as a trainee. This patient, you can see they're an older patient, so they're about 10. They fell and they avulsed upper right C. And it's resorbing anyway, it's undergoing physiological resorption. The treatment for that was nothing, but somebody has given local, they've reimplanted the C, and they've splinted it with wire and composite. And then they referred it on to us in tertiary care and asked us to take over management. So that's the wrong thing to do. We had to go in with local and extract that tooth. If you don't, it's just going to ankylose, and that 3 is going to be deflected. And you put the patient through 2 treatments that they didn't need. And always warn parent about the risk to the permanent dentition and write it in the notes, because by the time the permanent tooth erupts, it's going to be a few years' time, and they will have forgotten what you told them. So I always write this list. What's the risk to the primary tooth? If it's still there, what are the risks to the permanent dentition? And it depends on the age, okay? Under the age of 3, risk is higher. And here is just an example of one of our patients who subluxed upper A's. And we've 2 different injuries. So the upper right has obliterated. You can see here in the radiograph, pulp has disappeared, and the left is non-vital, and it's dark. We didn't need to do much with this patient. Okay, obliteration is a good sign. There was no infection. However, his friends at school, he said, had made a really good joke with him, and he thought it was very funny. I did too, actually. So what they said to him was, "Can I connect to your Bluetooth?" Poor kid. But the good news was we were able to manage him conservatively. Okay, in the permanent dentition, taking clinical photos is key. If you have a camera, it's much better than making a little drawing in your notes. If not, I always do a little drawing and mark where the injuries are, soft tissue, etc. Because it's very difficult to record something like this unless you have a camera. So take your photos, upload them at the same time, and when somebody comes back to you in 3 or 4 years later asking you for your notes, it's very, very accurate. And always consider both PDL and hard tissue injuries. And we know in the permanent dentition, the most common injury is a hard tissue, and it's a crown fracture. And the important thing is that we cover the dentine. If we don't, the risk of losing vitality is very high. It's over 50%. If you do cover it, it's much lower. It's about 8%. And you don't want to end up with a big sinus like that and a big periapical area. So always cover exposed dentine. That is the most important thing with those injuries. We use crown forms quite a lot, I'm sure you do, so Otis Pella. Come in different sizes like this. We choose the size of the incisal edge, and usually you can actually use the contralateral tooth if you don't do an incisal edge, so you know which size to take. And remember, as you trim them, they get a little bit bigger, always. My top tip when you do trim them is put some cotton wool inside, because it's very hard to see them on the bracket table. And quite often, I've trimmed my crown and then I can't find it. So if you do something like this, you can actually see it against the green. And we always say you need to make a little hole in the crown to leave the air bubbles out. You don't want to pick it up and give yourself a sharps injury. So I would advise use a cotton roll. Put it on the bracket table, push your probe into it, like that. Okay. And that's how you do it safely. Complicated, you can do a direct pulp cap, but it doesn't work hugely well. I would tend to do a partial pulpotomy for any complicated enamel dentine fracture. And it doesn't depend on the developmental stage. Even with completed root development, I would still go straight ahead and do a Schweck. We know about direct pulp capping. Pinpoint exposure, new exposure, you place whatever medicament you're going to use. So in the past it was calcium hydroxide. Nowadays we are using biodentine or total fill, and just cover the tooth. And it does work quite well. Anna Fuchs is the lady who did all the research on pulp, and she found a success rate of about 80%. So 1 in 5 will fail. I'm sure you're familiar with Meyer Schweck. He was around until about 2008. And he did his famous study in '78, looking at removing part of the pulp and maintaining a vital radicular pulp. And his success rate, even though it was calcium hydroxide at the time, was 96%. So very good success rate if your diagnosis is correct. And it's so simple, even our undergraduate students do it. So this is one of our undergrads doing a Schweck. You do need to give local, you do need to place a rubber dam. You take your high-speed handpiece and you remove some of the pulp until you get to healthy pulp. This was a few years ago, so we were using calcium hydroxide. As I've said, nowadays it will be total fill. And then you just restore the tooth and monitor it clinically and radiographically. You will get some pain for the first few weeks, and it will probably obliterate, but that's fine. We're happy with that. So, very simple, high success rate. Pulpectomy, sometimes we do need to do it. We don't use calcium hydroxide anymore, as we've heard before. We will use total fill, and then we would backfill with a warm vertical condensation for our open apices. And it looks really nice. It works really well. But you have to use warm vertical once you place a plug, because I've seen people have a plug and then try to use collateral, which of course won't work. The one thing I'd say about root fractures, they have a very good success rate. And we know we have mid-third, coronal third, apical third, etc. So coronal third would have the worst prognosis. But they have, in general, a very good prognosis of remaining vital. So if they're displaced, you reposition and splint for 4 weeks. If they're not displaced, leave them alone. Okay, you don't need to splint an undisplaced root fracture. And if they become non-vital, you will only root fill to the fracture line. Okay, you don't need to go beyond. But the tip is they have an excellent prognosis, so don't extirpate them straight away. Just monitor and make sure that they have lost vitality before you intervene. Only extirpate to the fracture line if so, and don't splint undisplaced root fractures. And I've seen people do that on quite a few occasions, and there's no need. What not to do, this is a patient we saw who had an undisplaced apical third root fracture. We've seen privately, and the treatment for this, of course, was to monitor. It had an excellent prognosis. But the private dentist has extirpated and placed a GP cone, but then they've lifted a flap and they've actually surgically removed the apex as well. So they've changed the prognosis from excellent to hopeless. So that was, again, the wrong thing to do and completely unnecessary. And coronal third, even though the healing potential is less, they do have a healing potential of about 20%. So again, we can give the benefit of the doubt. Splinting, I like titanium trauma splints. I'm sure you're familiar with these. They're very, very light. You can cut them with the scissors, and they're made for flowable composite, 1 diamond per tooth. Of course, you can use wire and composite, but I like these because they're flexible and very, very simple to use. And one tip when it comes to measuring, it can be quite difficult to measure in a patient's mouth. So if you want to, you can use some floss instead. Measure with the floss, and then go to the side, measure your splint and cut it. So you've got the right length. Okay, so that's much easier for the patient. And when you place your splint, you want to splint the uninjured teeth first and then pull the injured one into the splint, not the other way around. Just showing you there, we're using our flowable composite on the two uninjured teeth, and then the last thing you do is pull your injured one in, and then it's in the right position. Okay, so don't do it the other way around. I've seen people do it, and then you wonder why you haven't repositioned in the right position, and that's why. In the permanent dentition, we also have concussion subluxation that we don't need to do much with apart from monitoring. Okay, and we know they can lose vitality, so I tend to say to parents, teeth will show their true colours in about a year, so we need to monitor for at least that long. Subluxation, tooth is a little bit more wobbly, but I don't tend to splint these unless the patient is really uncomfortable. And again, you follow them up for up to a year. Open apices will obliterate, much like the primary dentition, and that's good. They'll be a little bit yellow in colour. They won't respond to sensibility testing, but you can leave them well alone. And you can see this tooth here, the pulp looks like it's completely disappeared. It is still in there. You will find it if needs be, but it's a difficult endo. And only 8.5% will lose vitality. So you don't have to rush in to extirpate these teeth. So yeah, pulp canal obliteration is a vital pulp. With extrusive luxations, it's different in the permanent dentition. You want to put it back where it came from, and you want to splint for 2 weeks. These teeth will be very mobile, so you can see the upper right one, it looks like it's hanging down. And here is Ethan, who presented with extrusive luxation of upper ones, and it was a late presentation. His dentist had already repositioned and splinted, but they weren't quite in the right position. So he ended up with quite extruded ones. We spoke to our friendly orthodontists, and they were able to put a sectional fixed and intrude them back into a position. And they're vital. PDL is sound, no need for any other intervention. So orthodontic repositioning is very useful when you have delayed presentation. Lateral luxation, again, you're repositioning and splinting, and these are frequently non-mobile, so they're stuck in bone. So you give local and reposition, and these teeth were repositioned by a general dentist, but they're only splinted to each other, which isn't ideal. So we have used our TTS splint, and with a lateral luxation, PDL outcomes are excellent. Okay, so again, you just need to monitor. Here they were in 17, wide open apices. November 17, continuing to develop. March 18, continuing to develop. And then March 19, closure of the apex and some obliteration. So that's success. How to reposition? Well, just make sure you give really good local. That's number one. Okay, make sure you give buccal and palatal. Protect the airway, and just bring the tooth back. If you can use your fingers, it's better. Sometimes I have to use a forceps. TTS splint in place, flowable composite, and one uninjured tooth at either side. And you can see radiographically, we're back in position, and the TTS splint is on. And it looks really good. And that tooth remained vital, and the PDL remained vital. But if you can use your fingers, it's much kinder to the tooth. Again, with intrusive luxation, you have a much more severe injury, PDL-wise, and it won't respond to sensibility testing. But this is one of our patients who stood at one side of a seesaw, and then somebody came in the other and sat on the seesaw and intruded her one severely. And because they have a closed apex, we know we need to extirpate them. So we surgically repositioned, TTS splint, and one of our undergraduate students did this actually. So extirpated the teeth in 2 weeks, nice endodontic treatment, and very nice outcome. So surgically repositioning them was important so that we could access for our extirpation. Protect the airway is my tip, because these teeth can disappear down the airway if you're not careful. And remember, they're very, very slippery. Avulsion, number one tip I would give, if it's a closed apex, if it's out of the mouth at all, you need to extirpate it, because it will resorb. This was one of our patients, Lewis, who avulsed upper right 1 and 2, and the 2 is actually very palatally positioned. And he was just about to start his orthodontic treatment when this happened. His dad came and repositioned both teeth in the right position, which was fantastic, and his dentist had placed a composite splint. We replaced that with our TTS splint, and I've just shown you the occlusal to show you where that 2 is. It's very far palatal, so it's quite difficult to splint that with wire and composite. Again, we knew we needed to extirpate, so one of our undergraduate students did this. One tip, when you're extirpating, make sure you do it when the splint is still on, because they're going to be very mobile, and if you take the splint off first, it's very difficult to access. So I'm just showing you here, we've accessed with the splint, and then we've removed it. Again, very nice root canal treatment, so he's done some plugs and obturated. So very good outcome for this patient. The teeth have ankylosed, of course they have, but he's gone off to orthodontics with the caveat that these teeth can't be moved from where they are. So yes, always extirpate a tooth that has been avulsed with a closed apex. This is a cautionary tale. So this boy avulsed his upper left 1, and he avulsed it at a weekend, so there were no dentists on call. And he went to A&E, and we know it's a time-dependent injury, but he waited 12 hours and nobody came. And his parents were getting really upset, and finally, one of the doctors came and repositioned the upper left 1, so that's really good. However, that's where they put it. You know? And you could argue you don't need to be a dentist to see that that's not the correct position for the upper left 1. So if you're going to go to the trouble of repositioning, just make sure you put it back in the right position. He then went to his own dentist the next morning, who did a really good job. He repositioned that tooth. It looked very good. Splinted. Now the treatment would be in 2 weeks, extirpate and remove the splint. So dentist didn't do that. Dentist monitored and referred to me about a year later with the words, "I'm not sure if the upper left 1 has taken." So when I saw him a year later, that splint was still on and the tooth hadn't been extirpated. And we know this will happen. This is severe infection-related resorption. So you could argue for this patient, his treatment was neither appropriate nor timely. And that tooth could have been saved. So please remove the splint at 2 weeks. We know this tooth has a high risk of ankylosis. And don't be like the snowman who fell in love with a hot stove. So that's a nice little children's story, hoping that the tooth will not become non-vital and that it won't resorb. It will never work. There's no way it can. The tooth will lose vitality, it will resorb. Again, this is upper right 1, has been repositioned and splinted, and somebody felt, I'm going to give this the benefit of the doubt, at the 2 week mark, but look what we have here, the writing's on the wall. It looks like somebody's taken a bite out of the side of the tooth. So that tooth is non-vital and starting to resorb. Composite splints, I really dislike them. They're rigid splints and they don't work. And especially those kind GDPs who colour match the composite to the tooth and then send them to me to spend hours removing it all. So use a flexible splint. If you're considering your timings, you can use 2C. Okay, so 2 weeks, subluxation, extrusion, avulsion, because there's no bony fracture. Everything else is 4, apart from coronal third root fracture, which is 4 months. And as I said before, primary tooth, if you were repositioning a lateral luxation, IEDT suggests 4 weeks. Personally, I've never done that. So 2C, this is the sea in the west of Ireland, the sea you swim in. It's a good way to remember your splinting times. What not to do? This patient avulsed both upper 1s. Somebody has repositioned and splinted, very good, but they look a little bit strange. And that's because they're the wrong way around. Okay. So it's not the end of the world, but ideally, make sure the correct tooth is in the correct socket when you put them back. This patient has had his lower one splinted but not repositioned, and I have no idea why. The idea of splinting is that you're supporting a repositioned tooth or a mobile tooth. So yeah, don't do that. Always reposition before you splint. And I have to give a plug to the guidelines for the orthodontic management of the traumatized tooth. Quite often you're asked by the orthodontist, when should I move the tooth? This is a guideline from the BOS, and it goes through each injury and tells you how long you need to wait. So less severe injury, 3 months, more severe, 6 months to a year. And they're freely available online. They're very good guidelines because I'm one of the authors. So I'd like you all to read them. But yeah, very, very useful. Read the guidelines. Okay, I think I'm just on time. That was a very quick overview, but please do come with any questions.
Thank you, Prof. Barry, for your insightful presentation and informative lecture. I think this tips and tricks all helped us to speed in our decision in our clinical practice. If anyone got any question for Prof? No? Okay, so I think we reached where we really want to provide and present you with a little appreciation from KDA. And thank you so much for your presence, which is make our conference really special today. And thank you.
Thank you. Oh. Is it done? Yep. Thank you very much.
I think thank you.
I know, I need the small one that connects it. You have it? The mic. Sí. Sí. Okay, شكرا. هلا حبيبي. تست.
اثنين. شنو حاسة؟ حاسة بشيء منى؟
Hello, everyone, and welcome back after your, let's say, light meal or lunch meal. And today we are ready to have our heavy meal, which is in dental sedation techniques. It's a great opportunity today to introduce our esteemed speaker. He's one of the best speakers in Kuwait, and we can say he is one and only in Kuwait in that field. My name is Dr. Sarah Al-Juwayhil. I'm one of the pediatric and special need dentists. It's a great opportunity again to welcome, and please welcome with me, Dr. Muhammad Abdul Wahab. Dr. Muhammad Abdul Wahab is a consultant dentist anesthesiologist. He has completed his dental degree from University of Pittsburgh School of Dental Medicine and Dental Anesthesia residency at University of Pittsburgh Medical Center. He also completed his master in public health from School of Public Health at University of Pittsburgh. He is currently appointed as a consultant dental anesthesiologist at Kuwait Ministry of Health and also adjunct faculty at Kuwait University School of Dental Medicine and adjunct faculty of University of Pittsburgh School of Dental Medicine. He specialized in providing anesthesia service to dental patients and special needs patients. He's licensed to practice in Kuwait and United States in the state of Pennsylvania. Please welcome with me and Dr. Muhammad, the stage is yours. Thank you.
Dr. Sarah, thank you very much for the nice presentation. You made me feel so proud of myself. Thank you for attending, everyone. Thank you for attending my lecture, attending KDA meeting. My name is Dr. Muhammad Abdul Wahab, and as Dr. Sarah said, I'm a consultant dental anesthesiologist. Every year I get asked to actually provide a lecture about sedation and dentistry in the KDA meeting. And in the prior years, I was asked a lot to actually give a presentation about how to do the sedation and the anesthesia part for patient. Unfortunately, the first couple of times we did, the feedback we got from the audience was that one lecture is not enough. And they rather learn about the options what anesthesia and sedation options they have if they have an anxious patient, if they need anesthesia. So this is why today we're gonna talk about what options. We're gonna emphasize and put a lot of effort to teach you guys and provide to you what's available in Kuwait, what options you have in sedation, what the sedation types that we have, and how you can communicate with your patient. So to start with, and whenever we talk about dental anesthesia or anesthesia in general, we have to talk about Dr. Wells. Dr. Wells was the first dentist, and actually considered the first anesthesiologist, that used nitrous oxide to do a surgery or to do some type of procedure. Before that, it was done in 1866. Before that, any patient needed surgery or needed any procedure done, they used to literally give them plant, or they give them something to make them drowsy, or give them alcohol. After the discovery of nitrous oxide, the gas in 1788, they didn't know what nitrous oxide was. So until Dr. Horace Wells actually applied nitrous oxide on a patient, and they did tooth extraction in 1866. So we have to mention that. So he was considered the first dental anesthesiologist, or the first anesthesia provider at the time. Later on, it caught up, and actually more people asked for nitrous oxide. So nitrous oxide is a very old gas, and it's a very old technique that the dentists and the healthcare actually have. So after 1866, nitrous oxide, they found out that actually it makes people happy, and it makes people laugh a lot. So they start doing what they call nitrous parties. So nitrous parties was actually very famous in the early 1900s, I would say, like 1890s to like 1910. So they brought a barrel of nitrous oxide, and they sell tickets, they bring people in, and they start just to sniff nitrous oxide, laugh, and have a good time then. But they had some fatality because it wasn't measured and it wasn't controlled. So this is just a little bit about the history of nitrous oxide and what we do. Now we're going to talk about sedation. What we have, what the definition of sedation, what actually we mean whenever we give sedation, why do we need sedation? To start with, we define sedation as giving medication or a drug to a patient to basically alter their anxiety or reduce their anxiety. Not necessarily eliminating the anxiety, but to reduce it to a level that allow the dentist to do dentistry. I'm sure if I ask you how many dentists have anxiety patient every day? We do, all of us. It's very common. It is very common in the healthcare and the dental field that we have anxious patient. I was one when I was a kid. I had really bad teeth, and somehow I became a dentist and anesthesia. I hated the dentist, and I still hate the dentist, and I rather get something taken before I do dentistry. So basically, we define it as a reduction of anxiety or stress or excitement by giving medication or a sedative agent. Now, the sedative agent can be either a gas, a pill, or a liquid, or a combination of either. If we talk about the need, or why do we need sedation, number one is anxiety and fear. And this is a study that, this one doesn't work. The first study we did actually was a study we did at Kuwait University, and it's published that 29% of the Kuwaiti population, or that people that actually we did the survey on, they said they have severe high fear and anxiety toward going to the dentist. And out of these people, 30% of them said, yes, we rather to actually have something, be asleep, have a medication, or get general anesthesia or something to go to the dentist. So fear anxiety is number one. We see that every day. Actually, I work in Jabir hospital, and we say that every day. Every day we have pedo patient, adult patient, all range of ages. They do have anxiety. It's not one thing. And honestly, before going to the specialty, I thought dental anxiety or fear from the dentist is not real. Basically, I thought no, the patient is just the patient is just not feeling he's spoiled or something like that. But actually, it's a real thing. So number one is fear anxiety. Number two, that actually we need sedation for, is pediatric patient, special need patient, or uncontrolled patient. Pediatric patient, honestly, do we have pediatric dentist here? Raise your hand. Guys, I have a great respect for you, and I applaud you guys how you actually deal with pediatric patients. They're tough. You have 2-year-old, 3-year-old, 5-year-old, 6-year-old. I don't even know how you can deal with pediatric patients. They really have very, very short attention span, and I don't know how you guys control it. But I applaud you guys, you do a great job. And this is one time, even with the intervention of the pediatric dentist, they cannot control the patient. They need actually some type of medication to relax. And we see a good number of pediatric patients that actually provide them sedation to do. Another thing is special need patient. Anybody work with special needs? Yes, no? Usually pediatric dentists, if we have the special needs clinic, I also give them a big clap on how they actually deal with special needs patients. These patients you cannot control, meaning they will not sit for 20, 30 minutes to actually have the dentistry done. So you definitely need to intervene. The other option is if you don't intervene, is basically having poor oral hygiene. And they usually come, especially special need patients, they come with either an infection or pain or something happening that you need to intervene at that time, or maybe within like 5 or a week time period. So it's a big thing. So uncontrolled patient usually is pediatric patient, special need patient. If we go further, another need for sedation is pain control. Pain control is usually done whenever we do IV sedation. We can provide medication through the IV to provide good pain control whenever the dentist or usually the surgeon or somebody is doing an extensive procedure. So sometimes instead of just giving a local anesthesia, we give IV medication to prevent and provide good pain control. And usually we have Dr. Mahmoud here, who's an excellent oromaxillofacial surgeon, and we work together. We do that a lot. Sometimes the patient does not have anxiety. The patient is just, the procedure is big. It's a big procedure. So we recommend that instead of having the patient go through the whole process, just give them IV sedation or other type of sedation to relax the patient, make them happy during the procedure, not remember anything, and the patient will be very appreciative of what we did. The last thing is controlled movement. Usually we have patients that actually have tremors, and to control tremors, we definitely need some type of sedation. You cannot do dentistry if the patient is moving. It's tough, it's not safe for the patient, and you have to actually provide some sedation. I've seen dentists that actually don't have access to sedation, that actually do hold the patient down because it's an emergency. But if you have an option and if you have actually access to sedation, just refer them to get sedation done. Now, type of sedation that we actually have in Kuwait, and it's available, and actually all three of the top one, the inhalation sedation, oral sedation, intravenous sedation, we do at Jabir Hospital, the dental center. General anesthesia is actually done in like hospitals. Well, the dental center, Jabir Dental Center, the general anesthesia will actually have to do in the hospital. But these are available in Kuwait. So if you work in private, you work in the government, you can actually ask and see how you can provide your patient with, if they need one type of this sedation. And the definition of the classification that I did is basically the most common things. For example, if we say inhalation sedation, it's usually in the dental field mean nitrous oxide. It's not, we're not talking about sevoflurane or isoflurane, it's just nitrous oxide. If we talk about oral sedation, it's just a pill. If we talk about IV, it's definitely giving medication through the IV. And if we talked about general anesthesia, it's just general anesthesia. So it's not about the level, it's about literally the most common names used in anesthesia. So I'll start with inhalation sedation, which is basically nitrous oxide. Nitrous oxide is very safe. It's one of the safest gases you can give to the patient. Plus, the machines nowadays is very safe that you cannot overdose the patient. Even if you go to the maximum dosage of nitrous oxide, you still give more oxygen to the patient than whatever the patient is breathing in room air. Do you know how much oxygen percentage we breathe in the room air? How much? No, I'm saying now, now we're breathing oxygen. What's the percentage of oxygen in the room air? Do you know? Dental student, that was in your lecture. Huh? 21. So basically we breathe at 21%. Now, everybody, we're only breathing 21%. The nitrous oxide machine, the advanced one, actually since the 80s, the minimum amount of oxygen it can give is 30%. So it's very safe. It's actually 9% higher than whatever we're breathing. So it's very safe. The other thing is very easy to use. You just hook it up, you have control, you have digital ones, you have manual ones, and it gives exactly what the percentage you want to use for the patient. The other thing is only good for mild anxiety. So patient with severe anxiety, it does not work with patient with severe anxiety. If you have moderate anxiety, usually it does not work. So you have to be sure and you have to be very careful of your patient selection. So you cannot just have somebody who's screaming or somebody who's actually very anxious. You bring them in and you give them nitrous and you think that the patient will be relaxed. It doesn't work this way. The other thing that you do need patient cooperation. The patient must sit, the patient must understand, they need to breathe from their nose, and you keep them doing that for another, I would say, however the procedure, an hour and a half. So that's need also the patient cooperation. So usually whenever we get a consultation to do nitrous oxide, we do actually do one appointment, which is basically consultation and introduction of the machine, introduction of the mask, and introduction of what's going to happen with the patient during nitrous oxide. So if you're into doing nitrous oxide at your clinic, make sure you do that. And it's actually a very good thing. The patient will actually break the ice with the patient. The patient, especially if they're kids, they will actually be very happy to use. Usually we write the name of the patient on the mask or the nasal hood, and we give it to them, tell them make sure you don't lose it. So we use just these small techniques just to make sure that the patient is comfortable and happy. Now, it doesn't work with pediatric patient, and from my experience, I don't know if pediatric dentists agree with me, but any patient below the age of 5, it doesn't really work because of the patient cooperation. Usually, the patient will not sit, will not actually understand what the patient needs to do, and how to breathe from their nose, and how to do any of that. So usually, I honestly don't think below 5, you can use nitrous oxide. The other thing about a limitation of nitrous oxide is office limitation. And whenever we talk about office limitation, we talk about the space. I mean, the machine is about this big, and you need good ventilation. A good ventilation, and you need an exhaust system that actually take all the whatever the patient is exhaling, so you don't get contaminated to the room. Another thing, you do need training. So with training, you definitely need incubate training to do nitrous oxide to your patient. You cannot just say, I'm trained, I need to do it. You definitely need to do, get some training. And the last thing about, and that actually I face a lot, is about the misconception. When I say about misconception, I talk about the dentist. Many dentists, and I see that a lot in the clinic, they refer the patient to nitrous oxide. We give them the gas, and then after like 2 or 3 minutes, they think the patient is completely asleep. And they go aggressive. They think the patient is under general anesthesia, which is not correct. Whenever you're giving gas, the patient is awake. The patient may be closing their eyes, but they're awake, they can hear. They're just relaxed. And their response to the pain is maybe delayed, but the patient still can feel. The patient can actually hear everything. And don't go aggressive. If you do nitrous oxide, just try to be as gentle as possible doing dentistry. Make sure always to put topical anesthesia, always, 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 because sometimes I see dentists that with nitrous, they say, no, he's sedated, I don't need to do local anesthesia. I'm doing local anesthesia. Now, another type of sedation is oral sedation. It's very common. We use it, and it's cheap. You would basically give a patient a pill or a liquid, something to drink, and the patient will be relaxed. Okay. You don't need any special equipment to do it compared to nitrous oxide or IV sedation or general anesthesia. And the drug reaction is way less severe. The patient needs it. It will go orally. It goes to the stomach, and then all the metabolism happens. So the reaction is usually, if there is any reaction, is very, very less severe. And there is no injury to administration. You're not starting an IV, so you're not actually going to the veins. You're not giving an IM, so you're not actually breaking a skin or giving an injection. You're basically just giving a pill. And usually patients love it, even pediatric patient. Pediatric patient, we give them syrup to drink. Adult patient, we just give them the pill. Taking the medication orally is acceptable for even kids because they drink. They have no problem drinking juice. Adult, everybody's taking pills. We usually have no problem taking pills. So it's a very good, cheap alternative to nitrous oxide. Another thing about it, it does provide deeper level of sedation than nitrous oxide. So if we use, for example, Xanax, sometimes we use Xanax, we use Halcyon, we use ketamine orally sometimes, but not in Kuwait. It does provide good actual level of sedation. We use Atarax, hydroxyzine. It's actually very good. It does provide very good level of sedation, deeper level of sedation. Usually the patient just feels that they want to go to sleep, and the dentist will come and then just do dentistry. And that works good with pediatric patients. Sometimes actually with the oral medication, we do give nitrous oxide. So we do a combination of oral and nitrous oxide. And it's a very good combination, and we do a lot, and a lot of procedure can be done. The issues with oral sedation that not everybody talks about, it doesn't work for long procedures. So you have to be very fast. You cannot just give a pill and then you try to work for 2 hours, an hour and a half. Because whenever you give the pill, you have an onset. It actually works it takes about half an hour, sometimes 45 minutes, depending on the medication, until the patient actually reaches that level of sedation you want. Once you reach it, the patient usually lasts for another hour, maybe 40 minutes, and then it's gone. The patient will actually wake up. And you can't do a very long procedure. The other, I would say, disadvantage of oral sedation is titration. You cannot, if the patient, you give medication, you have to calculate your dose very well, and you have to know exactly how much you want to give the patient to reach the level of sedation you want. You cannot just give the pill and then stop the procedure, give the patient another pill. It doesn't work because the onset, it takes half an hour to actually work. So some people do it, but it doesn't work really well. So kind of you have a one-shot thing. You give the patient the pill, You actually make sure that the patient reaches the level of sedation, and then you just do it. Sometimes people consider it a bad, not side effect, a bad thing is the level of sedation. Oral sedation do produce deeper level of sedation than nitrous oxide. Sometimes whenever we work with prosthodontists or periodontists, whenever they do implant, they ask the patient to open and close or do some this or that with their mouth just to check occlusion or something. And with oral sedation, usually that level of deeper sedation, the patient won't be able to do these movements. So we have a problem. Some surgeons don't like it, or prosthodontists. The third type of sedation that we talk about is intravenous sedation. Basically, personally, I think is the best sedation that we can provide to a patient. It provides everything you want for a patient. So imagine this. You have a patient, they need to go to have dentistry done. You're going to provide them with amnesia, you're going to provide them with analgesia, and you're going to control their movements. So the patient will come in, we'll start the IV, and then basically after giving the medication through the IV, the patient will not remember anything. So whatever happened after giving the medication, the patient is basically is not going to be registered in his brain. So for him or her, it didn't happen. The other thing is, besides the amnesia, is the analgesia. If you have an IV access, you can give you have a lot of options of many medication for pain control. You can give opioid, you can give paracetamol IV, you can give Toradol IV, NSAID. So you have a very good range of medication that you can give the patient. So even if the procedure is painful, even if the procedure is lengthy, you can do a very good job with controlling the pain. Not only during the procedure, also we can give medication to control the pain after the procedure. And then the movement control. We control the movement by basically taking the patient to a very deep level, and they will be asleep. And we do that a lot with the special need patient with tremors, even pediatric patient with the IV. So basically, the patient is completely asleep. You can come, do your dentistry, and these are available. I'm just telling you what options you have, and based on which I would say indication for any type of sedation, you can choose how to refer your patient. It's good for the pediatric patients, special need, even adults. We do a lot of adult patients also, implants, surgeries, extractions, even regular dentistry, fillings and like cleaning and stuff like that. And another good thing about it is we as anesthesiologists, we can titrate, which is one option that is excellent. So we bring the patient, he can titrate, so basically you can make the patient go deeper, making him very sleepy, I would say, or deeper with anesthesia effect, or make him light, which is basically make the patient respond to touch or whenever you actually talk to the patient. So we have control of the level of medication we give the patient, because we use very short-acting medication through the IV. And based on this, now there's a whole new trend about like one-visit dentistry, sleep dentistry, one-day smiles. The patient usually come in, they pull all their teeth, and they put implant, and they put immediate dentures, and the patient will leave within like 6 hours with a full mouth, and you basically smile. So it's very good. It's actually one of the best, because you can do a lot of things, a lot of dental procedure with it. The bad thing about it is we have very limited providers in Kuwait, okay? Another bad thing about it is you have to do an IV start, because if you do an IV, there's always a risk of, I would say, infection or actually trauma to the veins or phlebitis or something like that. Another thing that sometimes, depending on the dentist or the surgeon, is the level of sedation. Again, sometimes the dentist or surgeon, they don't want the patient to be very deep during the sedation. So they don't like it. They say, no, I want them light, but you already gave medication. So it's always a good thing to communicate with the surgeon or with the dentist. Do you want them very light, or do you want them light, do you want them deep? But on the other hand, we can titrate, which is a good option for, a good thing for IV sedation. Whatever goes on IV sedation, or actually whatever goes on general anesthesia goes on IV sedation. For example, if you refer your patient to IV sedation, to get IV sedation done, You have to explain to your patient that they need to be fasting, they need to expect that they wear something light, they will go into an operating room similar setting to actually provide this. So actually you need to know that so the patient will not say, oh, you didn't tell me they're gonna start an IV, or you didn't tell me that this or that. So just to get an idea of this. Usually, I'm gonna show cases that we did later on. Now, the last thing, which is kind of, I would say not the standard, but that you can do definitely all type of dental procedure is general anesthesia. And general anesthesia is definitely can do any type of procedure, any type of dentistry under general anesthesia. The idea is very simple. The patient will be completely asleep. He will have a tube from his nose all the way to his lungs, and the patient will open their mouth. You can do whatever dentistry you want, root canals, implant, full mouth, orthognathic, whatever. It's basically the patient's completely asleep. You do require an operating room setting, so usually we do it in same-day surgery center, or we do it in hospitals. The good thing is also you can do very long procedure. I'm sure like orthognathic surgery, 4 hours, 5 hours, 6 hours, we do that. It's fine because you're doing general anesthesia. With IV sedation, we usually try to limit it to 2 hours, not because of the medication, just because of that, the need of the patient that they need to actually go and actually relieve their bladder. They need to pee, basically. So what you see is the patient is moving and increase in heart rate and blood pressure, telling us that he needs to be kind of a sign. With general anesthesia, if we usually ask the surgeon how long the procedure is going to be. If it's longer than 2 hours, we automatically put a Foley catheter just to make sure that the patient's comfortable and doesn't need to actually have an accident during surgery. The other good advantage of general anesthesia also is you can do advanced surgical procedure. So basically the patient is asleep. You can do whatever you want surgically, safely, surgically during that. So dentistry, fillings, root canals, implants, crown preps, everything. And with general anesthesia, we do put something we call a throat pack. We put like gauze down the throat, so nothing will go down the patient's throat, and the patient will be completely safe. So nothing will go to the patient's lungs. I would say not the disadvantage, but not a negative, but the thing that we have to keep in mind and consider is with general anesthesia, you require more preparation. So usually sometimes you need an operating room, you need appointment, you need to actually book the patient, and it's a little bit more expensive than doing IV sedation or doing other type of anesthesia procedures. So this is basically just the option we have. We talked about nitrous oxide, inhalation sedation, oral sedation, IV sedation, and we talked about general anesthesia. Now I'm going to show you some examples that actually were things we did. This is a video. Actually, I got that from Dr. Yusuf Al-Awali. I'm not sure if he's here or not, from his clinic, Smile Design. Can I get the audio, please? Okay, thank you. And he's basically doing an extraction for the patient. And he's using nitrous oxide. He's a pediatric dentist, excellent pediatric dentist. And it's basically doing, but I want you to hear, I'm sorry, I'm talking.
حاسه بشيء؟ زين الحين انا راح اهز له ضرسك لما هزه عشان تطلع الوساخه منه زين شوفي راح اهزه يمين ويسار كذا شوف يلا ببدا.
So this is exactly what we want whenever we do nitrous oxide. You see that level of comfort, the anxiety level is actually gone. And there are other videos I'm not going to show, but the patient was very apprehensive. The patient actually was standing next to the dental chair. She was refusing to have dentistry done. But Dr. Yusuf talking to the patient and the parent talking to the patient convinced her to actually sit and have nitrous oxide. And he was able to actually do the extraction. The other option would have been just hold the patient, force her to have the dentistry done, or not do anything, and basically would go into an infection and, I would say, pain for the patient. So it works, it does work. Okay, that's another example of a patient that we did. This case is actually from during my residency, a long time ago. Okay. So we had this patient was 28-year-old male. He came to the surgery department. He needs third molar extracted. You can see he has an impacted third molar on the lower left, right, and basically because of the, I would say, severity of the procedure or the involvement of bone removal and everything, we just suggested that the patient would go under IV sedation. So this patient was healthy, he was a PS1, no contraindication to treatment, and the patient had no allergies and he was not on any medication. So he was scheduled in 3 weeks, so we pulled number 1, 16, 17, 32, which is what, 1, 8, 8, I don't know, 1, 8, 2, 8, 3, 8, and 4, 8, okay? And that's basically was the setup of the IV sedation. We have, he was the chief resident then. We have a dental student was assisting him, and the patient was on a dental chair. But definitely with IV sedation, we have a monitor. We monitor his heart rate, we monitor his blood pressure, and we monitor his oxygenation. So there's not a lot of setting needed with IV sedation. It's basically a regular dental office, but you just need the monitors. It took 45 minutes. The patient had controlled all his movement, and the patient was extremely satisfied with the treatment option that we chose. Another case that we did with under IV sedation, again, is she was a 61-year-old female. She came edentulous. She needed implants. And we just said, okay, because she needed 8 implants, we just do IV sedation instead of general anesthesia. Because she's healthy, we can do it, and we have a very good surgical team. So we did the same thing. Same dental chair, we have everything. And we had the surgeon, I think a periodontist, and the assistant, that was me a long time ago, okay? And we had the anesthesia preparation. The patient was on a dental chair. We have all the monitor, the pulse ox, and she was relaxed. And after the procedure, this is basically the end procedure. They did LV plasty, and they put 8 implants, 4 on top, 4 on the bottom, and the patient went home the same day, and she was very happy. And it was then all under IV sedation. So the patient was happy. She didn't feel any of the pain. She didn't remember anything. The last thing she remembered was just an IV. And then she went home. She was really happy. Another patient that we did is this guy. He was 58-year-old. He came to the department. He needed full mouth extractions. And he had a history of hypertension, diabetes, and acid reflux and depression. And because of the acid reflux, we didn't go with IV sedation because we needed what we call protect the airway. Acid reflux, you might have some acidic or some gastric acid come out, a liquid. So actually what we said, well, no, we're gonna do with general anesthesia and get a consultation from a physician just to get some labs and some medical history updated for us. And the patient came in. This is his mouth. We did a nasal intubation. This is always what you see, is a nasal intubation for dental procedure. Sometimes they do oral intubation, but it's not very helpful for the surgeon or the dentist whenever they do it. So always if you actually do general anesthesia for your dental patient, always ask your anesthesiologist to do nasal intubation, unless there is a complete contraindication. So the patient came in, and actually they pulled all his teeth, and it was a very good case, and the patient went on. Of course, we cannot do sedation without talking about pedo. So this patient actually came to the pediatric clinic, and they needed all these teeth done. I think 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So I needed to have 15 procedures done out of 20 teeth. So almost all his teeth needed to be fixed. And this is kind of cases that you definitely, even though you can do them, even if the patient semi-cooperative, I would rather just have the patient go under general anesthesia, honestly. Because the patient will not remember anything. The patient will just basically be asleep. He'll be actually comfortable. The last thing he will remember, usually with pediatric patient, we give them something to drink. So this is the last trauma they will remember. As I was in mommy's arm or daddy's arm with my family. I took something to drink, and then I woke up. That's the only thing. This is the trauma. This is the dental trauma. And in, what, an hour and a half, 2 hours, you can do all of these teeth in one setting, if you have it available. I know in some setting you don't have that option available, and you might take, I know you do it in pediatric dentists, they do things in quadrants. So you can do like the upper right. So you're probably gonna take, what, 4 or 5 appointments if the patient allow you. But if you have a case like this, please refer them to have general anesthesia done or deep sedation, IV sedation done, because it's very helpful for the patient, it's more beneficial for the patient. The other thing that we talk about whenever we talk about general anesthesia, usually the patient come in the day of surgery and they leave the day of surgery. They don't need to actually be admitted the night before. So usually they come in the morning and they leave the same day. Another thing, one thing also is just that the patient will need to be seen by the anesthesiologist maybe 3-5 days ahead of time. And as a dentist, if you refer your patient to have general anesthesia or IV sedation, because you need to do it definitely in, I would say, operating room setting, or you do it in a same-day surgery setting, you have to understand, and you have to tell the patient what to expect. So always tell them that you must be fasting, you have to wear something comfortable, and you will get an IV, but you will be asleep. We had a patient about a week ago, and we talked to her, and she was actually happy that we did IV sedation, but she said, I thought that I will be awake. Well, whenever we did IV sedation, for us, she was awake, she was responding to us. But for her, because of the medication we gave, it did not register, so she was in an amnestic state. So for her, she just forgot everything since we gave the medication. So basically, just explain to the patient. If the patient knows what to expect, they will not have any problem about the procedure and about the anesthesia provided. Okay, so I gave you example of the type of sedation, the option we have in Kuwait, what we can do, and the type of kind of cases. If you have any of these cases, similar cases, you can basically seek and ask what you need actually, how you can actually get sedation done or general anesthesia done for your patient. And that's my time. I kind of passed 3 minutes. Thank you very much. Any questions?
Okay, thank you, Dr. Muhammad, for your engaging and informative presentation. We would be delighted to hear any question for Dr. Muhammad.
Yes, Doctor. Okay, to get a license of nitrous oxide in Kuwait, it depends on your training. We know, in fact, if you're a pediatric dentist, oral surgeon, and a dental anesthesiologist, you're automatically during your training, you get the training. So the Ministry of Health will accredit that, okay? If not, there are certain nitrous oxide courses provided in Kuwait that will actually give you the training part. It's accredited by KDA and by KIMS, and they will accept it as a training part. However, there are other things you have to follow to get your nitrous oxide. For example, you need ACLS, BLS, and certain other like facts or other things you have to do. This is basic for nitrous oxide. And just one thing. If you're ever gonna do nitrous oxide, just a suggestion, do not get the digital. I don't know if they're selling downstairs or not, but don't get the digital. Go with the manual machine. It's better, it's easier, it's cheaper, and it's just better. With the digital, you need electricity, you're limited with the cord, and it limits your mobility in the office, so don't get digital. The other thing, there are some companies, they're advertising what they call a big tank machine. Never ever with gases and anesthesia, only work on one nitrous tank and one oxygen tank. It's dangerous. You always need to have a backup. So whenever you buy any machine or think about buying a machine, always make sure that you have a backup tank, either for oxygen or nitrous. That's just to mention that. Any other questions?
Thank you, everyone. Thank you, Dr. Muhammad, for your informative lecture and insightful presentation and performance. I think if anyone got any question, Dr. Muhammad is more than welcome to be sent to him. And now we are more than happy on behalf of KDA to present Dr. Muhammad with little appreciation. And thank you for broadening our information in that field, which is your famous, and make our conference so special, Dr. Muhammad, with your presence. Thank you.
احمد جيب الهيدسيت الثاني وافتحهم. put on your hand. Your hand. Put. Yes, like this. ايوه. Try.
صح.
Test, test.
Test, test. Hello?
Hello, everyone. Hello. I hope everyone had a good time so far. My name is Dr. Ziad Al-Zaid. I'm a consultant orthodontist, and I'm the head of Kuwaiti Orthodontic Society. Today, Dr. Hamid Suwaidan and myself will be your chairpersons for this afternoon orthodontic sessions. Before we begin, I would like to use this opportunity to make an announcement. In the year of 2025, I mean coming soon, we will have upcoming exciting orthodontic events. Our first event will be MSc course and hands-on workshop. And this will be by Prof. Wan Moon. The date of this event will be the 31st of January 2025. The other event is the second Kuwaiti Orthodontic Symposium, which will be in the 11th and 12th of April 2025. Alhamdulillah, our last first Kuwaiti Orthodontic Symposium was very successful. And inshallah, we will work very hard to make the second event even more successful. So stay tuned for these two events and for these 2 days. Now, I will pass the mic to my colleague, Dr. Hamid Suwaidan.
Assalamu alaikum. Good afternoon, everybody. My name is Dr. Hamid Al-Suwaidan, specialized orthodontist at Jabir Ahmed Dental Center and a member of Kuwait Orthodontic Society. It's my pleasure today to be with all of you to introduce our esteemed speakers, Dr. Mishari Al-Fawzan and Dr. Nicolo Dovidio.
Bravo.
Dovidio. Dovidio. Dr. Al-Fawzan is a consultant orthodontist, graduated with a master's in orthodontics from University College London, Eastman, Salam, and obtained a membership of orthodontics from the Royal College of Surgeons in England in 2013. He has been a Diamond Apex provider with Invisalign since 2020 and has been holding numerous Invisalign workshops and presentations since 2017. He has also been assigned as one of the first official Invisalign iTero speakers in the MENA region since January 2024. And Dr. Nicolo is an aesthetic dentist practicing in Kuwait. He focused on aesthetic and digital dentistry since the beginning of his career with publications and studies. He developed new protocols and approaches in the vertical preparation technique together with the digital ecosystem. Recently, he became the first iTero speaker in the Middle East with more than 2,000 documented digital cases. Please welcome our speakers with me.
Thank you.
Thank you. Thank you, Dr. Hamid, and thank you, Dr. Ziad, for the great introduction.
Shukran.
Actually, today we want to share with you, the purpose of the lecture is to share with you our digital transformation in our practice. And hopefully, you allow us to inspire you to adopt, if you not yet adopted this digital transformation. We like to call it do less and get more. And the reason why is that we realize with adopting the digital transformation, we're actually doing less, but eventually getting more.
So, as the title suggests, we're going to talk about digital and the multidisciplinary approach together with the digital workflow. So the first question that comes to my mind when I think about digital is why digital? Why should I go digital? And this is actually the question that I made myself 5 years ago, because I was not used to use digital at all. Actually, I was against the digital workflow. But then thinking about that, just think the morning when you wake up, I know you take a coffee, you do meditation, you have a healthy breakfast. I wish it was like that. The first thing we do in the morning when we wake up is we check our phone. We check our laptops. Actually, I have the alarm on my phone, so I'm forced to see the first thing I do is to check my phone. And then, second thing, check emails, check social media. We are, from the beginning of our day, into the digital. So, even in the medical field, think about that. Few months ago, a doctor performed a surgery from Barcelona to Peking via remote. So the patient was in Peking and the doctor was in Barcelona through a digital connection. So us, as a dentist, can we avoid the digital transformation? I don't think so. And
since the adoption of the digital transformation, we have a saying in our practice, Crown Dental, where we practice, we say, "El treno se está moviendo," which is, the train is moving, because this is what happened. Exactly. So I wanted to share this with you.
So from a patient point of view as well, the digital transformation involved them, because thinking about the past, now I love this picture, is named Cavadenti, which is a picture of an old dentist in 1600. And imagine, the doctor is performing an extraction in front of other people, no gloves. Everything is a table where probably they had lunch before. Everyone is looking. At the end of the treatment, most probably the patient thanked the doctor. When they're, "Thank you very much, doctor, for saving my life." Think about that nowadays. It wouldn't be possible to do that because of social media, because of internet. Patients are getting, they get instruction. They come and they know exactly what they want. They come with a diagnosis made through Google. Nowadays, I mean, recently AI. They come to us, AI told me I could have bacteria because of this wrong crown in the lower right. Are you dentist? No. Okay. So the level is getting better. People are getting more informed. And the average level of dentistry is getting better and better and better. So again, we cannot lose the train, as he said, that is moving. And we have to adopt this transformation, because the most common image that I have in my mind is that, especially me, that I work in the aesthetic field, patient, they use the mirror while I'm working. This is something that really means something. And another important word is multidisciplinary. Together with the digital transformation, this is something that nowadays we cannot avoid, again. Because, again, patients they know that you can have benefits out of it, and Dr. Mesher is going to explain what are the benefits.
So basically, when you think about the digital workflow, it's faster. Not only the steps are faster, because I know, for example, when I used to take impressions for for example, Invisalign, it used to take from me 10 minutes, 5 to 10 minutes, and sometimes you have to repeat it. So the steps are actually faster. Now with the scanner, we can do it faster, and it's faster delivered to Invisalign to receive your aligners. So in general, it's faster. And now with the multidisciplinary, as Dr. Nicola was saying, we're actually doing less number of teeth needed to be treated. So for example, if the teeth from a multidisciplinary approach, ortho-prosto specifically, if I can do ortho and prosto together, I can minimize the number of the teeth I have to treat in the treatment. And of course, working with Dr. Nicolo, it's always an obsession of doing less preparation. And I think all prosthodontists, if they can prepare less tooth, they would like to do that and then avoid invasive procedures, I'd say. And believe it or not, I worked probably 10 years in orthodontics with so many prosthodontists, But together with Dr. Nicola, I think we do less than 20% of the teeth with root canal treated. So we rarely, almost never do elective root canal treatment. And the reason why, I think it's much simpler. And this is what we're trying to say today. Applying the digital is actually much simpler. Applying the multidisciplinary in a digital workflow, it's simpler. We just move the teeth that needs to be moved with a great communication tool using the digital scanners or the ClinChecks, and then we decide that we don't need to do root canal because we have actually moved the teeth in the right position. And of course, less extraction if needed. This is you, because this is the Italian concept.
So it means that there is a lower biological cost that is more cost effective for the patient. And at the same time, there is less discomfort because, as he said, you're taking analogic impression. Analogic impression is definitely more discomfortable than a digital impression. And you keep more option for the future. Now, this is, I think, this is what I'm seeing. This is the trend in medicine in general. We tend to keep, I put the picture of an archer because in Italian we say, we keep more arrows for our bow. I want to have more option in the ears to treat not only a tooth, but the health of the mouth of a patient. The moment I remove an option, which could be an extraction of a tooth, I remove the tooth. I can lose a bone, I will place an implant. Dr. Al-Kandari looks at me, yeah, we will place an implant, but if you can place the implant later on, maybe it's better, because when or if the patient will lose bone, then what will be the other option? Will be more invasive and more invasive and more invasive. Instead, I keep the tooth, let it live for some other time, hopefully for a long time, and then continue with the other options that I can have. What are the benefits, Dr. Mishari?
So basically, we are hopefully in the next part of the lecture, we are sharing some cases. We can achieve much better aesthetics together in this multidisciplinary approach, and it's much easier to reach those goals. We adopted also a system that's more personal, because you know, if you're actually doing 10 veneers or 10 crowns, you're actually, it's more whether you say, you can name it natural, but it's a fake teeth. But if you are actually doing a single veneer or 2 veneers, you're actually making it more personal. And we will show how using this digital tools makes it possible. We also get much more predictable outcomes, because nowadays, which we will show as well, we're using the iTero scanner, and we're actually getting some tools in the iTero scanner that can actually simulate the outcome of the treatment. Not only the outcome of the ortho, but with a very powerful tool, which is the Smile Architect, that is integrated in the ClinCheck, which is the application that we use for planning the orthodontic treatment. We have the restorative or the aesthetic treatment incorporated. And there is a smile simulator also coming. And you also, this is what we like to do, we can delegate. Because in the past, you have to take your impressions, you have to do more procedures. And I know nowadays we're actually, personally, for example, I work in 6 chairs or sometimes 7 chairs. If it's not the digital workflow, this is almost impossible. So with this, these are great benefits. And I think we said the train is moving. If you don't do that, you have to charge more. And then your patients, you'll end up with less patients because you're actually not providing. And that's compared to a solo practice. But in a solo practice, we're not talking about solo practice as a solo dentist. It's actually, sometimes we tease each other, because if you're a solo dentist, but you can do both, which is understandable.
It's a solo mentality.
It's a solo mentality. If you have a solo mentality that you approach a case, and this is, I realize it with experience, and we have the luxury in Kuwait that we're working always in a multidisciplinary center. And I know in the world it's not always the case. So if you work in a multidisciplinary center, you get the idea that when you see a case, so you don't see the case as from a point of view of an orthodontist, but you see a case from a holistic point of view, and it's much easier to approach it, and it's vice versa. If you're doing it from a solo approach, it's much more complicated. And we like to believe that we are great communicators, but this great communication didn't come quick. We had so much fight in the beginning, and then this fight became less and less. Alessandro is laughing. This is our technicians in the clinic. We fight a lot in the past. Now, with visualizing tools that we have, we fight less. I hope to say that, yeah. The outcome is always limited when, when you're doing it from single approach. So for example, in the past I used to do orthodontic treatment. Even if I'm in a setup of a multidisciplinary, I like to finish the case as an ortho case, but sometimes it's impossible. The tooth shape is not nice. Patient is looking, aspiring for a great smile that they have in their mind, but it's impossible to do it without the aesthetic touch-up after the treatment, and vice versa. If the prosthodontist wants to do it from a pros point of view, then it's also almost impossible.
I don't know how many restorative dentists are here today, but how many times it happens that you approach the case, you deliver a fantastic case in your mind, but you're not addressing the chief complaint of the patient. So he came for a proclined smile, and you're fixing the teeth, you're doing a full arch, fixing the teeth, changing the proclination, but you're not fixing how much he wanted, because you cannot, because you should remove teeth, because maybe you need to do root canal that you don't want to do. So instead, the orthodontist can fix the position of the teeth and then adjust only the small things that needs to be adjusted, delivering a more natural and better aesthetic final result. So the question, there are a lot of dentists today, so the question is, as a dentist, the moment you were a patient, if you were a patient, what would you do? What would you choose? Would you choose an approach and a treatment that can be minimally invasive, that can be faster, or at least that is, I know that could be important or not, but more cost effective? You avoid RCT, you avoid extractions, and at the end, it's personal. It's your smile. It's not a copy-paste. It's not a Kim Kardashian on a woman or a Tom Cruise on a man. It's you, in a better way. What would you choose? Most probably I would go for a natural treatment.
Absolutely.
Here we have the video of Dr. Meshari that is explaining how it works, the digital workflow in our clinic, but we have no audio, so he will talk for you.
So basically this video is just, we give it to our patients, we try to send it via WhatsApp or email before their first visit to understand the steps that we do. And then, because we thought in the beginning, because we do scan every patient that comes to the clinic, so we thought that patients will be reluctant to do the scan, but this helps that the patient is coming. Even if they're coming for a hygiene, they understand that we're gonna do a scan, and the scan is gonna be done by the assistant or some of the dentists. And with the scan, they're actually also feeling that you're actually coping with the dynamic world, that everything is advancements. We take some pictures and we upload them in the Invisalign app, because we like to have not only the scan, we like to have the photos stored in the iCloud. And this is better for also storing the data. And then we explain the treatment on the spot. While the doctor finished scanning the patients, he called me, he give me the heads up of what the patient is complaining of, and then I can show the patients the things that his concern, and also if there are, because at the end of the day, we are dentists, you want to give a holistic treatment plan, you give them a holistic treatment plan with that.
So I love this picture because I always say that in our case, we use iTero. It's a scanner, digital scanner. And the digital workflow with iTero is something great, not only because it's a great tool, as we said, it's faster, but also because it's a great communication tool. So I call it the iPhone of dentistry, because it helps the communication between the orthodontist and the restorative dentist. At the same time, it helps the communication between every doctor and the patient, because the patient can see directly on a screen what's happening. He can zoom, he can touch, he can rotate, and we will see later on a video how it works, but it definitely helps a lot the communication between dentist and the patient, and it translates the information that the dentist get during the first visit to the lab technician. And this is something, I think, priceless, because communication with lab technicians sometimes is tricky. Sometimes it's difficult because I'm Italian, so we always tend to talk about cuisine. But imagine you need to describe the taste of a pasta, of a soup, ravioli, I would say, lasagna. It's difficult to describe something. It's a matter of taste. So instead, with a tool like a digital tool, the communication is much easier and faster and actually stays recorded. So again, how it works, as Dr. Meshari said, the patient enter in the clinic and fill a form and questionnaire that can address the chief complaint. And we have a treatment plan coordinator that read the form and already knows who to refer the patient. Of course, X-rays and pictures, as Dr. Meshari said, are taken. Then finally, we take a scan. And the scan, it's definitely faster than how many of you take analogic impression. For me, it used to take 5 to 8 minutes. It depends on the kind of impression that I'm taking. A scan takes 2 minutes to take an arch. And if you make a mistake, you can repeat it quickly. You don't need to wait other 5 to 8 minutes. It's easier to store and find the file. How many times we have an emergency in the clinic, and I go to the lab. We need this case. I mean, you just, thanks to the system also, that is part of the digital workflow that anyone can use in any clinic, you find the file easily, and you can prepare a temporary, you can actually prepare a final crown if you can. So it's easier to store and find the file. It's less invasive, as we said. You have a problem. It's useful in the future because, again, you store the scan and you can use it whenever you want. And it has a very good conversion rate. As Dr. Meshari said, patients feel like they are on a space shuttle. They feel like they are doing something advanced. It's not something old dentistry like the picture I showed you before.
We like to say that we are in a world where we are driven by the chief complaint. So the chief complaint is where we are taking the treatment. So this is very important. We don't treat patients how we want to do, but with this visual tool, the patient have the chance to explain what they're really looking for in the treatment. And then we have this tool that we're talking about in the iTero, which is the Align Oral Health Suite, and it's actually gives you so many things that we use in every patient. And again, by good conversion, we are actually talking about that because the patients can visualize the problems. Here you can see this is the NIRI, where it's infrared, where you can show if there is any decay. A patient can actually visualize this in their mouth. And by the way, I don't know, lots of time in the Instagram, there is memes where you actually make jokes about dentists that they talk to you when their hands are in your mouth. Here, I realize that we don't do this anymore because you're talking to the patients, you're touching the screen and you're talking to the patients. Great communication. You can actually show the patients where we have the problem, and it's actually, we'll see here, we can see there is actually a decay over there. We can see, and we confirm it with radiographs, bite-wings radiographs. So actually, imagine every patient nowadays, when they come to the clinic, even if they're coming for any purpose, if they're coming for an orthodontic treatment, I actually give them a full comprehensive plan in less than, let's say, 5 to 10 minutes, having all this data restored. I don't think this is possible in the analog way. It needs much more comprehensive approach. Here you can see actually the gingiva, if you have any problems. My friend and colleague, Dr. Hamid Al-Qadi, he's a great periodontist. I always refer to him if I have recessions or something. In the past, for me, honestly, as an orthodontist, it's very hard to check every single tooth if there is a recession. That's the right way to do it. But with this tool, it's much more feasible and easier to be done.
Say the truth, you didn't check in the past.
Exactly.
Actually, this
only in the lower incisors, I check. As an orthodontist, lower incisors or upper incisors. That's if you're actually really pedantic, you have to do that. But in the posterior, it's very hard. Here I can check even the old restorations, crowns, if they have recessions. I want to make him happy. If I have open margin, I refer to Dr. Nicolo. And patients actually hate to see the metal margins of the crowns. So if you actually can fix this, you let the patient know, they visualize it, it's easier to do that. And then this is the occlusal gram. You're actually, a lot of time, patient comes with a problem in their bite. You tell them that, yes, you're biting on one side more than the other, one tooth more than the other. And then if they visualize it, they know that you know what you're talking about, and they're actually more likely to subscribe to the treatment. By the way, all of these things, I mean, 6 months or 1 year ago, we did not use all of this. So it's very dynamic, but it's super simple. It's everything is there now. You just need to use what is available for you, and then an overview that you can see the bite of the patients. And then with this tool, again, in a practice, I think in a private practice, the engine of the practice is that the referral system. If you have a great referral system, you're actually, patients is happy, doctors are happy, and the clinic, the lab is also happy, and the clinic runs in a very smooth way because everyone knows what he's gonna do, and it's very clear.
And as we said, they work less and they get more. That's why they're happy.
Exactly. Everybody's happy. So eventually, when you do a treatment plan, you're actually doing a solid treatment plan because you have looked at the case holistically.
Since I prepared the presentation, I put the restorative as a first slide of the treatment plan. I mean, again,
of the cases.
Of the cases, of course, because, I mean, in general, you can approach the case as you want, as a restorative, as a perio, as an orthodontist, as a GP. In the digital workflow, I started the presentation with the restorative. In this case, the patient came to our attention to change the 1-2, upper right lateral. In her mind, it was discolored. So we prepared the digital project at Exocad in our lab. Here you can see the scan of the temporary placed. I always try to see the case in black and white so I can understand if there are mistakes. In this case, for example, the lateral, the temporary is a little bit short compared to the left side. So I can communicate with the lab, take the final scan. The lab will prepare the project, and we deliver the final case. The patient is happy. We addressed her chief complaint, and the case is done. The thing that it was always in my mind when I used to think about digital is always, will it be precise? Will it cover the margin that I don't want to see as a restorative? I don't like to see the margins of the tooth or any kind of metal margin if there is. But as you can see, I do vertical preparation. Sorry, I didn't tell you. But as you can see, it's a full zirconia crown, pretty precise, and I'm very happy with the final result. Sometimes, for example, the digital workflow is useful in a multidisciplinary approach between orthodontist and prosthodontist when you need shortcuts. For example, this patient came for an orthodontic treatment, and at the same time, she was complaining about the upper left central that was discolored. So what we did the same day, I just prepped the tooth after taking the initial scan, sent the project to the lab that made for me a temporary that is cemented the same day, different color, less discolored. We worked a bit on it, and then she took the scan to finalize the case with the Invisalign provider. After that, she will deliver the final when she's done with the Invisalign treatment. Inlays, overlays, and overlays are the easiest thing to do in the digital workflow because you just need to prep the cavity, scan, take a scan of the preparation, and this is very useful, very usually you can delegate. The lab will make the project a milling in the same day, actually in 1 hour, and you can cement the final restoration. In 1 day, you finalize an inlay, an onlay, an overlay, whatever you want. Of course, it will need occlusal adjustment and so on, but in a couple of hours, you finalize everything. It depends on the lab if they want to work or not. Sometimes they are lazy and it takes a little bit longer.
This is just a quick overview of how we do it. This is my protocol in the ortho when the patient comes. Everything is straightforward after saying all of what we said. Now we take if the patients have any requests. Yes, we can take notes of that. And then if they have requests, which is in Kuwait, sorry ladies, but it's always there is wedding. So especially in this period of time, they always have a wedding. So if they have a wedding, they have special requests. They want it faster. They don't want attachments on the label. They have special requests. So we write them down. We make sure that the assistants or whomever is with you in the clinic write this down and then take this into consideration. If not, we go ahead with the treatment plan. Fixable as in orthodontic setup, not fixable. From the beginning of the treatment, you're telling the patients that, by the way, you have a discolored tooth or the shape of the tooth is not nice, you will have to go do a restorative work. So if you say it in the beginning of the treatment, imagine you say it from the diagnostic day, from the first moment that the patient comes. After 6 months of the treatment, patient is already trusting you because this is what you told them in the beginning. But if you tell them midway in the treatment or at the end of the treatment, patient is more likely to reject or feel like you're actually hiding some of the information, even if you didn't know that. And then I have just, because it's digital, because everything is prescription that you fill, and I filled it just looking at it in Invisalign every 6 months or 1 year, I have a protocol that I created. I call it aesthetic. So when I tell the lab that I want it aesthetic, they put the attachments for the anterior teeth in the back or in the lingual side of the teeth. And if it's conventional, they can put it anywhere. And then I go ahead with my treatment plan. And if there is any adjustments, I do it. And I move forward.
So everything is related, as we said, and we will keep saying that, it's related to the chief complaint of the patient. It's the chief complaint of the patient that address our treatment plan. We're not gonna fix something that is not patient's concern, or actually we try to, as much as possible, accomplish the request of the patient instead of treating it ideally as we want, and the patient will not be happy at the end of the treatment.
Done.
So when we talk about multidisciplinary approach, or especially in orthodontic and prosthodontist, we talk about aesthetic. So aesthetic is divided in macro, mini, and micro. Macro, we're gonna skip it because it's more about maxillofacial surgeons. The mini part is related to a smile, where it's defined by the lip line, the smile arch, which is the arch that is designed by the teeth that should touch the lower lip or should follow the arch of the lower lip. Buccal corridors. This is more about the orthodontist that usually can open or close the buccal corridors as much as he wants. Dental axes that have to be parallel. And then for the microaesthetic, which is more about the restorative, we focus more on small details, like, for example, the golden ratio, the golden proportion that is becoming famous. I see a lot on social media, where the central has to be 1.6 times bigger than the lateral on a frontal point of view, and the canine should be 0.6 times smaller. The zenith, which are very important to have an acceptable final result aesthetically. The dimension that needs to decrease while going distal to the smile. Inclination of the arch, which should go between 5 to 10 degrees. And then the gingival margin between central and canines that should be taller than the lateral. If you have all these factors, you're already going toward a nice looking, a better aesthetic smile. Now, all of that, here we have the dental axis and the embrasures that have to be symmetrical. Now, all of that can be summarized in a template that starts from the perpendicular line from the hollow of the nose, where the canines should be inside, and then we create the midline. Now, out of it, we can pull the lines for the golden ratio, and then lip line and smile arch. Now, all of that, I did it before Invisalign and Itero came up with something called Smile Architect. Dr. Meshar is the expert about that. Don't smile.
So basically, no, they're taking a picture. So basically, this is actually what Dr. Nicolo is accusing Align, that they're actually stole this from him, because we used to work with the lines that Dr. Nicolo just presented. Nowadays, there is this powerful tool, which is the Smile Architect. The Smile Architect, you're uploading the case with the smile of the patients, and then you can actually digitally decide on those lines not necessarily in an analog way. So Dr. Nicolo do the first part of this smile architect. He decide for me where those lines should be and where the teeth should actually lie at the end of the treatment. And then, did I click? I apologize.
I didn't.
So basically, and then I decide on where is the final position of the teeth is. And this is important because imagine all of what I said, I used to do that with my patients, but nowadays I say this and I show them in this powerful tool. So it's a communication tool, not only treatment planning tool, but it's a communication tool. When you show the patients, and when they first actually introduced this to us, I used to tell the patients that, look at this. Even Invisalign now are doing what we used to do. So this confirms that the direction that we're going is actually the right direction for treating the patients this way. And you can choose the shape of the restorations. You can actually mimic. Sometimes we mirror. You will see in the cases we do one crown, so we can actually mirror the crown next to it. And at the end, there is a button there that says mass. And the mass, there is a reduction or addition. So the patient can see that after aligning the teeth, you will have less reduction and more addition. So you're actually prepping the teeth even less. I think this tool is going to be a great factor in our treatment in the future because it's a big learning curve. We are actually sharing with you something today that we haven't reached yet the end, and there is no end. It's a journey. So actually, I think more to come and more can be done with these tools. I think this is the next coming treatment planning tool. And as we said, the chief complaint drives us, and by this we can say, for example, from an orthodontist point of view, a lot of time someone can come to the clinic, they have an orthognathic problem or a skeletal problem that they don't want to fix. They have a diastema they want to close. So usually I feel obliged to explain to the patients the problem that they have, but not necessarily enforce the treatment on them and go with the treatment that the patients would like to have. And this gives you the maximum satisfaction. And I always say, I think success in our plan, in our practice, is to give the patient the maximum satisfaction, is not delivering the most beautiful work on your personal opinion.
In your mind.
Or in your mind, exactly. This is a slide that we came up with. We will not go through it all, but we understood that from orthodontist point of view, we look at for example, the vertical discrepancy or the anteroposterior or the transverse or dentoalveolar issues that the patient have. But from an aesthetic dentist, I realized that the list is longer. So I start to see that the shape of the tooth makes big sense in the end of the treatment. So even if you do a great job as an orthodontist, you will never give the patients the maximum aesthetic. So when I see any of these problems, I refer from the beginning to Dr. Nicolo to give his opinion, even if the patient doesn't want to do it.
Since I know Dr. Meshari, I start caring about the midline. It was something I never focused on in my life, in my career. I started recently. The discrepancy, but there is never seen, guys. I mean, for me,
orthodontists, we're obsessed about the midline. So we'll go through the cases.
Finally.
Now, we'll share with you our cases. But I would like to say something before we go into the cases. I'm looking at Dr. Nicolo and he's talking about the digital. I'm fascinated because this man, 3 years or 4 years ago, used to be completely against this. So the reason why I'm sharing with you this is first to tease him, and second is to tell you that even if you have the same point of view, even if any of you think that digital might not be precise or might not be the future, he's an example. His father, peace upon him soul, he just actually did 25 or 30 years of analog, and we had a fight with him and his father about, let's move to digital, and the argument was, no, it's impossible, the microns, the precision, he used to do precious metal or metal ceramic, and it's actually a big debate. Nowadays, he's in the stage talking about something that 3 years ago was completely out of our comfort zone. Thank you. So actually, this is Fawaz, he's not happy about his smile, and he came to me actually. From an ortho point of view, it's a very straightforward treatment.
They always come to him. They never come to him.
Used to be. Nowadays, all the patient comes to him. So I discussed with Fawaz that the treatment is straightforward from an orthodontic point of view, but he has this incisor that has an old filling that will definitely not change, and the shape of the tooth actually will not change in the orthodontic treatment plan. So if you picture that your teeth, when they're straight, this tooth is going to be looking much better. It's going to look straight, but it's not going to solve the problem. So what I did is I already gave Fawaz an idea that this tooth is going to need a veneer, and then I proceed with Invisalign. As you can see, 23 aligners, which is less than 6 months, probably 5 months of treatment. For orthodontists or people who use actually Invisalign, most of the attachments here, as you can see, just probably on the 7 are optimized attachments. And optimized attachments, they come from the system. So this is actually probably the second treatment plan that I approved. So I haven't done much in the treatment. It's much more simple approach. And then at the end of the treatment, this is how he looked like. There is a slight gap distal to the upper right central incisor. So I refer it to Dr. Nicolo to deal with it.
So as a restorative, it's much easier to approach this kind of case because I just need to restore the 1-1. Now, when I talk like that, they look at me, yeah, it's easy. Yeah, I mean, lab technician will do his job, the dentist should do his job. So anyway, we decided to restore only the central to have a better natural look. This is the upper occlusal view after the orthodontic treatment. And here you can see before prosto, but after ortho, and after the single veneer on the 1-1. There was something, the tooth was still proclined, so again, it's not a waste of time. Refer back to the orthodontist, please fix the position.
So we do that as well. If we have any problem, that's what we said. If you are actually approaching cases in a multidisciplinary way, you can always go back to do some adjustments, and the patient's already having 95% of the treatment done, and the patient is happy and willing to go with your plan.
So here is Fawaz's final smile. Comparison before ortho, after prosto.
I like to always vote here. Is it the orthodontist work that made a difference? So 1 to 2 is better, or who thinks 1 to 2 is better than 2 to 3?
But keep in mind that keeping it this way, it would still look bad.
So 1 to 2 is better, or 2 to 3. I'd like to say that there is big change in both ways. So one of the tools that we use in the digital, I actually use nowadays, almost nowadays, all the cases, I show them the face visualization, which he can see the after treatment in face visualization. So I like this case. This is Thamer. He actually, when he saw this, he signed up right away because it's a huge difference and big change. And actually, nowadays I use it for all the patients, but one trick is that don't show the patients from the beginning. So the scanner should be on your side because this is done by the scanner. Just once you take the scan with a picture, you can see this. I keep it on me. If the result is actually, because sometimes, the AI never give you the precise thing. Sometimes it gives you a wrong picture. You don't show it to the patients because it will make the situation worse. Patients will have doubt. So I say it. If it's a good result, I show it to the patients, but I do it for all the patients.
That's ala tool. It's right to say ala tool.
Exactly.
Haya.
Haya. Again, Haya came to me to do orthodontic treatment because I did for her mom. But looking at her smile, she doesn't like the bottom teeth, and she feels that her smile is uneven, but it doesn't have to do anything with orthodontics. So I already explained to her that I can actually treat her lower incisor crowding, but the uneven smile is more related about restorative and perio involvement if needed. So that's how she looked like. Very simple, very straightforward. And again, you will realize that all the cases, now we'll go to more complex cases, but from my end, I feel the case is simple. From Dr. Nicolo's end, he feels the case is simple, but I think it's simple because we're actually, each one of us is doing half of the treatment, and then the treatment becomes holistically easier. But if you're actually trying to solve the problem in a solo approach, it's much more complicated.
Because simplify is the highest way of sophistication.
Wow.
So, mashallah.
So Haya is only 12 aligners, and again, all optimized attachments, so I didn't actually change much in the treatment. I tried to, as he said, improve the center line and just slightly reduce the overjet, and of course, align the lower incisor, which is her main concern. And I can say, in this case, the pros work is much more important. So I give it to you.
Grazie. So here you can see the intraoral photos after Invisalign treatment. We decided to change the 6 anteriors. This is after ortho. That's the final after prosto. Sorry, Pirio, the picture was taken after we removed some cement on the upper right lateral. So there is some inflammation of the gum, but overall, I think it's a nice result. At the pretty natural. Patient is super happy. The mom was supposed to do veneers. She didn't approve yet, but maybe one day she will after this result. So here you can see before ortho, and after prosto. Thank you for saying that. The best improvement from my side.
Hello?
Ahmed?
You got 5 minutes.
Yalla.
Okay. So Ahmed came with, he doesn't like the appearance of his teeth. We'll go through the cases fast. We like to show you all the cases, but what we want to show is that in this case, in a comprehensive way or in a multidisciplinary way, it's much easier. So I align the teeth, refer it to Dr. Nicolou, and then made it possible that with only 6 veneers, we reached, again, very short treatment.
19 aligners. This is the final intraoral photos after Invisalign treatment. Straightforward. Occlusal view. And we change 6 upper teeth. That's the final result. Mr. Ahmed is happy, and we are happy as well. Comparison between, this is how he started, this is how he finished. It squeezes a little bit the picture from what I see from here, but anyway, I mean, that was his concern. We fixed this concern. That's it. Of course, we adjust a few things more. Dr. Meshari loves this case.
We'll finish with this case, probably.
Okay.
So Mohammed came. He doesn't like his smile. This is an extremely difficult case, or a scary case when you first see it, because it's actually, when you look intraorally, he has an anterior open bite, spacing, proclined incisors, some perio involvement. So it's quite challenging. However, again, in a multidisciplinary approach, it's much easier. Already, Mohammed knew that we will do it in a multidisciplinary, so we're doing some restorative work after the treatment. And we'll just go through the process again. Straightforward Invisalign treatment. We just retract and extrude the incisors. That's him after the treatment. Nice result, but nice result from ortho point of view, but it's not a beautiful smile at all.
So we fixed 2 veneers on the 2 anteriors.
It is, we like to do it conservatively, and I think the patients already have a very drastic change. He's always saying, he keeps coming, this is 2 years or 3 years ago, he keeps coming and saying, the Duania, they call me a liar. They say, you fixed all your teeth. It's impossible that it's only 2 teeth.
And by the way, he speaks only Arabic. I don't speak Arabic, I mean, just a little bit. And the communication was made through the digital, and thanks to Dr. Meshari, that sometimes translates as well. But patient, I mean, to address the chief complaint of a patient that doesn't talk your same language, I think it's something crazy, especially for an aesthetic dentist. So the moment you achieve a good result and the patient is more than happy, I think this is the best result you can get out of your profession.
You have 2 minutes. 2 minutes.
Can we do another case?
2 more?
2 minutes.
I was having fun. So this is before ortho. After ortho, I have to say that was already a nice case, but we fixed it a little bit more. So you won this one.
Okay. Another tool, and we will end with this. The other tool that we use, again, in the digital, because a digital transformation is not only digitizing the clinic, but to use this data to help you achieve your results. This is called the progress assessments. In the difficult cases, I like to divide the journey of the patients into quarters, and every quarter I take a scan to make sure that the plan is tracking. So in this case, same case that we saw the other feature, which is Damer, I can see that all the teeth are actually tracking where I want them to be tracking. Some of the teeth are not tracking in the back, but it's not important because it's a premolar that needs more rotation adjustments. I do it at the end. So there are so many tools that are in the system to be used, and using those tools actually give you a differentiating factors with the treatment, with the patients.
You still have 25 seconds.
We end with the progress assessments, and let's just go to the last slide to thank you all for being here with us today.
Thanks a lot.
We like to say that we have a workshop coming, and if anybody is interested, we can drop us an email or call us the end of the year, inshallah. Thank you so much for your attendance and
Shukran.
for a great presentation. Thank you. Thank you so much. Please, questions.
I think we have question and answers.
Thank you guys for this fantastic presentation, and thank you for sharing your experience. Any question?
Yes.
How did you see him? How did you see?
Thank you so much for this amazing presentation. Just one question. Can you clarify more about the relationship between the digital concept and doing less endo, and give us like more examples?
Less endo?
Yes.
Basically, when you do the planning in the digital, you're actually, so in general, if you do a multidisciplinary, you're actually doing less endo because you're actually moving the teeth in the right position. The last case we show, Mohammed, the teeth are very proclined. If Dr. Nicol were to do it without orthodontic treatment, it's actually almost impossible, or there will be extraction or maybe root canal treatment. But using it in the digital way, you're actually knowing what to do. You know what's the final position of the teeth, because even if the tooth is 2 millimeter advanced or something, you will actually end up with root canal treatment. And I think prosthodontist knows better, but I think most of the cases need elective endo in these scenarios.
It's basically do the movement, do an orthodontic treatment, but prosthodontically. So if you need to move a tooth without an orthodontic treatment, definitely you need to do a root canal because you will touch the pulp during the preparation. Thank you.
Any other questions?
Any questions?
Thank you so much.
Thank you very much, our speakers.
Thank you.
And we're happy to present you with appreciation from KDA conference.
Thank you. Thank you. Thank you.
We'll
do it together.
Thank you. I'll keep this one.
Thank you.
Thank you. Thank you. Thank you. Thanks a lot.
Hello? Guys outside, come here. Guys in the coffee break. Okay. Zain, I will start now. Our next speaker is Dr. Mona Al-Awadi. She will be talking today about beyond traditional aligners, innovations in digital orthodontics. Dr. Mona Al-Awadi is a board-certified orthodontist currently working at the Ministry of Health. Dr. Mona Al-Awadi earned her DDS from Dalhousie University in Halifax in Canada. She completed her orthodontic residency and master's at the University of the Pacific, San Francisco, California. She's also a diplomat of the American Academy of Dental Sleep. So let's welcome Dr. Mona Al-Awadi.
Thank you for being here today on a Friday. Inshallah, it'll be a good flow from Dr. Mshari and Nicolo's lecture. So I'm going to be talking about innovations in digital orthodontics. So we're going to go over 3 different topics. The first is indirect or in-house aligners. I'll use those terms interchangeably throughout. Then we'll talk about direct printed aligners. And then finally, digitally designed appliances. So why are we talking about aligners? There is an increase in patient demand. They're coming into our offices asking for aligner treatment. It's a good option that provides improved aesthetics compared to traditional braces and improved oral hygiene. It also is a good option in terms of increased comfort, and we do see market trending and increased revenue. Also, it's less chairside time for you as a practitioner, so this is a good option for someone in a busy practice. So we can see research has shown that there is an increase in demand for more aesthetic option as people are asking for aligner therapy. And we do see an increased demand throughout our region as well, with the highest during the pandemic, as people were more reluctant to go to an orthodontic office for regular visits of traditional braces. Also, we see that the biggest generating revenue in 2023 was adult age group, but we see a trend in teens, and they're the fastest growing age segment. So here we have 2 charts showing the Kuwaiti clear aligner market, and we can see an obvious increase in the market revenue. And they predict between 2024 and 2030 an increase of about 30% in market revenue. The bottom chart is Middle East and Africa clear aligner market, and we also see a very, very similar trend to the Kuwaiti clear aligner market. Also, clear aligner therapy, with that treatment, we see a decreased risk in white spot lesions, mainly because we see that we have shorter treatment durations and improved oral hygiene, because the patients can remove their aligners, they can better clean their teeth, so we see lower levels of plaque. So the first topic I wanted to talk about was in-house aligners. This is a great option to the typical conventional aligner companies that we're used to. They provide decreased costs, so you're no longer slapped with a huge lab bill associated with your aligner therapy. It provides a customized treatment plan and a much faster turnaround rate. So there's less back and forth with your technician. You no longer have to wait for manufacturing and shipping times. So this is the manufacturing process. First, we start by scanning the patient, and we can use any scanner you have in your office, so you're no longer limited by the brand of scanner that you can use, whatever is available in your office. Then you do your virtual setup, print your models, and then do the thermoform. And these are just a couple of the treatment planning softwares out there. There's no right or wrong in terms of treatment planning software. It's just whatever you prefer using. So try out a couple of softwares and see which one you're most comfortable with. So most treatment planning softwares will prompt you to start by trimming your models. And I suggest removing any data you do not need for your print, because you don't want to waste time and you don't want to waste resin on unnecessary data. And then you'd go on to segment the teeth. Usually this is an automated process, but you can see here from the video, it did not detect one crown, so you just have to go back and adjust the outline of that tooth. So this is the fun part, is the actual virtual setup. You can move the teeth individually, like you can see in the video, or you can ask the software to auto-align the teeth for you. There are other features like sequential distalization, there are bite shifts. And I do suggest using a checklist to review your treatment plan. So we go through the planes, so we go to the transverse, sagittal, and then the vertical, and then check your final tooth position. And once we have our final tooth position, we can pick the appropriate attachment we need for that movement. So most softwares, they have a pretty vast library of attachment shapes. You can change the location, you can change the size, you can change the torque of the attachments that you use, depending on what movement you want. So I think one of the most important features of these virtual softwares are being able to do a diagnostic setup with them. This is the most powerful feature. So let's go through this example. Is a 26-year-old female. Her chief complaint was lower incisor crowding. She was class 3 molar canine, right and left sides, with minimal overjet and overbite, and moderate mandibular crowding, minor maxillary crowding. She did not want treatment on the upper arch, so we're focusing on the lower arch. Our two options were extracting the lower right 4 or the lower left incisor. So this is the first treatment simulation. We can see the lower right posterior segment drifting forward into more of a class 3 position as we're closing up the spaces. Our second option was doing the lower left 1 extraction. You can see the opposite happening. So our lower right posterior segment is distalizing into more of a class 1 relationship. So there's no right or wrong, it's just whatever your goals are, and you can pick whatever biomechanics you would want to use in these cases. But here, for this treatment planning simulation, we went with a lower left incisor extraction because we had minor maxillary crowding and pretty significant lower incisor crowding. So once, it's just a suggestion that if we do extract a lower left 1 or lower incisor, you want to put the largest vertical rectangular attachments you have, because you want the aligner to grip as much of the tooth in order to control your roots as you're closing up the extraction spaces. So I just wanted to go over a couple of in-house aligner cases. This is a 24-year-old male with a chief complaint of closing the diastema. He's class 2 molar canine, right and left sides, with a deep overbite, excess overjet. He has minor spacing in the maxillary and mandibular arches, and the lower midline is shifted 2 millimeters to the left. These are the occlusal shots. You can appreciate the spaces and the rotations, mostly on the anteriors. But the patient only wanted to address the midline diastema. He was not interested in wearing elastics. He did not want extensive treatment. He expected the treatment to last for a couple weeks only. So he wanted to close the spaces as quickly as possible. So this is a simulation. You can see we're closing up the spaces by retracting the incisors, and we're trying to maintain the torque on the incisors because they're already upright. But I didn't add any more crown torque to those incisors because it's counter-effective to closing up the spaces. And this is the patient back after 4 weeks, 4 aligners, and 1 week changes. So you can see already a huge improvement. The diastema is already closed. You can see here, it's a better look. The diastema is closed. Most of the spaces have closed as well. We can look at the occlusal shots. So we already achieved the patient's goals in 4 weeks only, and 4 aligners. He still has some remaining spaces on the lower arch, but we're still only halfway through the treatment. The second case is a 40-year-old female. Her chief complaint was wanting to fix the front teeth. She had a history of limited clear aligner therapy, but she never wore her retainers. So obviously, her incisors relapsed. She's class 2 molar and canine, right and left sides. And she has these rotations on the central and lateral incisors. And that's what she wanted to address. So after 3 weeks and 3 aligners and 1 week changes for each aligner, we can see pretty significant improvements already in the rotations of the teeth. The patient's very happy with the results so far, but we're only 25% through treatment. So I wanted to present these cases just to show you that there are options to give our patients with these minor relapse cases or anyone with minor rotations. You can opt for in-house aligners. So I want to go over and conclude that with in-house aligners, some of the advantages we already discussed. It's a decreased cost, so you no longer have to pay a huge lab bill to an aligner company. It's a customized treatment planning, so you get to work on it from the beginning to the end. And it's a faster turnaround rate. Some of the disadvantages, it does require training of staff, new equipment if you don't have a 3D printer, ongoing maintenance, like the same as you do with any other equipment you have. It does have a learning curve, and it can be time-consuming if it's not delegated to the proper staff. So the second topic I wanted to go over was direct printed aligners. Basically, this is a new approach to in-house aligners, where you print the actual aligner itself, and you no longer need the models or thermoforming the aligners. So what this does is it reduces the waste. So you're not printing a resin model and then throwing it out. They do claim it's an improved turnaround rate, but if you look at their post-process, there are several steps involved in it. So you're not sure about that point. It does provide greater control over the material dimensions, and it decreases inaccuracies associated with printing a model and then doing your thermoforming. So what it is it uses a photopolymerizable resin with a digital light processing printer to print a material that's appropriate thickness and elasticity for aligner use. So I wanted to discuss the differences in fit between the thermoforming aligners and the direct printed aligners. In a thermoform aligners, the studies show a discrepancy between 0.05 millimeters and 0.65 millimeters. What that means is once I print a model and then I make my thermoform aligner, the discrepancy between the two, so the differences between the two are up to 0.65 millimeters. So let's say I prescribe as a movement of 0.25 millimeters. That might not be clinically significant because of the huge discrepancy associated with the process of thermoforming. So let's compare that to direct printed aligner fit. One study here compared the direct printed aligners with 2 types of thermoformed aligners, the A6As and Zendura Flex. And they saw that the discrepancy between the master STL mesh and aligner mesh was greater with the thermoformed aligner than the direct printed aligners, meaning the direct printed have a greater precision. So you can see here on the scatter plot, all the discrepancies are under 0.5 millimeters, whereas with the Essex and Zendura, the data is kind of scattered. But we do have to take these results with caution because the reduced dimensional accuracy of the thermoformed aligners may be associated with the actual process of manufacturing. Also, it's difficult to correlate in vitro studies with actual performance of an aligner. And there can be scanning inaccuracies associated with this paper. I I also wanted to discuss some of the effects of the actual thermoforming process on the aligners. So what it does is it increases water absorption of the aligner, and that increases the surface hardness. It also makes the aligner much thinner, and you can see discrepancies in the thickness of the aligner. So some areas can be thick, some areas can be thinner, so it means that the force on the teeth can be unpredictable. And that's not something you cannot control during that process. Also, removal of the aligner frequency and the magnitude of activation can influence the generated forces. As well as the thermoplastic-made aligners can be reactive to the intraoral environment. So body temperature, humidity, and salivary enzymes can modify the aligner dimensions and mechanical properties. So in contrast, we look at the properties of direct printed aligners, is that it has shape memory. And that minimizes the undercuts because it responds to temperature. So we put the aligner in warm water. Patients can more easily insert it and remove it from their mouth. And it minimizes the amount of blockout we're using, so you can maximize the orthodontic force on the tooth. So this is a cool feature of direct printed aligners. They have robotics. So these robots obviously decrease human error, and they increase your efficiency during this manufacturing process. What they do is they start the printing process. They can remove the build plate from the printer and replace it. They remove the aligner from their build plate, and they can put the aligners in the spinner and cure the aligners. So just to summarize, some of the advantages we already discussed of direct printed aligners is you no longer need the 3D model that you printed, and you don't need to do the thermoforming. It has shape memory. It's a more accurate fit. The thickness of the aligner is controlled since you print it out. There's less need for blockout due to the shape memory. It provides a light continuous force. And you can customize the aligner's design. So for example, the outlines of the aligner can be either straight or scalloped, and you can possibly use less attachments for this type of treatment. The disadvantages is, since they don't provide an attachment template, is you need to place the attachments before you scan the patient. There's also a long post-process. It's technique sensitive, and there are more steps in the digital setup. So in conclusion, there are many factors such as material properties, biocompatibility, and force systems delivered by the direct printed aligners that need to be examined before we can make clinical recommendations regarding this new technology. The last topic I wanted to talk about was digitally designed appliances. So digitally designed appliances are fully customizable to each patient's needs. Typically in dentistry, the most common printed materials we have are resins, nylons, and metals. So what we print usually with resins are models, obviously, mouth guards, splints, surgical splints, so they can be for TODs, they can be for restorative implants. You can print indirect bonding trays. And you can see the bonding tray here at the bottom. And then with nylon, typically the most common printed device is the mandibular advancement device. It's used for obstructive sleep apnea patients. Those that cannot tolerate a CPAP. So this is a great alternative for them. And the last material we print with are metals. You can get as creative as you'd like with metals. You can basically print anything you want, but the most common appliances are expanders, distalizers, and TPAs. So this is an example of how crazy you can get with your design. These cases are from Dr. Audrey Yoon. She practices in California and is a faculty member at the University of the Pacific. She does a lot of adult MARPI cases. So for example, when she needs to use more than 4 TADs, here you have examples of expanders with 6 to 8 TADs that are being used. She can place them anywhere she needs in the palette. She also has some auxiliaries here. If you can see on the palette, she has intrusion arms on the palette, and she has those same arms on the buckle. And she also can put buttons here. So it's fully customizable to your specific patient needs. And you can see here, each expander looks different because it's specific to each patient. In contrast, you can create something as simple as a TPA with hooks. So this is impacted canine case, upper left 3 is impacted. All we needed was a TPA and a hook, so it's pretty simple to design that. And finally, just wanted to show you a video of how to design these appliances. So we start by placing the TADs. The good thing here in these softwares is you can place the TADs anywhere you want. So you're no longer limited by a stock expander where it tells you where you have to place the TADs. You get to pick your expansion screw. So in this example, we used a Tiger screw, which is the most robust expansion screw out in the market. But you can pick whatever expansion screw you like, for example, a Hyrax. And then you can make the support arms as wide as you want, as far away from the pallet as you'd like, as thick as you want. So it's fully customizable, and you can add things and auxiliaries like these intrusion arms. You can see here, these intrusion hooks. Finally, I just wanted you to kind of think about your treatment options. We're not limited to the business models of big companies, so we want to cater to our patient-specific needs. So we have a lot of alternatives, like using these softwares and using in-house aligners to provide our patients with the best treatment possible as healthcare providers. And feel free to contact me by email if you have any questions. Thank you.
Thank you, Dr. Mona, for your insightful presentation and great lecture. Now we would like to hear from your questions from the audience. Any questions?
Thank you, Doctor, for a nice presentation. My question is, what is your experience with the in-house aligner? Which software you have used so far?
Sorry, what?
In-office aligner.
What did I use?
The aligner, you are using the in-office aligner.
What software?
Yeah, which software?
I used a lot of different softwares. You can use Dent1, Archform, Maestro 3D. I tried them all, and then, because I don't want to like push a certain company, but I started by trying out a couple, and then whichever one suits me best. So a lot of them have free trials. So I would suggest try a couple. So like Archform, Dent1, or Maestro 3D. You can get like a free trial, try them out, and see which one you're most comfortable with. But they basically all do the same thing. It just depends on your preference.
But I heard some softwares are not customer-friendly, user-friendly.
Yeah.
It's difficult to learn.
Yeah.
So in your experience, not for the company's sake, from your experience, which one you suggest for a beginner to start with? Which software?
I use Archform.
Archform, okay.
Yeah.
Okay, thank you, Doctor.
Yeah.
Questions?
Okay, thank you. On behalf of KDA, we would like to express our sincere appreciation to Dr. Mona Al-Awadi for sharing your expertise and insights with us today.
Our next lecture is going to be at 3:30.
هنبلش لا
Our third speaker for this afternoon is Dr. Fatma Al-Kandiri. Dr. Fatma Al-Kandiri is an orthodontist and cleft and craniofacial specialist, completed her undergraduate studies at Kuwait University. She continued her education at King's College London, obtaining her master's degree and specializing in orthodontics. Dr. Al-Kandiri further specialized in cleft and craniofacial orthodontics, in addition to special needs and medically compromised patients. She has several publications along her career, currently working at Bnei Delgar Specialized Dental Center and Farwania Specialized Dental Center. Please join me in welcoming our speaker. The stage is yours, Doctor.
Good afternoon, everyone. Thank you for the introduction. Today's lecture will be about cleft lip and palate, the journey from birth to adulthood. So this is the treatment journey. We usually see the patients from their birth, sometimes even before they're born. We talk to their parents until their adulthood. I'm going to go through these stages in this presentation. So the outline is definition, etiology, and incidence and development of cleft lip and palate, and then examination and diagnosis and classification. Also, in addition to that, we will go through the multidisciplinary approach and at the end, the orthodontic management. And the last bit would be about clinical cases, explaining those didactic presentation. So the definition of a cleft lip or palate or alveolus is the failure of joining properly during fetal development. The etiology of the cleft lip and palate is polygenic and multifactorial. It's environmental and genetic, both of them are involved. And it can be syndromic and non-syndromic. The usual syndromes that are associated with cleft lip and palate are Pierre-Robin syndrome, or sequence, and van der Vood syndrome, and Treacher-Collins syndrome. So the etiology of cleft lip and palate, the environmental factors would include drugs, alcohol, smoking, diet, viral infection, and teratogens. The genetic factors, it's usually polygenetic, multiple genes could affect, and it's multifactorial inheritance. So the home box mutations like MSX1 and growth factors, transcription factors, and genes involved in nutritional metabolism also involved. So the incidence of cleft lip and palate, I divided it according to ethnicity, gender, and syndromes. According to ethnicity, it's more common in Japanese, and then Caucasians, and then Afro-Caribbeans. The cleft lip and palate is, the incidence is 1 in 1,000 live births. In Asians, it's 1 in 500, and in Africans, 1 in 2,500. The cleft palate is 1 in 2,000 live births, and there's no significant racial differences. The gender, it's double the amount in cleft lip for males, and cleft palate is more common in females. According to syndromes, 70% of the cases of cleft lip are non-syndromic, while 50% of the cases of cleft palate are non-syndromic. The local data analysis that has been done by Dr. Al-Hayyan, the data were collected from 2009 to 2014. It was retrospective assessment for the incidence of the cases. In total, there were 203 cases. 109 were males and 94 were females. The Kuwaitis were 109 and non-Kuwaitis were 92. And consanguinity, which means mom and dad are relatives and or cousins. 107 of the cases were not related, and 77% of cases were related. Facial development, it starts from 4.5 weeks till 7 weeks, the area that are involved in the lip and palate formation. So the lateral nasal process and the maxillary process, all of them, they usually start laterally on the side of the face. And then through development, by the 6th week, the maxillary process migrates medially and fuses with the lateral nasal process, which makes the ala of the nose. And then later on, about 7 weeks, the medial nasal processes, they also migrate even more medial to form the philtrum of the upper lip and the medial part of the nose. The embryonic causes for the cleft palate is the palatal shelves in the upper arch. It's either they don't form at all, or they form, but usually when they start forming, it's in a lower position. So they have to go up, grow, and fuse. So in any disruption of those stages will affect the palate, causing the cleft. Classification of cleft lip and palate is several classifications are present, and specific description of each individual case is recommended. And we've got clinical presentation is so variable between patients. So examples of classifications would include Curran and Stark classification that has the numbers listed. So you start from the right side going to the cleft palate and then to the left side. So we've got the lip, which has number 1 and 4, alveolus 2 and 5, and primary palate 3 and 6. And then we start with the hard palate 7 and 8, and soft palate is 9. And there was a modification of that classification that added the nasal part. This is the nasal floor, and the nose has been added to this classification. And it's called Millard classification. Millard modification, sorry. And then we've got the Lachal classification, which it's relatively the same thing, but it's more simple. That has the lip, alveolus, hard, soft palate, and then alveolus and the lip on the left side. So for this classification, how do we assess? Usually we start from the patient's right side, always start from the patient's right side. And then if we're writing the letters, it's either capitalized, which means complete cleft, or small letters, which means incomplete cleft. And then for the areas that are healthy and not affected, we would just put a simple dot in that case. For example, the example that I have has 2 dots, H, which is hard palate, S, which is soft palate, and A and L, which is alveolus and the lip. And since we started them later on, which is the left side of the patient. So this would include the patient would have a complete cleft lip, alveolus, palate on the left side. Classifications of the lip, we've got several classifications involving starting from a notch in the lip to incomplete, to a complete cleft, being unilateral, bilateral, and affecting the nose as well. The classifications of a cleft lip and palate, as I mentioned, all of them, well, the easiest way to know if there is a cleft, is it complete or incomplete? Is it unilateral or bilateral? And then you can assess and put all of those details. And which part is affected? Is it the nose? Is it the lip? Is it the alveolus or the palate itself? So classification of the palate. So of the Vogue classification, that has the soft palate only for number 1. 2 would be hard and soft palate. 3 would be unilateral complete, and 4 would be bilateral complete. There's other facial clefts or facial clefts that can present. So as we said, the cleft lip, unilateral lip, bilateral lip, median nose, median cleft, and then oblique, that has the side of the face, and then the median cleft in the middle of the nose, and the lateral cleft on the side of the nose, of the side of the mouth, and then the mandibular cleft that is in the middle of the mandible. The oral features that are associated with the cleft patients, they have hypodontia and supernumerary at the same time. We've got microdontia, impacted canines, delayed dental eruption compared to their peers, and hypoplasia in most of the cases, malformed teeth, there are dilacerations, maxillary midface retrusion, higher susceptibility to caries, and usually they present with cross bites, both anterior and posterior, especially if the palate is affected, or the alveolus. And then central line discrepancy that is usually toward the cleft side. There is a large team working on those patients. So we've got the medical part of the team that has plastic surgeons, ear, nose, and throat surgeons, speech therapist, cleft nurse, pediatrician, psychologist, audiologist, geneticist, and nutritionist. When it comes to the dental team, usually we've got the maxillofacial surgeon, orthodontist, pediatric, restorative, general dentist, and general dental practitioner, and also I forgot to add, sorry, the prosthodontist and periodontist, which they are very helpful, especially at the last stages of the treatment. So the treatment journey, we're starting from prenatal. About 20 weeks of gestation, usually the patients are diagnosed, especially if it was affecting the lip. They can see that with the 3D sonography, with the new development of sonography. We can see that. And once the parents are, they know their child has a cleft early on, they usually contact us, or their gynecologist usually refers them to us, or they can discuss it with them as well. So they just need reassurance, especially if they don't have anyone else in the family that is affected with cleft. Prenatal counseling, they need talking to parents who like have children with cleft. They went through the experience just to let them know what happens. And then from the scientific point of view, we just go through the process with them and break down what they need from that moment on. And if they have any questions, we can answer their questions. Once the child is born, till they're about 5 months of age, if pre-surgical orthopedics is recommended, we can start with that treatment. So first of all, once they're born, we do a full assessment. We evaluate them at birth, and then add the patient to the registry that we have in Farwaniya Hospital, as our cleft team is there. And we need to send them to different specialties if they haven't been sent already from their pediatrician. So we send them to genetics, audiology, ENT, plastic surgery, pediatrician, and feeding specialist. When it comes to feeding, it's difficult for the child to feed normally, especially if they have cleft in the palate, because there is negative pressure in the mouth. They cannot drink their milk. There's no suction inside their mouth, so it's difficult to drink the milk. So it's recommended to use this Herbermann bottle that has a long teat. It's soft at the tip and long, so it can go all the way to the end of the throat, so it prevents them from regurgitating or aspirating the milk, or it goes through their nose, so it goes directly to their throat and ease the feeding for them. Usually when we feed them, they should be relatively upright, about 60 to 90 degrees, so to make sure that the milk doesn't go through their nose, and make sure the baby burps after feeding, and when they sleep, to sleep on the side to prevent any aspiration. Pre-surgical orthopedics, the aim of that treatment is to modify soft tissues and the alveolus, and it's composed of plates and lip strapping. The mode of action, we use lip taping or strapping, and then the tension production from that is used to approximate the soft tissues, and then we retract the anterior alveolar segment back with the force of that tension. And then the acrylic plates, when they're used, it's either used for obturation, but it's not recommended to only use it for obturation, and encourage approximation of the alveolar shelves by grinding the acrylic that when we place it in the baby's mouth. Nasoalveolar molding, the NAM appliance, it has been developed by Grayson in the early 90s, and modified the orthopedic appliances in a way that added the nasal stent, which improves the nasal cartilage early on in their life, to improve the anatomical form, to have a better results post-surgery, which is the lip closure. The pre-surgical orthopedics, the advantages and disadvantages, it's not a must to use it in every single case. It's still a controversial topic in the field to use it or not, just because of several reasons. So the advantages of that is it improves feeding, better middle ear condition and speech development. It reduces the complexity of orthodontic treatment later on, and psychological support for parents, because they feel that they're doing something for their child, especially when they're at their early life, that they're doing something for their children, and facilitate the surgery. And for aesthetic and symmetry advantages, especially for bilateral cleft cases, the premaxilla sometimes could be lateralized, so we just try with the appliance to bring it to the middle. The disadvantages of that is very time consuming and cost for like the travel expenses. It causes maxillary growth restriction, requires frequent visits for adjustment and grinding, and it might be overwhelming for the parents, and also the complexity of straightening the nasal septum. And it has, according to studies, it has limited impact on the shorter or longer term. But as I said, it's a very controversial topic because the quality of the studies are not the best to assess. Most of them are retrospective. There are no controls, and it depends on several conditions to decide on this conclusion to use it or not. Moving on with the treatment journey, once the child is ready after the orthopedics to prepare them for the lip surgery, about 4 to 6 months, the lip surgery is done. This is a video of a lip surgery, but the child is a bit older in age, so the technique is just remove the excess connective tissue that has been trapped in the lip and correct the lip aesthetically, rather than like doing the procedure from the beginning. Just to give you an idea, so usually they do the marking points of the lip, and then they do their incisions, they remove the excess tissue if it's needed, and then they suture. The nose surgery that has been done, it's to correct the cartilage of the nose, to elevate the ala of the nose. According to Dr. Hisham, who did the surgery, it's a new technique that he's using, so I'm not sure about the research and everything behind that. But if you have further questions, please feel free to ask me later on, and we can guide you through that. So when the patient is about 10 to 12 months of age, we do the palliative repair. At the same time, since they're going to a GA surgery, so we do the ear tubes at the same time with the ENT doctor to collaborate. This is an example of the palatal surgery. So what they do is they do the intravelar viloplasty, which is basically rearranging the palatal muscles, and then once they're rearranged, sutured, and then they close the palate. So on the side, there's no tissue. They just approximate the palatal tissues and leaving the sides, and it heals by itself. About the age of 18 months, we do the first speech assessment. And then, because about that timing, the time of the cleft repair is done when the child is starting to babble to begin with, because this is when the sounds are coming, and it's difficult to produce the sounds correctly with the cleft still open because they have hypernasality and connection between the mouth and the nose, and there's air escaping through the nose, so the letters are not great, and especially if they have recurrent ear infections, it's difficult for them to hear as well. So we need to manage that around the time they start developing their speech. So speech development, as I mentioned, it usually affects the P and B sounds, and they change them to an M sound. They have hypernasality and frequent occurrence of otitis media. The child's communication is usually disturbed for the cleft cases because they go for regular attendance for their hospital appointments, or they might be hospitalized having surgeries, and the regular outpatient appointments. So they're usually Mom and dad will be overwhelmed and don't have enough time to talk to their kids and sit down with them. And once they do, it's just basically they care for them too much. They forget that they need to treat them like any other kid. Audiology hearing assessment must be done before any speech therapy, just to make sure that if they can hear correctly, to be able to basically understand or talk to you back. And the follow-up, usually do that at the assessment is done at birth, and then they do a follow-up about the age of 8 months, 2 years, 5, and 10 years. So speech therapy, as I mentioned, it's to eliminate the hypernasality. Sometimes just need to teach the child how to get the phonetics out. It doesn't necessarily need a surgery at that time for speech. And then they can also, for a diagnostic test, they can do a fluoroscopy, video fluoroscopy, and nasopharyngoscopy as well. If they need a surgery, it might need to do a pharyngeoplasty, which is the pharynx at the back. They need to lengthen the pharynx to be able to reduce the nasal emission and the sound. Fabrication of NAM. So basically, we used to have heavy body impression. We don't use alginate for babies at all because they just get stuck in the cleft and we cannot take it out. It can be done under hospital setting, and someone has to be there for emergencies just in case if the child inhale or aspirate or anything happens, or they just need assistance in terms of breathing. The new technique is doing a scanning. We started using a scanner in our team, in our department, and that would be using just an intraoral scanner regularly, and then once we're done, if either use the impression or the scanner, we have to make the cast. From the cast, we make the NAM appliance. And this is how it looks like. Those photos are not related to the same patient, just to give you an idea of how it looks like. So the NAM appliance, this is just a demo for teaching purposes. So basically, it is made of acrylic, and it has retentive arms with a nasal stent that has a metal, it has a 0.9 millimeter of stainless steel wire that is added to the acrylic. And then we do the wire bending depending on the size of the patient face and do the measurements. In addition to that, at the end, we add the kidney shaped, which is made of soft acrylic to be able to elevate the nose. There is a dynacleft, which is this thing. Basically, it's only used to elevate the ala of the nose. Just for the cases that we just need to elevate the nose, we can use dynacleft. But the issue with that, it's basically you need to use the you have to stretch through the contralateral side to be able to pull it. But sometimes the management of the direction of the pulling might be a bit of an issue. While the NAM, you can use that with the wire, and you can add the acrylic based on the direction that you want. So pre-surgical orthopedics, we've got several cases. The first one is Vivian. So this child was 38 weeks of gestation and diagnosed with a bilateral cleft lip, complete on the left side and incomplete on the right, and has alveolus and palate unilateral on the left side only. He's non-syndromic, and the management was only to use nasal molding. We didn't need to correct the position of the alveolus because it was approximated from the beginning. So we just needed to elevate the nose. So this is him through the treatment. This is at the end when we sent him for surgery to do the lip closure. Second case is baby Jabir. So this is how he presented to us. He is a full-term birth. His mom and dad are cousins, and his lips are complete bilateral cleft. The alveolus also is bilateral, and the palate is unilateral on the left side only. For this case, we use the scanning. So this is the STL file, how it looks like. So this is how it looks like, and then we printed a 3D model and made the NAM appliance from the 3D model. The original gap was about 12 millimeter. This is him with the NAM appliance. This is how it was made originally. And then this is the start of the stripping and stripping with the NAM appliance. Because it takes some time from the time of taking the impression or the scan to the fabrication of the NAM appliance. So at that time, we start with the lip strapping to begin with. So this is a video of NAM fitting. So this is the straps.
Sorry, Doctora, 20 minutes remaining.
Okay. So this is a Correga denture glue has been added. We just add this little amount mainly in the interior part. We leave it for 5 to 7 minutes to make sure it's stable. And then using the strips, we're using 2 lines, one that has to go across the whole face and one that's added with elastics to put it from one side to the other. And the tension that we add on each side, it depends on where the cleft is or where we want to direct the premaxilla in that position. And then we have to make sure that the parents know how to place it. The child can drink milk with it, especially if it was the first visit, because they're not used to having that, so it might be a bit difficult. Once we are sure everything is okay, we'll just send them home. So this is him on the day that we added the nasal stent. So as I said, we just add the nasal stent, we measure, put the area that we want to add it, and then we do the wire bending, add the composite at the top just to make sure it's protective for the child, just in case if the soft acrylic falls off. And then once we're done with that, we just add the soft acrylic, as I mentioned, as a kidney bean shape. The one part that goes inside the mouth, and then where the groove is, it's kind of like the connection between the outside and the inside. And the lower part, you should see it outside. This is the lower part of the NAM appliance. And then every session, every week, we just activate that to elevate the nose a bit by bit. So this is him, the pre-NAM treatment. This is him during active NAM, just before the nasal stent. So we approximated the alveolus for about 3-4 millimeters from 12 to 3. And then once we're done with that, we added the nasal stent, and he's still in active treatment. The last baby is Tamim. He is one of my old cases that we took a regular impression for him. Dad or cousins, he has a unilateral complete left cleft lip and palate and alveolus. The management was using a NAM appliance pre-lip surgery. This is him after the lip surgery, and this is him, 4 years of age. There's still bifid uvula at the back, so we have to double check with the plastic surgeon, are we leaving it or are we closing that, and if it's needed. But his speech is not affected, and we'll just have to review the case. Going for the age of 4 to 5 years, the second speech assessment and surgery if needed. For the 6 to 8 years, interceptive orthodontics would be done if it's needed. For the age of 7 to 10, it's critical age because this is the time that we do a bone graft to prepare them. Just before the canine erupts, or if the cleft was affecting the lateral position, the lateral incisor, or sometimes the central incisor. So the idea of having orthodontic treatment before the bone graft, is it necessary? Do we have to do that? It depends on the case. It's very case selective. And the idea is we're preparing the area to align the arch itself to be able to add the bone graft material and close the fistula and the oral intraoral communication, or antral communication, sorry. So these are the side effects if there is a fistula still there, the food gets impacted, there's a nasal reflux and or antral communication. They have the nasality in their speech sometimes, and chronic periodontal disease in the area of the cleft. Okay, it's very case selective, so we have to do that before the canine eruption, as I mentioned, about 1/3 or 2/3 of root formation for that canine. And then we have to correct the posterior crossbite if it was needed and to aid the surgical access to the cleft side. So the prerequisites, we have to have a good oral hygiene, well-restored caries-free dentition with the help of our pediatric dentists. And extraction, if it was needed before the bone graft, it would be done 1 to 2 months before the surgery, or it can be done during the surgery itself. The modalities of orthodontic treatment before the bone graft would include the maxillary expansion using quad helix, trihelix, or RME, rapid maxillary expander, and proclination of the incisor, especially if it was a bilateral cleft alveolus, because we'll have a protrusion of the whole premaxilla. And then it could be either done removable appliance or sectional fix, and sometimes upper fixed appliance. The face mask, if it was needed or indicated pre-bone graft. The side effects is we have to make sure that we don't bring the roots of those teeth into the cleft area. Otherwise, we might end up with fenestration or resorption or loss of vitality of those teeth. A surgical procedure of the bone graft. So this is an example by Dr. Hisham Burisk. There are 2 teams working for the bone graft surgery of surgeons. One would be working on the iliac crest to get the graft from there if it was autogenous graft, and the other team would be preparing the area in the alveolus. The bone graft assessment, we usually wait about 3 months minimum to evaluate if there is enough bone in the area. We take either plain radiographs, 2D or 3D CBCT radiographs. And then the tooth eruption through the graft would indicate that we have enough bone in the area and actually it's successful. The maintenance of the bone, it depends on when we're doing the surgery and if we are waiting for that tooth to erupt, if it was impacted, or if it was missing and we want to move the dentition into the cleft area to make sure the bone is there. Otherwise, we will lose the width and height of the bone, and they might need to have another bone graft later on when they're old, around the restorative time. And orthodontic treatment around the age of 12 to 14, just to see if they need anything else in case of impaction of the canines, if we need to align the upper arch just for psychosocial reasons, if we need to do any modalities of orthodontic treatment, has to be done around this time, but the patients and their parents, they have to be aware that it's not the end. They might need another orthodontic treatment, especially if the growth is unfavorable, and we need to do that in the future once they're fully grown. So as I mentioned, they have a delayed dental development in comparison to their peers, and the orthodontic treatment has to be kept to a minimum. We don't need to increase the burden for the patients, and difficulty to keep their good oral hygiene just increases the risk on them. For that reason, just keep it to a minimum. And then they should know that we have limited objectives at that time. At the end, once we're done with the orthodontic treatment, if it was done pre-bone graft and we continued later on, or we're starting later on, we have to make sure that we use a temporary bondage retainer into the area, especially the area of the bone graft, to maintain the position and prevent the rotation of the teeth in that area. But we have to have a regular checkup and maintenance for those patients. The last stage would be adulthood, when they're 18 years and above. If the orthognathic surgery is needed, they need, after we finish with orthognathic surgery, and then they can do the rhinoplasty and lip revision, just because if we advance the maxilla, that might widen the nose, and then it would affect the results if the surgery was previously done, like the nose surgery. And final prosthetic treatment. So if it was the case camouflageable, we can just finish our orthodontic treatment. If it was like regular ortho, or if it was severe and complicated, we have to discuss orthognathic surgery. And then restorative intervention also has to be decided with the prosthodontist before we start any kind of treatment, just in case if we want to replace teeth, if we want to camouflage, for example, a canine as a lateral, or what kind of prosthetic treatment is needed, fixed prosthesis, or do we need implants? It depends on the case and the situation. So we're starting with the cases. We've got Peter, who was, it's a transfer case, so these are the records for me. He's 8 years old, male, medically fit and well, presents with a unilateral complete cleft lip and alveolus on the right side. And the surgeries has been done before the lip around the age of 3 months. Extraorally, his summary of his occlusion is class 2 division 1 incisor relationship, mild skeletal two base, average vertical proportion, and nasal deviation to the left. He has poor oral hygiene and he is an early mixed dentition. The malocclusion is complicated by mild crowding the upper arch and overjet 4 mm, overbite 3 mm, and upper midline shift 1 mm to the right, and lower is 2 mm to the left. The cleft side is on the right side between the upper right 1 and 2. The orthodontic treatment plan was to align the upper right one, which was previously rotated, and then create space for the bone graft. So this is the fistula that present. This is where the bone graft is needed.
Sorry, doctor, I have 5 minutes.
5 minutes?
Yes.
Okay. So this is where the cleft area is, and then we did the bone graft. I don't have post-bone graft, only OPG. And then it's 2x4 appliances, and we're bringing the root into the position to maintain the root in that area. This is him at D-bond. He has a fixed retainer on this side, and this is his occlusion, but we're waiting for him to grow, and then we'll see if we need further treatment. If that's the case, I'm just gonna skip to this case. We've got Dana. She's also a transfer case. This is how she presents. She has a she's 15 years old with unilateral complete cleft lip and palate and alveolus on the left side. She has class 3 incisor relationship on skeletal 3 base with increased vertical proportion. The malocclusion is complicated by anterior crossbite and anterior deviation by 2 millimeters, and also chin deviation to the left side. So her treatment plan was to remove the braces, improve the oral hygiene, and review her as a new record. This is how she presents. This is her occlusion in centric relation. This is in centric occlusion, the maximum intercuspation. And her treatment plan was to remove whatever appliance she had, start with the rapid maxillary expansion, upper fixed appliances, and do the bone graft and on the left side, and review her for orthognathic treatment. So this is her pre-bone graft. This is the surgery that has been done for the bone graft. So basically, as I mentioned, there are 2 teams working on this. So it was performed under general anesthesia, graft the alveolar cleft using autogenous bone, and it's harvested from the left anterior iliac crest. 2 teams of MaxVac surgeons collaborated. The release incision was done in order to have tension-free closure at the end. The nasal mucosa, I'm just going to repeat the video, it's very short. The nasal mucosa closure was done, and also the bone that has been harvested was taken a block of bone that has the cortical bone was reshaped, placed into that, and pinned into place. And then once we have that box, we added the cancellous bone at the end, and then we closed tension-free. This surgery was done by Dr. Ahmed Al-Kendiri, and I'm thankful because he gave me the videos. So this is her 3 months post-bone graft, and this is her 6 months post-bone graft. We have enough amount of bone in the area that we can move the teeth in, and our plan is to align the upper arch. So she stopped the growth, but she's in still severe case, and her plan was to have an orthognathic surgery. The fourth one, maxillary advancement and BSSO, set back and correct the asymmetry. So the lower midline should be aligned with the chin because that would be corrected surgically, and the upper midline would be corrected during orthodontic treatment. This is her at the moment. She's still in active treatment. How many minutes do I have? Okay. So I'm just going to discuss this case. Mohammed. He presents with class 1 incisor relationship, skeletal 1 base, but he has hemimandibular hyperplasia on the right side and chin deviation by 2 millimeters with a maxillary cant lower on the right side. And he was assessed for the, he has also 2 impacted supernumeraries in the lower arch. His treatment plan was to improve his oral hygiene, caries assessment, refer for extraction of the supernumeraries at that time, and then orthodontic treatment was decided to go with orthodontic camouflage and to continue fixed orthodontics. We did arch wire expansion in the upper arch, and then a yin-yang wire bending, this is how it looks like. This photo was taken from Dr. Abdullah Shrida. Sorry, not Abdullah, Ahmed Shrida. And so basically this is how the wire looks like before we engage it into the brackets. And that would help with the correction of the maxillary cant. In addition to that, TAD's placement was decided on the right side to impact the right side. And there would also be retained asymmetry about 2 millimeters. And this is how he looked like. So I used GIC blocks and then used elastics on the left side to extrude the upper left side slightly. And then the visit after, I used TADs on the right side to impact the upper right side. And it was only done on buccal TADs just because the teeth, everything was rolled in, so I wasn't very worried about the palatal cusp drop when I intruded the upper arch. So this is him during the treatment. This is him post-treatment. So this is him after debond. Basically, we corrected the maxillary cant, but at the end, we ended up with a minor this is him in centric relation. This is him in maximum intercuspation, so centric occlusion.
1 minute.
Okay. So this is his occlusion. We tried to finish it, but he got accepted in medicine and he traveled. So that required early debond. And I'm done. Thank you, guys.
Thank you, Dr. Fatma, for this excellent presentation and for the shared knowledge.
Thank you.
Do you have any quick question? Quick or, okay. If anybody has any question, they can ask Dr. Fatma later on. Thank you.
So basically, this is my contact email. If you have any questions, you can email me. This is the cleft unit number, just in case if you encounter any cleft patients and you want to send them to our department. This is the website. Dr. Latifa was kind enough to make this website and share the knowledge with us. It's called Special Smiles. This is my Instagram account, which is my professional account, and this is the Special Smiles Cleft Unit account. Thank you, guys.
Our next topic will be about 360 approach, perio-ortho synergistic approach. How many of you have wondered about 360 approach? Today we are in luck to have Dr. Mohammed Ghuli to talk about this topic. Dr. Mohammed Ghuli earned his DDS at Virginia Commonwealth University in 2015. He completed the combined periodontics, orthodontics program and obtained his master's degree at the University of Pennsylvania in 2021. Dr. Ghuli is fully board certified by the American Board of Periodontics and the American Board of Orthodontics. Bravo. He is also a fellow of the Royal College of Dentists of Canada in periodontics and orthodontics. He is currently a faculty member at Kuwait University, University of Pennsylvania, Temple University, and the Kuwaiti Board. Please join me in welcoming Dr. Mohammed Ghuli.
Okay, tamam. Clear. Okay, perfect. Let me go ahead and put this here. All right, thank you very much, everyone, for attending here today with us. Today, I'll have an interactive session with everyone. It's going to be question and answer. It's going to be us learning all together, okay? A little bit about my background. Thank you very much for our chairpersons for introducing me. So, I did my Doctor of Dental Surgery at Virginia Commonwealth University. Then I joined Kuwait University as a teaching assistant and joined the combined perio-ortho program at the University of Pennsylvania. These are my current academic affiliation. I'm a full-time assistant professor at Kuwait University, faculty member at University of Pennsylvania, Temple University, and I'm fortunate to be associated with the Kuwait Institute of Medical Specialization. I do not have any financial relevance for anything that I'm going to be presenting. I'm not going to present any off-label uses for any materials that I'll be presenting. Okay, so orthodontic diagnosis and treatment planning. When we started in orthodontics back with Angle Orthodontics, you know how we used to treatment plan cases? They used to look at models only, that's it. Then the era came of CEFs. The first person when they were using CEFs were like, we don't need CEFs, we can use models to diagnose people. But then we came along and understand back in the 80s about the importance of facially driven treatment. Because let's take you back to the 70s, what happened, everybody was getting non-extraction treatment. So their faces were fuller in that component. Nowadays, you'll see people saying facially driven treatment, aesthetically driven treatment. We start with the face. We have to look at the profile first. The idea of 360 is, I know we look at the face, it tells us to extract or not extract. But something else we have to think about is the periodontium. When I look at the periodontium, does the periodontium allow me to do non-extraction therapy? Or am I just gonna level and align and have teeth outside the bone? So that's something to keep in mind from that perspective. So our basic pictures that we take to visualize how we treatment plan the patient. What do we look for? We look at arch perimeters, we look at soft tissues, hard tissues, occlusions, all those components. But let's take a step back and take a look at these 6 cases. I'm going to be talking about a few of them. We look at them at, what do we see? We see different malocclusions with different periodontal needs. For example, case number 1, a patient that lost a tooth for a long time, so the teeth collapsed, and we have no space, adequate space for an implant. Here we have a patient that lost her posterior teeth. So we have what we call a progressive bite closer, okay, dual bite occlusion. Here we have some cases that are showing us this patient, or number 5, telling me, Doc, they make fun of me. They say I have very large teeth. Can we do something about that? So we're going to dissect into those cases one by one and different topics that we're going to talk about. So let's talk about forced eruption. Forced eruption, as an orthodontist, is going to be a tool in your armamentarium that you're going to love, and all other specialties will love with you. The concept of forced eruption started back when we have thinking about orthodontic movement. The easiest orthodontic movement is what? Is extrusion. It's only tension. The hardest one would be intrusion because we're compressing the tissues. But we have to think about in 1940, Oppenheim, this is a different one than the Oppenheim that has the movie about. He was thinking about force erupting the tooth into animal models, and what they used to do is notch teeth to make sure that the teeth extruded, nothing else from that component. So, and then Dr. Engelberg at the University of Pennsylvania, he was a periodontist and a restorative dentist. He was thinking, I don't want to do osseous surgery for those cases. Can we force erupt the teeth and do occlusal adjustment to idealize the position, and then we go ahead, we improved crown to root ratio, okay? So, and then we typically know that the mucogingival junction does not change because the Japanese group looked into that. Okay, doc, you're telling us important information. How can we apply that? So this is a patient coming to you with the chief complaint, I have long teeth. So when I look at it, we have some areas here. Could it be some root that is exposed? It could be, but as a periodontist, it's unpredictable to do the soft tissue. But you are lucky here. How many orthodontists in the room we have? How many periodontists? How many general dentists we have? Okay, so we have a full of everything. So when we have to think about that, as an orthodontist, what you want to do is you go ahead and you do your forced eruption and do your occlusal adjustment. That way, you idealized all the positioning that you have for the teeth. That way, we can see how the patient looked at. We no longer have longer crowns. Now I can send it to my prosthodontist or restorative colleagues to have a full mouth reconstruction. For this case, it's easier. So this is from a soft tissue perspective, right? We thought about that dimension. But what about hard tissue? This is a patient. We have a tooth that we know this tooth is not restorable. When we look, patient has high smile line. If it was me, I don't want uneven gingival margins. We live in the era of immediacy. Everybody's saying immediate implants, let's place them. But the issue with placing an immediate implant here, we're not going to change the topography of the bone and tissue. The tooth will always be asymmetrical. For me, the centrals are important. Every time I look in the mirror, they're not going to be ideal. So let's use the concept of forced eruption. So back in the 90s, the Salama brothers, also from the University of Pennsylvania, came in and says like, okay, we did forced eruption for restorative purposes, but what about for implant site development? Can we do that? Yes, we can. So what we have to do in this case, we can change the topography of the teeth. So we have an unrestorable tooth that we can take a look at, but the hopeless tooth is not a useless tooth. What we can do here is actually look at the resorption that we have on this tooth, and then what we're going to do is go ahead and force erupt it so we can do that. But there is an issue here. We have a lesion. What's going to happen if I force erupt when there is a lesion? We know that orthodontics is sterile inflammation. Here we have pathologic inflammation. So if I combine sterile and pathologic, it's a recipe for a disaster. So what we want to do is, first of all, we're stabilizing the arch. That's why you see the wires bent. No activation yet. We go ahead and refer to our endo that does an apicoectomy, and then after doing the apicoectomy, we go ahead and force erupt the teeth with rectangular wire so we can maintain the torque. Now we built the soft tissue and the hard tissue for the case. So now this is a more predictable case. What we can do here from that component is we built the tissues that we need, and we can see how we idealize this case. All right? So we can see clearly how the bone was built. All right, so implants for anchorage. I know a lot of people say the best time to place implants is after ortho. This is a case where I challenge you why I do placement during ortho treatment. So this patient comes, she's telling me, Doc, I'm an empty nester. I have 2 children, they went to college, I'm retired, I want to change my smile. When I look at a case like this, dual plate inclusion, compromised case, please, you were a dentist before you were any other specialist, and if you are a dentist, you have to think about saving teeth. So just taking all the teeth out and reconstructing this case with implants, full arches, It's not the predictable way of going. We can still save teeth. So what we can do here, actually, we think about reconstructing this case with teeth and implant. So in a case like this, what we want to do is reconstruct the case. But I'm not just going to start the treatment. I have to refer to my prosthodontic colleague, restorative dentist colleague, to do a setup. Whether you do the setup digital or analog, as a resident, we were trained you have to learn both digital and analog ways, because if digital does not go the right way, you have to know how to do it. So we did a setup of how many implants you need and all that. So with that being said, we go ahead, we begin with the end in mind, and we idealize the occlusion. So in a case like this, I start by placing TADs, Holy biplane. So what I can do here is idealize the occlusion for a case like this. And then now we can see the tooth fractured, right? But fortunately, we're just talking about forced eruption. So what we can do for that one tooth that you can see later on, now it's a more predictable case that we have. So what we want to do here for that one tooth, we're going to do endoretreat, and then we go forced eruption and build that tooth. And all of a sudden, we have a case ready. We refer it to our prosthodontic colleagues, and it's all ready for restorations. Okay? All right. So we'll talk about space opening. We have a case like this. When we have space opening, we're going to use an open coil. What is the downside of using an open coil? We have to understand the mechanics that we're using. If we're using an open coil, we're going to have things that are going to shifting the midline. Fortunately for us, we want the midline to shift. We want proclination of the teeth, and we want distalization. So we have to think about that component. So idealizing the space, then we can see how much of a large of a defect that we have. Based on the defect, we can go ahead and now, during ortho treatment, do our bone grafting procedure, because we're moving teeth away from the orthodontic procedure, right? So that way we can go ahead and build our tissue, build the bone, do our periosteal release. What we were able to do is reconstruct allograftic material used, collagen membrane, primary closure was obtained, and now we can see we were able to have an ideal setup for a case like this, right? So now this case is an ideal setup, and you have your pontic, and ideally you want to have a 4 millimeter, because you want to make sure that you have room for swelling. If the patient swells, you have that room. Now we have a predictable case. The patient will be able to get their implants later on. Okay? So when we take a look here, we can see how we were able to reconstruct what was lost for this patient. Okay, so let's talk about intrusion. A case like this comes to you. I want you to focus here. When we take a look at this, the easiest way that you can think is, I'm going to extract the tooth, and that's it. And I'm going to put the implant top and bottom. Intrusion is not predictable. We live in 2024. TADs came to the market around 2000. It's been 24 years. We are fortunate we live in the era of TADs. Yes, we can do intrusion with TAD. But first thing you have to do is look at the OPG. And you have to say one thing. The first thing, I look at the location of the sinus. Do you guys think we can intrude into the cortical floor of the sinus? Who said yes? Who said no? It's a 50-50 question. Easiest question there is, 50-50. Can we intrude in the cortical floor of the sinus? Who says yes? Who says no? Yes? The others are saying no, I guess. Or yes, we can, but it will take more time. In a case like this, it is more predictable to intrude. So what I can do, actually intrude and space closure. We can actually intrude into the sinus, we can mesialize into the sinus, but it depends on the timing that it takes to do that. We already know that through systematic reviews. They've been studied, looked into different studies. We know that we can intrude into the sinus, and actually what we can do is mesialize. I place my TADs. Typically when I place my TADs, I like to take a PA to make sure that everything is fine. You always double check, cross check that we don't have any other issues, and then we go ahead. Does it make a difference if I have one TAD on the buccal or 2 TADs on the buccal versus 1? Who thinks 3 is better than 2? When I was a dental student, I thought more is always better. If a little bit is good, more is always better. But actually the evidence says there is no difference if you use 1 TAD, if you use 2 TADs or 3 TADs. That's why typically we use 1-1. It's more for patient comfort, cost effectiveness, and such like that. So these are numbers that I would keep in mind. This is just when you're dealing with pros, is what numbers you have to leave for those cases. Like if you're doing cement retained implants, screw retained implants, we have to understand what we're doing. Okay? So we just go ahead and do our typical placement of TADs. We want to go ahead and mesialize the dentition. And as you're mesializing on rectangular wire, you do get some resistance, so you have to think about using a shepherd hook to be closer to that. And if you can see, I use a round wire, Australian wire with a gable bend, so we can go ahead and start closing the space. And now we can see a more predictable space closure, and then we can do micro osteoperforations to make sure the cleat is clear. So let's look at the case. We took a relatively hard case to an easy, predictable case. No molar endo was done on this case. Just pure intrusion and occlusal adjustment. That's it. Okay? So the dual plane occlusion that we had, it was corrected, and we can see what we have from that perspective. And sometimes I put my buttons on the palatal so I can make sure I'm tracking the tooth on both sides. Okay, and if you can see here, we love our anatomy. We have to remember, whenever we extract teeth, we want to close the space closer. Let's just rotate the molars so we can have easier space closure. Because when it's rotated, it's 12 millimeter. If it's not, it's 10. So as you know, if we derotate to correct a class 2, rotate to correct in a case like this. Okay, so what about space opening? I have an ideal class 1 occlusion, but I want to open a space for an implant. What I can do is, actually in this case, I can place a TAD and then anchor into my TAD. And we know Newton's law, for every action there is a reaction. That way I cancel the mesialization and I only got distalization, a distal vector. So now I have a more predictable case that we can go ahead and do that. Okay, this patient came in, they wanted a dental implant. What is the issue of having an implant here? Why are we concerned for having an implant here? This is not an ideal situation for an implant. You should refer them, whether you're a general dentist or restorative dentist, you should refer them to idealize the occlusion to be able to place an implant. There's a lot we can do. What about the posterior crossbite? I hear a lot of people say about posterior crossbite. Posterior crossbite is not an issue to have. We can have it in adult patients that we cannot expand. They don't want to do any MARPI or SARPI. We can maintain it as long as we have an ideal smile arc that we create. So in a case like this, we make it a predictable case for our patients. We idealize the situation so we can be able to go ahead and restore it. And you can see this is a crown prep that was left through the years, so it mesially drifted. So what we want to do in a case like this is actually idealize the position of it. And now I'll show you in the occlusal view how we did that. So we have root tips that we're going to extract, and then we idealize the crown prep position into the ideal position. During that, you want your restorative dentist to maintain the arch for you, temporize it. Now you are in a predictable occlusion. You can go ahead and place your implants. All right, what about this? Your simple class 2 case. We see them, this is bread and butter of orthodontics, class 2 cases. But there is another issue, the dimension I told you about. You look at the profile. I like the patient's profile. I don't want the chin, the lips to go back, because that will give him a prominent chin and nose, what we call a dish chin profile. But I have to actually procline the teeth, because I'm not gonna extract in this case. So I have to think about hard tissue phenotype modification or soft tissue. So in a case like this, I look at the CBCT, it's fine. So it's a more predictable to do soft tissue. The other question is timing, doc. What is the time? Is it before? Is it after? Is it during? Healthcare is a dynamic process. There is not one time. There is a case-by-case situation, individualized plans. There is no cookie-cutter orthodontic treatment. So in a case like this, we already know, I sit with colleagues that are orthodontists. They tell me, I don't see a lot of recession a lot. You know why? Because recession does not show up except after 2 to 5 years after treatment. So if I'm lucky, I'm trying to call my patients for recall. If I'm lucky, I can maintain them for 2 years. For 5 years, I'm not seeing them. Then it's the periodontist problem, when he sees them and he sees the recession for those cases. So in a case like this, what you want to do is idealize the position, but first you have the conversation with them before starting. You need soft tissue grafting. I'm going to refer you to my periodontist. Throughout the procedures, the patient's conditioned. They know they're going to be referred to the periodontist to do the procedure. So now I idealize the position and I realize I have lack of keratinized tissue and decreased thickness. So what I want to do here, soft tissue grafting right away. I refer to the periodontist and we do soft tissue grafting in this case. After we did this, this is a more predictable case now. We can take a look. We idealize this. This patient most probably will not have recession later on because we idealize the position of teeth. And then we idealize the occlusion that we have, and now we finish the case. This is at the day of the debond. we can see the case will be settling in to be nice. We looked at the 360 concept of idealizing the occlusion. Okay? All right? And this is a happy patient at the end. So let's talk about something else that I want you to keep in mind. We do a lot of extractions in orthodontics for adult patients, young patients. It's not the same. You have to think, if there is no buccal plate, let's build that bone because it can create an issue. This is a case, a fellow colleague extracted. What happened is they just removed the buccal plate. There was no buccal plate. And now as an orthodontist, close the space. Patient's asking me, Doc, why isn't the space closing? Like, look, it's been 7 months now. The space is not closing because what's happening is now there is no bone to go there. There's going to be cortical bone. And we're going to know it's going to take a while to do that. So what we want to do here is actually do a guided bone regeneration to build the bone because the roots is already perfing through. You see? It's going to perf through. So what we wanted to do is build the bone in a case like this. So we were able to, this is a separate case. But you see, if you don't, all the roots will come through. And you'll have issues later on from that component. Okay? So we build the bone. And if you have a referring surgeon, tell them I want you to use allograftic material, not xenograft. Xenograft, it comes from animal models. It takes longer to resorb. It's kind of against the fast movement of orthodontics. So we go ahead and place that. Membrane, space closure. We can all idealize the position. Space is closed. Could this have been avoided? Yes. How would we avoid it? In a case like this, day of extraction, ridge preservation, start activating right away. Doctor, can we activate? In a case like this, yes, we can activate. There is plenty of evidence. The regional acceleratory phenomenon is real. It's been discovered in 1984. We live in 2024. Almost 40 years later, we can apply concept that we learned. So we can go ahead, close the space as quickly as possible without any issues in a case like this. Okay? So another thing to think about. Here is a case, class 3 malocclusion, lower incisor. How can I determine which tooth to extract? For my fellow general dentist, typically what we want to do before any lower incisor extraction, to do a setup, whether it's digital or analog. In this case, we did a digital setup, and we determined what we want to do. Do I want to treat this case with aligners or fixed? There is a hybrid modality that we can do. Because we have severely rotated teeth, what we decided to do is a hybrid modality, and we know the weakness of the aligner therapy is what? The rotation. So we go ahead, and we see how severely rotated we are. So what we want to do here is ridge preserve, as I showed you, and then use brackets only on the lower. I told the patient, give me 3 months, and I'll transition you to aligners. And then 3 months, December, we're done now. Now the patient is ready to go aligners, jumping the case. Now this is an easy, predictable aligner case. Whichever system you use, it's an easy case. Okay? So we idealize the position in a case like this. And we also look at the profile, look at the lower lip. We improved the lower lip appearance for that patient. We can see how we appreciated that position. Corticotomy and grafting, a glimpse of history. We know it's been there. It can be done. The idea behind corticotomy and grafting is what? Is that we can do it to expand the envelope. A lot of the things I'm showing today, I just want you to know the things can be done. You have to think about collaborative treatment, multidisciplinary treatment, wherever you are working. Please, as an orthodontist, you want to take a CBCT to see how your cases are. If your cases are looking like this, it means you did not respect the fourth dimension, which is the bone. It means that's why I want to take about 360 all around it. This patient is a long-term prognosis and not a predictable prognosis for them. I've reflected so many roots that I don't care whatever system you're using, you cannot build bone on the buccal. Whether you do slow movement, hard movement, it's not. We can see that. We can see by clear clinical evidence, these are the cases. Whichever bracket system you use, you have to think about building that bone system. This is a case we started beforehand. What we wanted to do is visualize what's going to happen. Let's take a look at 3D planning. We can see we have a profile that does not allow extraction, lack of keratinized tissue, and then we go ahead and do our CBCT. Look at it. I already know there is no magic. I'm using robotic wires in this case, robotically bent wires, and still the teeth will procline and be coming outside the bone. Okay? So we go ahead and do our phenotype modification through hard tissue, and we go ahead and do our decortication, grafting, and we activate right away. At 2 weeks, you can activate. faster treatment time. Evidence has shown up to 40% decrease of total treatment time for adult cases. I'm not talking about your adolescents. And look at the phenotype now. Look how thick it is. Look at the periprobe. Look how I can see it here, and now I do not see it anymore. The thickness of the tissue. Appreciate what you could do in a case like this. All right? And now we idealize the occlusion. All right? It can be done. Now the debate with membranes or non-membranes is for a different day. It can be done. This is by a colleague of mine, where they did actually phenotype modification with the use of bone and membranes. So you can do both ways to do that.
10 minutes.
Okay, perfect. Thank you so much. So we have that case, and we can see how we change the phenotype for a case like this. What about a class 3? Let's go back. Class 3 malocclusion. This patient, 3 consultations at the same clinic. He came to the orthodontic clinic at University of Pennsylvania 10 years ago. They told him surgery, surgery, surgery. They were like, okay, we can treat you non-surgically, non-orthognathic surgery, but the profile will not change. It's not going to be a huge change of the profile. So what we wanted to do is phenotype modification, building the lingual aspect, okay? Not the buccal only, building the lingual aspect of the teeth. And we can go ahead and made a predictable, an unpredictable case predictable. We were able to close the space non-surgically, all that component. When I'm talking non-surgically, I'm saying orthodontically, non-surgically, okay? So we can see the difference that we had in a case like this. Also, our typical history of bone loss. People told those patients, you cannot get ortho treatment anymore, you're done. We can't treat these patients. We stabilize periodontal disease, and then we'll go ahead and plan them. And what we can do as well is what? Occlusal adjustment, improve crown to root ratio. This can be done with aligners, decreased velocity, decreased aligner change time. Instead of 1 week, do 2 weeks. Okay, and then we do our frenectomies for those patients to maintain space closure. You can see how we have that. A case like this that's presenting here, that we can see that we have an open bite. What we want to do with our open bite techniques is what? Think about the lip and tongue habits that the patient has. And we know open bite in the literature. Like if it's dental or skeletal, all those components, we have to think about them. Who chooses option A versus option B? You want your attachment to be on the buccal or the lingual of the uppers? I personally prefer them on the linguals when I can, because fortunately for me, this is an intrusion case. Let's look at the clin check. I'm intruding the posterior teeth, not touching the anterior teeth. I'm only idealizing the centrals, okay? Look at that. First clin check, because you know for every action there is a reaction. So what happens here? We idealize the occlusion, okay? And then we edge to edge, right? What I can do now, short class 3s, even without any refinement. Now I'm ready, I do my crown lengthening, and this was done with collaboration of Dr. Septi. We moved an unpredictable case to a more predictable case. What we can do here is idealize the situation, all right? So we can see how before and after for this case. And then a case like this, everyone, take a look. She came to me, they told me I needed to extract my lower central. Can you do ortho for me? I was like, okay, let me take an x-ray and take a look. We look at the bone loss here, significant. And I was like, okay, as long as we treat the perio disease, we can do it, and I can do it with aligners for a case like this. What we did is we idealized the occlusion, and we were able to do that. Okay? Before and after. A case like this, it doesn't look predictable at this point. What you want to do, aligners with TADs. It can be done. Now it's a predictable class 1 case. You can go ahead and do that. Only aligners with TADs in a case like this. Okay? A case like this, when we take a look at Lester, he is one of my lab techs. He was telling me, Doc, my teeth are proclined. Should we start ortho or perio first? This case, ortho or perio? We have the soft tissue considerations. So in a case like this, you want to think about the movement of the teeth. So we start with perio first, soft tissue grafting, and I do my ortho treatment, idealize the position, and we can see how we made it a more predictable case in a perio-ortho component. Okay, in a perio-ortho component pictures, we can take a look and we can see, I call this picture the power of perio-ortho. When people tell you root coverage is not real, you're canceling a specialty that was invented since 1945. Periodontics is a specialty of treating with these kind of situations. We can do, a lot of science has been gone through root coverage. Okay, this is another case where we can see is we're going to do our perio first, and then what we do is our ortho treatment We have creeping attachment and idealizing the situation. Okay, and then we do a little bit of crown lengthening. Okay, this case, perio or ortho first? Perio, ortho? This should be ortho first, because even if I graft, it's gonna issue with my graft. So I have to idealize the ortho. Now it's now at refinement, the first refinement, I go ahead and do my soft tissue grafting, idealize the position, and now can fine tune this with orthodontics now. Okay, this case, ortho or perio first? This one you do ortho first, then we can go ahead and finalize it, idealize the settling, and we have that component. Just a quick topic about aligners. MRPs, that it's one of customized designs. You have to think about the occlusion that you have. What is the design you want to do? It's a predictable treatment. It can be done. We are fortunate we have it in Kuwait. That's something you want to look into. Please provide this treatment for your patients. Be honest with them. It's something that we can do. It can have complications. We can deal with the complications with each other. Okay? So it can be done with fixed appliances. It can be done with aligners, both. Does it have complications? Yes. Be honest with your patient. It can happen complications. This patient comes to me, دكتور اللثة كلت الجهاز. You see? That complication can happen, but you can deal with it. We can let the patient know, yes, complications happen. You already did your consent form, but how to deal with it, what's going on, stuff like that. We can remove the appliance and start over again. It's not a big deal. All these components are easy to deal with. This is my final case of today. This is telling you the multidisciplinary case is real. MARPs, amazing. We can do them. But we have to think about, there are cases we cannot do MARPs for. In a case like this, it's narrow. If I do 4 TADs, this patient is going to be going through so many things. Let's have them go through SARPI and then idealize the occlusion for this patient. We do SARPI. You want to guess how many expanders we went through? 3 expanders. Each one 12 millimeter. This patient at this point was not trusting the process. It was like telling us, Doc, is everything going all right? It doesn't look like everything is all right. But you have to trust the process slowly and surely to idealize the position, to take an unpredictable case to predictability. Okay, I want you to focus on one thing. Look here at the upper right one. There is actually recession, but we did not catch it in the beginning. There was so much going on. But always do that. We have to reassess the cases that we did, and we idealize the situation. So this is before and after for this case. And we went ahead and did the soft tissue grafting for a case like this. And we did a coronally advanced flap. We idealized the position. And this is before and after for this case. This is using the 360 concept. And we can see here, there is a lot of problems that we face, but there is a lot of solutions for the problems that we face. Okay? And I want us to let you know that there is a course that we're going to have, me and Dr. Kamal, about orthofacial and surgical approach. And I took this opportunity to announce about our book that's going to be talking about orthofacial reformation, which is going to be telling us about what we're going to be doing for our patients to have that component. There is one take-home message I want you to take from my whole presentation regarding the cases and everything. I'm happy that you are all here on a Friday afternoon to do better. Because as Maya Angelou said, do the best you can until you know better. Then when you know better, do better. And each and every one of you are spending your Friday afternoon. It's a valuable time. It's amazing weather outside, here with us at the KDC to learn more, to learn together. Thank you so much for being here with me. It's an honor and a privilege. Thank you.
Thank you, Dr. Oli. It was really an amazing lecture. Personally, I didn't want the lecture to end. Anybody has any question, please? Any questions? Thank you very much.
Here.
That's okay. One question, please. Thank you so much for the amazing lecture. Usually when you do the soft graft, you do the hard graft also at the same time, or only like case by case?
Yes. Yeah, if you want to do soft tissue, we do soft tissue first, then we do the hard tissue for cases that need both. But in certain cases that it's borderline, we can do hard tissue because some evidence shows that the soft tissue will thicken for those cases. And regarding the timing, as an orthodontist, you have to think about when is the best time to refer, depending on your movement. If you are tucking the roots in, tuck the roots in, then refer them for them. If you want to push it outside, you want to do it before, typically with your patients.
Thank you so much.
This is an appreciation from KDC.
Connection. Say title.
Our fifth speaker for this afternoon is Dr. Fatma Hussein. Dr. Fatma is a board-certified craniofacial orthodontist with a special interest in the treatment of complex craniofacial cases. She received her dental degree with honors from Kuwait University, and she completed her residency in orthodontics and obtained a Master of Science in orthodontics from the State University of New York at Buffalo. She undertook a fellowship in craniofacial and special needs orthodontics at the Children's Hospital Los Angeles. She is currently an assistant professor at Kuwait University and the State University of New York at Buffalo. The stage is yours, Doctora.
Thank you for the kind introduction. I know it's 5 p.m. and most of you have been here all day long, so I'm going to try to make this short. Today I'm going to be introducing a new technique, something that's new in the craniofacial world, where we actually managed to protract and distract the maxilla forward with a Le Fort 1 cut using bollard plates, face mask, and class 3 elastics. So to begin, I just want to make a few disclaimers. I do not have any relevant financial relationship with any manufacturers or any of the products that I'm going to be mentioning today in the presentation, and I'm not going to be discussing the use of any unapproved or off-label material. Another disclaimer is that I have obtained written consent of all the patients that I'm going to show today. Let's get started. So this is going to be the outline of today's talk. We're going to start with stating what the problem is, what is the problem that we're trying to solve, what treatment options do we have for the patients that we're going to be talking about today. I'm going to talk a little bit about distraction osteogenesis, since this is what we're doing, and then I'm going to present the distractorless maxillary distraction. I'm going to show one case and I'm going to explain how it's done, and then we're going to talk about ways to optimize your result or your treatment outcome. So I'm going to start with this slide about the road not taken. Oftentimes in life and in orthodontics as well, you come across two options or even more, and some may seem straightforward and easy. It's a quick fix, while others may be more challenging, and it's often the challenging roads or routes that may lead you to dead ends, and those are going to eventually have you look around, turn around, and think outside the box and try to find another option. So what I'm going to be talking about today is basically the road not taken. It's not something that we do every day. We happen to do it because we hit a dead end. So for the craniofacial anomalies population, we often are presented with patients who have skeletal class 3 malocclusion. We often see it in patients with cleft lip and palate, patients with craniosynostosis syndrome, such as Cruzon, Pfeiffer, and Apert's. This is one of my cleft lip and palate patients at Children's Hospital, Los Angeles. You can appreciate how the patient is presenting with a class 3 malocclusion really early on, very severe class 3 malocclusion, evident clinically and on the lateral septum. This is another patient, 11-year-old female patient with Cruzon syndrome. Again, if you look at the trace septum and you look at the clinical presentation, the patient is also presenting with a class 3 malocclusion, and again, that's a skeletal class 3 malocclusion. We see the same presentation with patients with Pfeiffer syndrome, and then again with patients with Apert syndrome. And sometimes the clinical picture can be deceiving. If you look at this patient's clinical pictures, you may be thinking, oh, this is not as severe of a class 3 as I would imagine. But if you look at the lateral septum, you can appreciate that those upper central incisors are severely proclined, and this is what's masking the negative overjet. So what options do we have to offer for those patients? We know that when we have a maxillomandibular discrepancy greater than 9 millimeter, this kind of warrants a surgical correction. So some of the treatment options that you're going to give to those patients include a Le Fort 1 advancement with or without a BSSO, depending on the way the patient presents. And then the other two options would involve distraction, either with internal distractors or rigid external distractors, also known as RED. So my goal of this presentation is basically to introduce a distractorless way to distract the maxilla forward using bollard plates and face mask. If you want to know more about different treatment options for craniofacial patients, especially patients with cleft lip and palate, and specifically orthognathic surgery options, it's a good idea to go and look up this article published in the Oral and Maxillofacial Surgery Clinics by Dr. Steve Yen. You have a big table, and then you have multiple columns. Patients are divided based on their negative overjet from more severe to less severe, and then you get to know about the benefits and disadvantages of each option. So this kind of helps you make a decision for your patient. But today what we're going to be focusing on is the distraction, the two distraction options if you have more than 10 millimeter negative overjet, and those include the red and the internal distractors, and those are really the options that we're trying to avoid. So this is what our red looks like. I personally cannot imagine a patient saying yes to this, also, although I've seen patients who've had to go through this, but imagine the patient having to go through surgery to have this stabilized on their skull, and having to live with this for at least 6 months, having to go to school or work with this on, having to go to sleep with this on, shower with this on, and then once the patient's case is stabilized, they'll have to undergo another surgery to remove this distractor. So this is really what we're trying to avoid. So which option are you going to give your patient, and then what is the best option for that patient? That's the one thing you got to keep in mind. There is no framework that you can use for every case. It really is based on the case that you're seeing. So a little bit about distraction osteogenesis. Does anyone know what distraction osteogenesis mean? Anyone has any idea? So the simplest way to define distraction osteogenesis is that you're basically stretching a fracture callus to form new bone. So imagine if you have a fracture in a long bone, ideally the patient would get a cast to try to stabilize the two fractured segment and to allow the callus to heal and to form bone in the area of the fracture. What we're doing here with distraction osteogenesis is that we're pulling those two pieces of bone apart after the callus has formed, so we're stretching the callus, and then once we are at the length that we're happy with, then we're stabilizing it and allowing it to calcify. In this way, we're actually forming new bone. So why are we doing this, and how are we going to do this? We basically introduced this at CHLA because we wanted to avoid the discomfort and stigma attached with both internal and external distractors. This is a bone-borne distraction design that will use the elastic force to advance the maxilla forward. And we're going to do this using a protraction face mask and bollard plates that your oral maxillofacial surgeon or your plastic surgeon going to insert during the surgery. One very important point about this technique is that it's completely dependent on patient cooperation. By the time the patient is ready for this kind of intervention, you would have known them for a while, for many, many years. And at that point, you would have treated them with either phase 1 or preparing them for a bone graft. You would have known that patient. So you would know if this patient is a good candidate for this treatment option. Because if that patient was at any point during your treatment non-compliant, then this may not be a good idea. Because you're going to put the patient through surgery, they're not going to be compliant, you're not going to get anywhere. And then another important point related to this technique is we always aim to overcorrect to compensate for relapse. Those patients usually have had so many surgical corrections, like for example, our cleft lip and palate patients, they undergo lip repair, they undergo palate repair, sometimes lip revision, they undergo ABG, multiple surgeries that result in scar tissue, and you're actually fighting that scar tissue when you're advancing the maxilla. So always account for relapse. And the rule of thumb when you're distracting, whether with this technique or with regular distractors, you always try to overcorrect by 1/3 of your goal advancement. So this is the patient that I'm gonna demonstrate on. So this is a patient's initial presentation. Lauren presented to us again in our clinic at CHLA when she was 18 years, 2 months old. You can appreciate her severe class 3 malocclusion, -9 millimeter negative overjet. She has a constricted maxilla. She's missing multiple teeth. So this patient was actually done growing. So we could have offered her an orthognathic surgery option. Again, this is her lateral ceph showing how severe her malocclusion is, and then if you look at her A and B angle, It's -4, so she is a class 3 patient. So what treatment options do we have for this patient? This is one of our lucky patients because she did have a lot of options to choose from. We could have gone with a 2-jaw surgery where we would do a Le Fort 1 advancement of the maxilla and a BSSO to set the mandible back. We could have given her a 2-stage treatment where we do a SARPI to correct the transverse on the maxilla and then go for a second round of orthognathic surgery. And then we could have done distraction with a RED. But then for this patient, we tried to give her a 4th option because she was not big on going in for a big surgery. So we gave her the option of doing a maxillary distraction using the bolide plates and a face mask. And that also included a SARPI. So how do you prepare your patient for surgery? Since this patient, this is special for this patient because this patient was also undergoing a SARPI at the same time. So we had to basically prepare the lower arch and then cement our expander. With cleft patients, I always prefer to do a 4-banded expander. The day of the surgery, I always check, make sure my expander is really solid on. We've had cases where expanders come off and then it's a really big problem after the surgery and after the cuts were made. This is the patient immediately after surgery. Does anyone have any idea what those metal things are on the CBCT? So you can appreciate on the CBCT that the Le Fort cut was made. I always take a CBCT, a full head CBCT after the surgery, especially if you're in a teaching institute. I worked at Children's Hospital Los Angeles and we had a lot of residents who would operate sometimes. So I always want to make sure that my cut were made and that they were made well. Those metal things that you're seeing on the CBCT are actually part of a chin cup. So, I mean, remember, we're doing a Le Fort 1. Usually when we're doing a Le Fort 1, we're advancing or setting back the maxilla and then we're fixating. In this case, we're not fixating anything and the soft tissue cannot really hold the weight of the maxilla. So if you were not to use a splint and a chin cup, the maxilla would actually be floating. It would actually fall down and then this will prevent your callus from forming because the two pieces of bone that are supposed to heal are very far away from each other. So this is one very important point. So this is a patient, you actually see the patient, if you think of it in terms of distraction, you have the latency period, you have the distraction phase, and then you have the consolidation phase. So our latency period for this kind of distraction is usually between 3 to 5 days. The maximum would be 5 days. We saw the patient 4 days after surgery, and we started her on a face mask. Bolide plates were placed mesial to the first molar in the maxilla and mesial to the canines in the mandible. So I have my patient run whale 14 ounces elastics from the bolide plates in the mesial to the maxillary molar to the face mask in hopes of protracting the maxilla forward. And then when the patient is not wearing the face mask, so the patient will be wearing the face mask whenever she's home. This is basically the general guideline, even for kids in which we're protracting. They only wear the face mask when they're at home. They don't wear it outside because we're trying to avoid trauma, stigma, bullying, all of those. So what about when the patient needs to go out? What do we do? So we are getting some protraction by distracting the maxilla forward, but what is gonna hold that in place when the patient is not wearing it? The patient will have to wear class 3 elastics whenever she's not wearing the face mask. So when you don't have active protraction or active distraction, you're basically stabilizing whatever you got on that day. And then the same way you treat any face mask patient, you're gonna have to work your way up with your elastics. So as the maxilla moves forward, you cannot use this exact same elastics because those are not gonna, there's not gonna be enough tension on those to pull the maxilla forward. So you're gonna have to increase the tension, you're gonna have to reduce the size. There were times when I used like the heaviest elastics that I had, and then I had to double elastics, I had to have them cross the sides. You basically have to be innovative until you get what you're looking for. So you can appreciate how the maxilla is moving forward. And then again, we took a CBCT just to confirm that we're actually distracting. This is a frontal view of a CBCT. So this is a patient treatment progress. You can appreciate how far she moved forward And then the other thing that you need to keep in mind is we're actually trying to overcorrect. At this point, the patient was not overcorrected. I usually like to see my patients in class 2 molar relationship, and then that's when I'm actually holding and stopping my distraction. And then you can appreciate the improvement in the patient's profile view. The patient initially had an acute nasolabial angle, pretty severe retrusive upper lip, and you can appreciate how she has much better lip support at this point. This is treatment progress. And then again, we were basically working, at this point, it was just like any other regular ortho case, where you're trying to settle the bite and improve a patient's smile line. And then this is a follow-up progress step that we took to the patient. You can appreciate that the patient's A and B angle normalized even though we did not do any surgery. And I'm going to show you a superimposition moving forward. I think those are the latest records that we have for those patients from October. At this point, we're just trying to settle the patient's bite. So this is the lateral ceph superimposition, and I apologize, it's in green, it's progress, it should be in blue. But if you look at the regional overall superimposition, you can appreciate how far the maxilla moved forward, and then you can appreciate that the A point moved forward as well, meaning we did get skeletal change. So if you're doing this, how can you tell that you're successful or that you're failing? Like, you're actively doing distraction right now and you're seeing the patient like every 3 to 4 days. What are the hints that you're actually successful? One thing you want to look for is a distraction rate of 1 millimeter per day. Always remember that this is distraction. If you're getting less than 1 millimeter, then something is wrong. Oftentimes, if you get less than 1 millimeter and you actively see that the patient is not progressing the way you want them to, it can be due to late distraction. Remember the latency period. I would not go beyond 5 days. So if you started your distraction late, there is chances that the callus was calcified, and that's why the maxilla is not moving forward. And in those cases, you're actually going to have to send the patient back to your plastic or OMFS surgeon to reoperate and recut that Le Fort 1 cut for you. There are times when you do everything the way you're supposed to, but you still do not get as much protraction as you would wish for. And this can be attributed to scar tissue, especially patients that were operated on multiple times. Because as soon as you protract the maxilla, you're actually activating an elastic system. So you're fighting that elastic force from the scar tissue. And in those cases, you basically have to look for another option, or you're going to have to attempt this again. Sometimes patient can be very compliant with the face mask, but guess what? They're not wearing their class 3 elastic. So whatever protraction you're getting from the face mask, you're actually losing whenever they're not wearing the face mask because they're not running their class 3 elastics. And finally, growing patients. I have done this for patients who were growing, but I did tell them that you may outgrow this, and this is a very important thing to discuss with the parents before you proceed and take this treatment option and offer this to the patient. So who would benefit from this kind of treatment? I offer this for my patients with severe skeletal class 3 malocclusion who are growing. Like, you see them when they're teenagers and they have a very severe class 3 malocclusion, very huge negative overjet, and you know just by the way they're looking now, they're not going to be candidates for orthognathic surgery because they're beyond the correction range. So for those patients, you're not really trying to correct their class 3 malocclusion, we are trying to get them closer to the orthognathic surgery correction range. And then you have teenage patients who have psychosocial issues, those who are bullied because of their retrognathic maxilla, their midface deficiency. I would definitely offer that to those patients, but then again, make sure you tell the parents this is not the final surgery. This correction may and may not be maintained, and your kid could actually outgrow it and still need some sort of intervention later on. I do offer this option to those who are fully grown and refuse orthognathic surgery, and fully grown patients who would refuse internal distractors or external distractors. And there are those patients who would be only candidates for distraction, but guess what? You would not have enough bone to install your distractor. Where there's one case where we tried to install an internal distractor, and guess what? The bone was so thin, the plastic surgeon was saying, by the time we distract, that bone is going to fracture and it's going to fail, and the patient would have been put through surgery for nothing. So we did offer this treatment option for that patient. How do you optimize your treatment outcome? How do you optimize your results? First of all, do not make any promises to the patients, because we don't know what the patient biology is going to be like. We don't know how much scar tissue they have. We don't know how they're going to react. Discuss the chances of relapse and growth with the parents. Make sure when they sign your consent form, make sure this is on the consent form. You don't want someone coming back to you after a few years and saying, we did go through a minor surgery, but our kid relapsed and now they need a bigger surgery. So make sure you clear those things out before you proceed with the treatment. You want to implement your distraction protocol carefully. I usually see my patients every 3 to 4 days, at least twice a week, and I know this is a little bit, may sound like a little bit too much, but you really need to be on top of everything. And if they can't come in the clinic, I do a virtual consult with them, or at least I have them send me photos. I need to make sure that that distraction is actively happening. And I tell my parents, do not stop distracting for whatever reason. If the ball plates are causing pain, if they're loose, they have to come in for an emergency appointment. If you're doing this for the first time, I highly encourage everyone who's, especially orthodontists who are on craniofacial teams, to attempt this if they find a case that is suitable for that. But if you're doing it for the first time, always have someone who's done it before on speed dial. It does look fairly easy, but it can go wrong so easily, and you need someone who have done it before and knows how to troubleshoot. And when you're trying to troubleshoot, try to think outside the box, because this whole thing is outside the box. This brings me to the end of my lecture. I'd like to thank our OMFS and plastic surgery team at CHLA, because if it wasn't for those two men, Dr. Mark Urata and Dr. Jeffrey Hamuda, we would have never introduced this to the craniofacial population. This was not an option a few years back, and now it is, thanks to those two guys, and obviously Dr. Steve Yen, the mastermind behind everything that I've explained today. And then obviously our CHLA orthodontic team, Dr. Ko, Dr. Grandy, Dr. Harris, and Dr. Lemia bin Huwaishul, who was the main provider on this case. Thank you so much. I'm glad to take any questions.
Thank you very much, Doctora. Thank you for this insightful and really useful information. Any questions?
There is no age limit. Like, I've done it for patients who are growing, and I've done it for patients who were done growing. You just have to, if you're doing for a patient who is still growing, you have to explain to the parents that, yes, we're getting correction, but the kid could outgrow it. That mandible could grow more, and they could go back to a class 3 malocclusion. It just reduces how big of a discrepancy it is. And I've had a patient who's almost 17 years old now and have maintained it, but I never promise them that they're going to maintain it. It just depends on how much that mandible is going to grow. Sure. The amount of distraction, the amount of movement forward of the maxilla is what you're trying to get is 1 millimeter per day. Any age group, yeah. If you're getting less than 1 millimeter per day, then it's something may be wrong. That patient is not responding to treatment the way you want them to. That's the distraction rate that you're looking for, yes.
And how much per month I should spend?
I'm talking about distraction, not expansion. So moving the maxilla forward. So yeah. So it depends, like, whatever you need to overcorrect your case. So it depends what was the discrepancy initially. But basically your end goal is 1/3 overcorrection of what you wanted to do, just to avoid any sort of relapse. So if the patient relapsed, they're actually back to class 1. I usually like to see my molars in class 2. So I actually finish them with quite a lot of overjet.
Any questions? Thank you, Doctora. And this presentation from the KDC. our next lecture is going to be at 5:45.
أحمد أحمد
Hello. We are fortunate today to have Dr. Wadah Sabuni with us to give presentation about mastering aligner therapy, expanding possibilities and key considerations. Dr. Wadah Sabuni received his DDS degree in 2002 from Alibo University and his orthodontics degree in 2006 from Paris V University. He did a master's in lingual orthodontics in 2009 and then a postgraduate study in orthognathic surgery in 2011. He's a member of many international orthodontic societies. He is an assistant professor at the University of Dijon, La Réunion University, and the European Master of Aligners. Dr. Sabuni is an international speaker for aligner technology, a Diamond Apex provider since 2013. So let's welcome Dr. Wadah Sabuni.
Assalamu alaikum. It's better now? Yeah. So it's a big pleasure and honor for me to be with you today and share with you my experience about clear aligners treatment, how we can manage cases from simple to complex. For me, it's always a big pleasure to be in Kuwait. It's my second time. Thank you very much for the Kuwaiti Orthodontic Society, for the ortho community, for Dr. Mubarak, and all my colleagues to inviting me to be with you today. So I will share with you today my 5A strategy to manage all simple and complex cases with Invisalign. When you are talking about clear aligners, always the question, what we can treat with aligners? Can we treat only simple? Can we treat moderate cases? Can we treat advanced cases? How we can move from simple to complex? What is the learning curve? How we can improve our skills with Invisalign? I always remember when I started my journey with Invisalign, it was in 2006. And at that time, for me, Invisalign, it was only for very simple crowding, very simple alignment, and very simple cases. And today, I switch 100% of my cases. I treat them with Invisalign. I don't have any cases that the patient know, you are not aligner cases. I need to treat you with the braces. So today, we are able, and we see together how we can move step by step to be able to treat all the cases with Invisalign. I'm practicing in Sanary-sur-Mer, which is a small city on the south of France, between Nice and Marseille, on the French Riviera. We work only with ortho. We have only ortho practice. We are 6 orthodontists working there. We have 10 chairs, and we do mainly Invisalign for all ages. In Dubai, we opened our new clinic, Smile Design Clinic, which is mixed between aesthetic plastic surgery and clear aligners and dental treatment, and Invisalign Center in Dubai as well, where I practice since 2016. Talking about ortho, we need to always remind ourselves when we start our ortho, when we did our study, we had always the digital, the plaster model and the X-ray to do our diagnosis. And I always remember the first study club I did it with Invisalign, where all orthodontists came to me after the study club with the plaster model asking how we treat these cases, how we treat all those patients. That's mean all of us, we learned during our study to create our treatment plan according of the X-ray, according of the tracing, according of the measures. And every time when you ask about this case, the colleagues ask, okay, what is the angle of the lower incisors, what's the angle of MA, what's the angle of the upper incisors? That means all our mind, it was around how we can treat the numbers, not treat patients. We never really learned to treat the patient, to see the patient in his global problem or in his functional problem. Today, everything changed because today, when we have the patient come to the clinic, our nurse does the scan. And within 2 hours, we receive the clean check. We have a huge number of information inside the clean check. We have the roots, we have the impacted teeth, we have the size of every teeth, we have the predictability of the movement. So today we have a huge number of information available. We never learn to deal with all those information. So what do we do with this information? We have two kind of people. The first kind, they said, okay, I trust the technician, I don't do anything, I ask the technician to do the modification. And in this case, we have the learning curve will take a lot of time before to be able to think. And the second kind of people, they said, no, I need to be able today to change my mind and to be able to understand all those data and to move from the one who collect the data or who do the appliance to the one who is able to analyze these data in order to provide our patient the best treatment time. That means today our role is only to be on the middle of all information and to provide our patient the best treatment plan and the best diagnosis. And today Invisalign, it's not a plastic. A lot of colleagues asking me, what do you think? Do you think Invisalign is better than the others? Should I work with Invisalign or Spark or I don't know who's? For me, Invisalign, it's not a plastic. All companies doing plastic with the same way. Today, Invisalign is the digital platforms. So if we need to use Invisalign, we should use all digital steps to be able to treat and to be performant with Invisalign. And that's make the huge difference. When we have 20 million patients treated with Invisalign, we have the data before and after, so we can imagine how powerful the data on the system and how powerful the artificial intelligence used by this system in order to provide the best simulation and the best treatment plan. And you know about the artificial intelligence, the highest level of the artificial intelligence is the deep learning. What is the deep learning? The deep learning, we need to learn the machine how they can improve himself by the data. That means more we put data inside the system, more the system will be intelligent and able to give solution. That means when we treat 2 million patients with the class 2 with this protocol and we get a good result, the software automatically will provide us the best treatment according of those 2 million. So more we give treatment, more we give data, more this system will be very powerful. And that we use it as communication and as setup and as treatment tools. Today we introduced the Lumina, so I think it will happen very soon here in GCC as well, which is the highest level, it's the revolution for the intraoral scan. For the first time ever, we have a scan able to capture the image directly from for the teeth. That means we have 8 different cameras inside the scan, with a very small scan, able to capture the image. So when we start to use it, we'll see it's completely different technology, completely different way to do the scan. We have the face simulation. When the patient comes in consultation, from day one, I can show the patient how the smile will be at the end of the treatment. Not only the smile, the static smile, I can even show him the video to show him how the smile will be at the end of the treatment. That means we can do video. With this video, we can show the patient the before and after, even before to start any treatment. So you can imagine as patient when he see how the smile will be, how the patients will be motivated to do this treatment and how the patient will be very motivated to and this simulation is done according to our setup. That means according of the setup we did, we have this simulation prepared. Every single patient come to the clinic, I do these photos and I do this simulation to show him how the smile will be at the end of the treatment. And one of the latest technology now we have with Invisalign is the facial scan. That means not only to have the photos, today with the iPhone, we are able to scan the face of our patient that take less than 1 minute. We can do some photos. We can create the facial scan of the mask, and we can combine this facial scan with the CBCT and with the intraoral scan. So today we have the intraoral scan, we have the integration with the CBCT, and we have the integration with the facial mask. So I can show the patient in 3D his face, the CBCT, the teeth, how they move, and I can show how the lip will change when I do my movement. That means the patient can see exactly how the face will change for orthodontic surgery cases. When we decide between extraction and no extraction, we have this artificial intelligence help to create this library of deformation of the soft tissue to show the patient how it will be. So today, all this technology make the difference and we help us to use the system of his best way. Just published this article about the audit, how powerful this artificial intelligence. I study around 13 cases with what we expected according of the initial simulation and what we get at the end of the treatment. And with this study, we can see we are very close, we are very efficient with this. Now, what does literature say about clear aligners? And that's very important. If we see even the very recent articles published in 2019, they said the mean accuracy with the clear aligners, it's around 50%. Even the one when they compare Invisalign 10 years ago and today, they still saying, okay, for some movement, we cannot achieve more than 50%. What does that mean? In all those studies, they compare what the clinician prepared, what the predicted movement, and what we achieve with the first set of aligners, without any auxiliaries, without any study about the compliance of our patients. For me, it's not very accurate to do it here. And I think the clinician, it's forced system and not the prediction of how the teeth will be at the end of the treatment. So we need to understand TURED and to use it with the right way. And we need to understand how we can push this limit in order to be able to treat the other 50% and to be 100% accurate as tooth movement. How we can do that? By using all the auxiliaries and all the other tools with the clear aligners. That means we need to move from only say, okay, I did my clean shake and I'm waiting to the teeth to move according of this clean shake, or to be the one who is able to guide the teeth through the clean shake to help the teeth to be on the final treatment. Now I will share with you my protocol about the 5A. What is the 5A? It's the 5 levels of complexity of clear aligner treatment. The first A, with the simple case, we need to do the treatment with aligner only. We don't need anything. We use the shape of the aligner, the plastics, to do the movement. The second level, aligners plus attachment. So we need to use the attachment as well. We need to have the force-driven biomechanics to help the teeth to move. The third level, we need to use auxiliaries, which is the buttons, the elastics, the mini screws, to help the aligners to do the movement. The fourth level, we need to use the adjuncts. That means we need to use sectional braces. We need to use slider. We need to use extra appliance to help the teeth. And the latest level, when we need the other specialty to help us. That means we cannot only as ortho, we need to have the perio, we need to have the surgeon, we need to have the prosto to complete the case. If we understand those 5 levels of cases, according of the complexity, we will be able to treat all different kind of cases. Let's start by the first one. With 1A, aligner only, we are talking about the shape molding effect. That means we are talking about the shape memory. We are talking about the flexibility of the aligners and how this flexibility is able to do this treatment. We are talking about Invisalign palatal expander. We are talking about the mandibular advancement with the wings. We are talking about the elasticity of the aligners to help the teeth to move. Very soon we will have in Kuwait, we have it in Dubai now, the Invisalign palatal expander. Marley, she's my first patient. I use this appliance. I was very, very surprised how efficient it is. I will share with you my first case with this palatal expander. So Marley, 7 years old, came to me because she had, referred by her pedodontist, she had crossbite. So the question is how we can correct crossbite for growing patients. For me, we cannot do it with only aligners. We don't need to have only dental movement. Now we need to have skeletal movement. We need to expand the upper jaw. When we expand the upper jaw, we improve the breathing. We grow the jaw. We have more stable result for long term. For me, it doesn't make any sense to do only the alignment or only the expansion. We need, usually in this case, I use the metallic expander, the traditional one, to do the expansion. When Invisalign started with Invisalign palatal expander, it was my first patient came. I told him, okay, look, let's try to do this treatment with this device. Panoramic X-ray and cephalometric, we can see the crowding. We missed space for the evolution of the teeth. She's long face, asymmetric, and open bite. We did the scan, very important to have very accurate scan covering all the teeth, even the molars, to have enough space to do this movement. And when we order the case, we have now Invisalign palatal expander as option, not only clear aligners. When we choose palatal expander, they ask us only one question: how many millimeters you want to expand? I have up to 12 millimeters. Each expander, it's 0.25. If we tell them I need 10 millimeters, they will send us 40 expander. If we tell them I need a 12, they will send us 48. If we need to have 4, they will send us only 16. So according of the number of millimeters, they will send us the number of expander. We don't have any clean shake, we don't have any simulation, only the expander done with the 3D printed material. Very strong materials. We receive the box, we have 2 templates to put the attachment, and we have all the expander inside. The expanders look like this. The first one is number 0 without any movement. Then daily the patient changes those expander. It's really very, very strong. Every time when the patient change, they feel some pain, some pressure on the jaw, and the expansion will happen. Even the last patient I used with the expander, I combined this expander with a facial mask, only to imagine how strong is it with orthopedic forces, and it's still perfectly fitted. We can see when the patient put it in, only to see how strong is it to put it on the teeth. We have only 2 attachments each side to fix it, and now the expander is on. We start the treatment. Here the very first photos. The good things when we have the expander on, so we have this occlusion. From the very first day, we don't have anymore this crossbite. Aligner number 10, we start to correction of the crossbite. We have the expansion. Aligner number 20, the expansion is done and the crossbite is fully corrected. We can see the shape of the upper jaw. We can see the occurrence of the expander. We can change them every day, every 2 days, twice a day. It's up to us to decide what's the frequency of the change of the expander. And we can see the occlusal photos. It's not tipping. Look, we can see the inclination of the posterior teeth. It's real expansion of the upper jaw. It's real skeletal expansion. It's not dental movement. So it's nothing to do with the Invisalign first or with the aligners. Now we are talking really about skeletal expansion. And we can see the patient smile before and after. And I did very small video with her and her mom, telling she's very happy with the result. It was very easy. And her sister has the traditional expander. She said it's nothing to do with this. She didn't do anything, and she's very happy with the final outcome. And I did the CBCT before and after, and we can see the real skeletal expansion done thanks to this expander. So, and I will tell you, in 2 or 3 years, you will see this appliance will change completely. They will innovate the way how we treat growing patients. Now, what about the adult? How we can use the shape molding for the adult? How we can use the plastics to move the teeth of the adult? How we need to think about this shape memory when you treat the case. This patient, 32 years old, came. He never had any treatment. As you can see, very big crowding of the upper and the lower jaw. Definitely, we cannot treat this patient without extraction because it's have a huge crowding, so we need to extract. But we need to think about this case. What we need to do is to expand the teeth in this side. We need to remove the teeth, so we decide to remove 1.4 and 2.5. Then when we think about the staging, how we can use the reciprocal anchorage to do the movement, I plan to move those 2 teeth inside in order to expand, and when we expand, we use the balloon effect to move the anterior teeth in. That means this shape molding, it's to use this expansion. When we expand, that will help to move the front teeth down. So we can see again the expansion, contraction, and retroclination of the anterior teeth. Now, what about the other teeth? I use inside, outside. I put the canine in and the premolar out. What about those 2 teeth? I did the rotation of those 2 teeth. That means we need to think about each movement, how I can use every movement in order to help the other movement to complete my treatment and to do it. Contraction, expansion, retraction, alignments. And we can see it's very easy, very simple, and we are sure to achieve without any extra aligners when we use this shape-driven mechanics to help the teeth to move. Exactly the same of the lower. We decide to remove those two premolars. We need to procline a little bit these teeth. In order to do it, we contract a little bit the second molars. When we contract, we push those tooth in order to be aligned on this one. Now we need to create the space here. We remove this one. We move this one outside, those two inside at the same time. We open this space, and they will have the teeth to move. The clean shake, contraction, expansion, alignments. And we can see the final result. Using the shape molding, it's the more powerful things we can have with the clean aligners. In this case, we need only to see the staging of the tooth movement in order to complement this movement to help us to achieve this final alignment for our patient. Without any extra aligners, we achieve this result. Now, after the shape molding aligners, after the shape-driven biomechanics, we need to go for the force-driven with the attachment. We need to have the attachment in the same case when we don't have enough contact between the aligners and the teeth to do the movements. I will share with you the case of Thomas, which is very nice patient because he had first a treatment with one colleague before I saw him. The idea of this treatment, so this patient had orthodontic treatment in the past because he had a genesis of one upper and the lower, the 12. And they tried to open the space. When he finished the treatment, they put the bridge to wait the age when he can put the implants. And when he went to the surgeon to put the implant, they told him we don't have enough space here to put the implant. So we need to re-axe the roots, and then when you have the space, we can put it. So he had the first step of treatment, 26 aligners, expansion, alignment. And when he finished those 26 aligners, he went to the surgeon to put the implants. The alignment was good, everything is good, but the surgeon, when he saw the patient, he saw there is still no space for the implants. So he contacted me asking, look, I had this patient, he had Invisalign, I need your expertise. Can Invisalign move the roots? Can Invisalign open the space to put the implants? Or we should move to braces or something else? I told him we can do it with Invisalign, but we need to have very specific protocol. We need to use specific attachment. We need to choose specific shape. I create another clean shake. With this new clean shake, I use slash attachment. Those inclined attachment to help the tooth to move. I use a small pontic. Why small pontic? In order to get more contact on the side. And I use the overcorrection to open the space. This means I use different technology, double attachment, slash attachment, small pontic, overcorrection, all combined together will make this movement happen. The patients wear the aligners perfectly. Even with these small pontics, we had the aesthetic of the smile that doesn't affect the smile. The space perfectly opened. We were able to put the implants, and we can see with the temporary crown. Patient smile after treatment, and we can see before and after. Same number of aligners, small change, would be able to treat more difficult cases. We use the beveled attachment, we use the double attachment, we use the small pontic, and the overcorrection. Combining these three technology, we were able to treat these cases. Elastics 316, 4.5 on the side. What about the third level of difficulty? So we finished the aligners only, we finished aligners with attachment. Now let's see the third level with auxiliaries. Why we need to use the auxiliaries, but sometimes we need more forces, we need more help. The aligners only cannot have enough encourage to do all movements. And I will share with you the case of a Florent. Florent came to me because he has TMG problem. As you can see, he has crossbite in one side, class 3 in left side, cant of the occlusal plane, and here the intraoral photos. The question is, can we treat this patient without surgery? Because we know to correct the crossbite, we need to expand upper jaw. To expand the upper jaw, the ideal protocol is to do SARPE, so we can open the upper jaw, correct the crossbite, we can resolve. And he said, I saw already 3 orthodontists, all of them told me we need surgery or I need MARPE and I don't want this. So my question, can we treat me without any surgery? 2 or 3 years ago, I didn't have any answer. I told them, no, I cannot. Today, thanks of the digital orthodontics, thanks of the CBCT and the integration between the CBCT and the intraoral scan, I can give him an answer. I told him, let me do the scan, and I will see what we can do. The wisdom teeth is here, the the X-ray, and we can see the clean check. So I did the clean check study. With this clean check, I tried to correct the crossbite with maximum expansion staying inside the bone. That means I try to expand until I start to hear the roots in contact with the bone. That means I pushed on the maximum of the tipping. I didn't do badly movement. I did more tipping movement in order to stay inside the bone and to be able to correct this crossbite. So I expand the upper, I retract the lower, I use crisscross elastics, and it was possible to correct it. On the other side, I did only distalization after extraction of the third molars. So we removed the 38, and we did distalization of the lower teeth with vertical attachment to correct the class 3. Very compliant patients, very happy for this treatment. I told him, for now, I'm not taking care of the cans. The only thing I need to focus on is the crossbite. Elastics crisscross on right side, always elastics 1-to-1, so I not create any rotation or any other movements. And on left side, it was the class 3 elastics. Very compliant patients after first set of aligners, crisscross corrected, class 3 corrected, midline on, no any pain on the TMG. Patient's very happy. He said, now I'm very happy, I don't have any problem, but gets very complex with my smile and with the cans. How we can correct this cant without surgery? Any screws. So when you mean screws, how we can do, we need to have 2 TADs. So for the who will join us tomorrow for the workshop, I will talk more in details about these topics. I create another phase. With this phase, I untrude the teeth on the left side, I extrude the teeth on the right side, so vertical elastics on the right, 2 mini screw on the left, the 2 mini screw, one outside, one inside, and the elastic through the aligners with a very easy way. Only 6 more months treatment for this phase. After 6 months, we can see the cant is corrected. And when we see the progress, very first photos, after the first phase, after the second, I think it's limited surgical case, it's surgical case, but thanks of this small step, we were able to treat it without any surgery. What about the 4th level of complication? The 4th level of complication when we need the adjunct. When we need the adjunct, when we need more difficult movement. Like if we talk about mesialization of molars. We know mesialization of molars with aligners only cannot happen. When you talk about intrusion of group of teeth, we know aligners only, it's very difficult. So sometimes we need to have more powerful tools. We can do it with aligners only, but it will take ages. That means if we need to mesialize more with aligners, we need to overcorrect, we need to slow down, we need to change the aligners every 2 weeks, and then it will take 5 years for something we can do it with the aligners, with the adjunct very quickly. So we can use today the digital orthodontics. We can use any digital software. I use appliance designers. I use OnyxF. I use all software today help us to design the appliance. We have the digital appliance or digital models. We can design. The first one, in order to mesialize the molars, it's very easy, we can do it. This one to untrude the 2 molars, we have it here, we untrude it. This one to mesialize the molars, we can do it. This one to upright the second molars. So today, no limit with what we can do with this adjunct. Every patient, we can create his specific appliance, and we can do it. Please read this article about the golden circle and how we can use those appliances or those auxiliaries in order to help the aligners to complete what we can do with the clear aligners. Sophie, 35 years old, came to me because she was very complex with her smile, and she needed to close the space of the 15. As we know, open bite with the clear aligners is very easy. Class 3 with the clear aligners is very easy. But it's very difficult to close the space by mesialization of the posterior teeth. That's why for my plan is, let's first to do the clean check, close the space, align the teeth. When I finish to align the premolars and the canine, I need to add my auxiliaries to mesialize the 2 molars. So first step, extrude anterior teeth, correct the class 2, and then adding the adjunct to help the teeth to move. Which adjunct I decided to do for these patients? It's my specific slider. These sliders, when I finish to move this canine and the premolars, it's bonded only on those 2 teeth, and we have here 2 power arms and very high section of the arch wires to move the teeth. And we have the aligners on top of it, so the aligners will guide the movement. So both aligners plus this expander, after 2 months, after 4 months, after 6 months, the space is closed. And we can see the final step, open bite, close, the bite is correct, and we don't have any space on the side, and we get perfect mesialization of posterior teeth. So if we need really to achieve the good mesialization of the roots, very important to combine aligners and adjunct. And patient's very happy with her smile. Now, the last part of complexity of clear aligners, it will be the 5 A's when we have aligners, attachment, auxiliaries, adjunct, and adjunctive. That means we need to have now other specialty to help us to do the treatment. We need the prosto, we need the perio, we need the other specialists to complete our treatment. Landry, 30 years old when he came to us. He lost his upper incisors when I think he had 6 or 7 years old. Very complex with his smile, never smile. He went to the dentist to put an implant, and he told the dentist, I don't want to do any orthodontic treatment. I need only to put my implant as soon as possible because I cannot smile anymore with my teeth. We can see the intraoral scan or the intraoral photos for this patient. Big crowding of the lower, and we can see the inclination of the upper incisors. So the dentist told him, look, I'm not sure I can do it without ortho. We can try if you want, but we need really to file completely your teeth. Let's have an opinion with the orthodontist, then we can decide. Today with Invisalign, we have very powerful tools for this kind of case, which is the Smile Architect. I don't know if you heard about this Smile Architect. Smile Architect, it's for all prosto cases. We are able to simulate the prosto, or simulate the implants. We are able to see how much we need to file from the teeth if we do the implants before to start the treatment, and we are able to create the mock-up to show the patient how he will look like after treatment. So this patient, we start from this position. So I told him we need to open this space, we need to procline, we need to do this expansion, we need to remove the wisdom teeth on the lower, and the treatment will be much better. I submit the case as Smile Architect, so I was able to decide the midline and the position of the teeth, the size of the teeth, the shape of the teeth, and everything before. It was 48 aligners, 1 year treatment time, so I told him what we need to do. That means expansion, alignment, small distalization. And I show him, which is the more important things, if we do the treatment without any preparation, I told him we need to cut all this pink part of the teeth. If we do the treatment, we don't need to do any preparation. We are on the no-invasive dentistry. If we need to do today the crown, we are able, but look how much we need to remove from your teeth. And if we move the teeth, look how those pink parts will disappear and will become only yellow. That means will be no invasive dentistry and will remove less than 0.5 millimeter of your teeth. So now up to you to decide if you need to cut fully your teeth or you need to cut only 0.5 millimeters. So for the patient, it's very helpful to show him this, to show him how the future veneers will be, how the future crown will be, and how his smile will be at the end of the treatment. And we can play with the patient to place those crown, to change the shape of those crown, to change the length. So everything it's today, we have it available. And we can export this project to give it to our dental technician in order to create the mock-up. So this patient, even before to start, tell him, look, let's have a mock-up before to start the treatment. This mock-up, the first day of the treatment, the patient was able to see how his future smile will be at the end of the treatment. So we can imagine this patient came completely depressive, and he see the photos, he see the scan, he see the preparation, and he see how his smile will be at the end of the treatment. So definitely this patient, it's already done. The patient is convinced, and he's able even to pay anything you're asking for to go for this treatment. We start the treatment, we do this expansion. During the treatment, we put the implants. We have the pontic inside the aligners to cover the space. We export the project to ExoCAD. You know, today Invisalign and ExoCAD are together, so we have the same. So we create the virtual articulator. We create our project with the facial scan. And from this, now we are able to create the prosto parts, to create the crown, to create the veneers, and to finish the treatment. And we can see the X-ray before and after, opening space, putting the implant and the crown. We can see patient smile before, the simulation. We did it when we started the treatment, and what we achieved at the end. So patient's very happy, and here what we get as final result. Now, I will share with you the case of my dental nurse. You know, it's always very difficult to treat you. His nurse, because you have it all the day with you in the clinic. So if you mess up with her, if you create any problem, you know, this patient will see you every single day and look, Dr. Shu, see my teeth, I have a problem. So Leticia had treatment before in the past. She was happy, but every time she helped me on the consultation, she saw I explained to the patient, we can expand the smile, we can improve the alignment, and she was always complex because she had black triangle on the side, so she wanted to expand her smile. She had extraction of 2 upper premolars on the past, and she had small crossbite, small alignment. So nothing major, it's small treatment, only small expansion, alignment, correcting this crossbite. So when she came to me, okay, it's easy treatment, we can do it after 3-4 years. I told her, okay, let's do it, do your scan, and I will do your clean check. 28 aligners, it was around 6-7 month treatment. Expansion of the upper, the rotation of the lower canine, alignment, it's nothing big as a treatment. What do you think about this clean check? Easy. We don't need to think about anything else. Look, before and after, the main things I need to do, correcting crossbite, small rotation, small expansion, that's it. Patient's very compliant, wear the aligners every day. After 4-5 months of the treatment, the alignments start to be very good. And she came to me, she said, Doctor, it's normal to have this small recession start to appear in my upper canine. There is any problem with this? She said, no, it's not a problem. It could happen. Start to try to change your dental brush. Use very slowly the movement and try to do a massage and move your teeth from up to down, and everything will be fine. 2 months later, she said, look, I'm not sure they improve. I have the feeling it start to be worse. I told him, no, the only things we need to do is really to go slowly and wear your aligners only at night and don't change at all. She said, okay, that's fine. 1 month later, it's become worse and the gums start to be a bit transparent. So look, we should stop the treatment. Let's have fixed retainer, and we stop to do anything. 2 months later, we start to have like a white dot on the gum. So she said, what is this? So I try with the Explorer. It's very hard, so it's not an abscess. So I'm okay, you need to see the endodontist. So I refer her to the endodontist. He saw her and she told me, okay, I think it's problem with the shape of the roots. I need to do very small surgery. So I will open the gum, I will file a little bit the roots, then I will close, everything will be fine. Okay, if it's very easy, let's do it. She went there, she did this small surgery, then she came. 2 weeks later, she told me, okay, doctor, can I show you my teeth? I said, okay, please. It was like this. So that's normal to have this roots completely out? I don't know, yes, maybe it's part of the process. I called the endodontist, and what's happened? He said, no, I opened the roots to do my filing, and I saw the root was completely out, no bone around it, so I tried to close it, but it's very difficult. So I didn't say anything to the patient. 2 weeks later, it was like this. So when I saw this, I started to panic. I called 2-3 colleagues. I told them, no worry, everything is good. And I told him, maybe we need to put an implant, so in this case, it's better. This tooth, it's not very nice. We have something better. I called 2-3 colleagues and told me, no, we cannot put an implant. We don't have bone. If we need to put an implant, we need to remove the laterals. We need to put the premolars, so we can put 2 implants on the side. We need to have fake gum here, and everything could be fine. And you imagine we have your dental nurse came to you, everything is good. We didn't do anything wrong. We did only small expansion, and we end up with this situation. So I started thinking, okay, how we can deal with this case. I did another scan. I told him, okay, let me do it. I asked Invisalign, please add lingual root torque. So we need to know Invisalign is one of the more powerful system to have the lingual root torque because we have this space between the two contact points around the crown. So I did this lingual root torque, I overcorrected, I add around 20 degrees. Everything went very well. Then I called my periodontist and told him, look, now the root is inside, please add your gum graft and it will be fine. He did the gum graft around this root in this situation. He did it 2 years ago. Then he did another time. I did the photos last week. Everything is perfectly stable. She keep working with me. She's very happy and everything is good. But my suggestion to you, please don't treat your dental nurse. Try to find someone else. So we don't have this kind of problem and everything will be good. Now, how we can do to avoid this kind of situation? I have this patient, very similar case. I never do any expansion without to combine the CBCT with the clean shake. I never do this expansion anymore. Because even look, this case, it's simple expansion. If we see for this case how the teeth move out of the bone, when you do this treatment, we understand we should really be very careful, and every single patient, we need to do the CBCT and to combine. Never do expansion if we don't have CBCT. All the time we have CBCT, we see the bone, we see how much you expand, and we see how much you can, and how we can avoid this kind of situation with this. So we can see this. Now it's very easy before to approve the clean shake to add some lingual root torque to avoid this fenestration. We can today see all the way, we can have the 3D views, we can see the combination between the 2D and the 3Ds, and we can decide exactly how much we can expand, how much we can incline, and how we can finish with the right way. And here what we approve the clean shake, we can see how different this clean shake with the very first one we receive it from a line. The last patient I will share with you is Julie. Julie, 35 years old. Never had any treatment before, very complex with her face. We can see she had major asymmetric, class 3, crossbite. She went to 2-3 orthodontists. Everyone told her, we need 3 years orthodontic treatment with the braces and no way to have orthodontic surgery and ortho protocol with aligners. Do you think we can treat this patient without surgery? No, we cannot. It's skeletal problem. Now the second question, can we treat it with Invisalign or we should treat it with the braces? And if we treat it with Invisalign, how I can prepare this case? So my protocol for all orthodontic surgery and clear aligners, I try always to go for surgical first approach. I try always to do the surgery from day one. Some case we can do it, and some case we have small interferences. My orthodontic treatment before the surgery only resolve this interference. Don't go for have full preparation like braces. Don't do the full decompensation. That's mean in case like this, the only movement I need to do before the surgery, it's intrude the 2 lower incisors and left side. That's it. When I do this intrusion, in this case, I can do the advancement, the expansion of the upper jaw, I can correct the asymmetric, then I can do the rest. So if we can see in this X-ray, she lost her upper molars, and we have the second and third molars completely tipped. But I can take care of it later on. It's not my priority now. I know I need to use adjuncts here to correct, to upright the molars, but I can do it later. For now, the only things I need to focus on it's to intrude those 2-3 teeth in order to be able to do the surgery, which is only 16 aligners, only 4-month preparation. Here, the only treatment we did before the surgery, only this intrusion of those 3 teeth, and that's it. How we can do this intrusion? We need the help of auxiliaries, so I use here mini screw and elastics between the aligners to the stud. These elastics will help the tooth to intrude, and from here now, we are ready to go for the surgery. We put the expander 1 day before the surgery. We have the lower aligners, we have the buttons outside and inside. Now the surgeon is ready to do the expansion, correcting the asymmetric, the advancement of the upper jaw. 1 day after the surgery. Now the case is done, I need only to have my finishing. I keep the expander on, I did my scan, and I do very small alignment to move the teeth on the final position. When you finish the surgery, we can change the aligners every 3-4 days because everything is very fast. Patients very motivated. After only 6 months, the teeth perfectly aligned. Now it's the time to take care of the 2 molars on the side. How we can do for those 2 molars? We need to add sectional braces, sliders, any kind of appliance we can do. I removed the expander and I did my setup to align the teeth. I asked to have cut-out buttons because I know I need to use here some auxiliaries. The auxiliaries I choose for this patient, it was sectional braces. Only 4 braces, arch wires, help the teeth and help the aligners to do the movement. 6 months later, we are here, everything's achieved. The sagittal, the transversal, the teeth, and the alignments. And we can see the photos before and after, and we can see the intraoral photos at the end of the treatment. Patient smile before and after. Cephalometric before and after, and patient smile before and after treatment. For all protocol about orthodontic surgery and all details, we can see these articles and similar in orthodontics. So we try to describe in these articles step by step how we can do this sort of preparation in order to be able later on to do the surgery with very short treatment. As conclusion, what we can see, we can say to be able to treat all kind of cases with the clear aligners, we need to respect those 5 levels of complexity. The first one, we need to think about the shape, molding, and about the shape of the aligners and how we can use the elasticity and the memory of the aligners to help us to do the movement. The second level, it's about the attachments. We are talking about the force-driven mechanics, how we can use this attachment to receive the force. The auxiliaries, we need to start to use the elastics and the mini screws when we need to have an extra anchorage. The adjunct, when we need to have a group of movement, we need to visualize molars. In this case, we need to have another kind of appliance. And the adjunctive therapy, when we need to have the extreme cases, we combine the different specialists together. I will finish with this words of Nicolas Jvade, the president of the World Federation of Orthodontics, saying the orthodontics appliance, while powerful, are never absolute. The creative planning and the data-driven objective will help us to achieve the most optimal clinical outcome for our patient. I hope it was helpful for you. Thank you very much for your kind attention.
Thank you very much, Doctor. It was really useful and insightful lecture. Any questions?
The Invisalign normal expansion, we are changing the arch form. There is big difference between what we call the arch development and what we call the skeletal expansion. Skeletal expansion, we open the bone. When you open the bone, we can improve the breathing, we have more stable results, and we don't change the inclination. When you are working about the arch development, we can achieve the same aesthetic outcome, like the adult patient. For the adult patient, we cannot do this expansion without MARPE or surgical. So we do it with changing the arch form with the arch development. So there is a big difference. We have a chance for the growing patient to be able to work on the growth, to work on the bone. So we need to use this chance if really we need it. So we need first to have very accurate diagnosis to say, okay, this is skeletal problem and this one it's a dental problem. When it's a dental problem, we can do it with arch, changing the arch form with aligners only. When we have skeletal problem, we need to use more powerful tools. We need to use expander.
Because the cutout usually they are high, so you need to adjust every tray, every aligner to be fit with the brackets. Is there a way in the software that we can ask the technician that we're going to add and make it faster?
So the only way we can do, you have 2 advice. The first one, it's much better to put the braces before to do the scan. Because for this case, what I did the clinch check, I asked to have the cut out, then when I receive it, I put my braces and I adjust the cut. And I did it for every single aligner, which is time consuming. The other option we can do is to put your braces, you put your passive arch wire, then we do the scan, and we ask Invisalign to shorten the limit of the aligners to be lower than those braces. And in this case, we have the aligners lower than the braces, and we don't need to touch anything.
That's really nice. Thank you for the tip.
Thank you. The protocol with MARPE and clear aligners. So depending patient age and depending the type. So I try to use, so tomorrow for the workshop we can go more in details about these topics. So I try the MSE system, the one of Moon, and I try the system of Benny Slader, and I try one other French system. So 3 different systems. The first things, if we can achieve the opening of the suture or not. I try always the first 4 or 5 days with very big amount of the expansion. With MSE, I do 6 expansion per day, then 4, then you know how it works. Now, when I finish to do my last expansion, I have the diastema, I leave everything stable for 2 or 3 weeks, and I do my scan 1 month after the last activation. I never use the combination between expansion and clear aligners simultaneously. I try for some patients to try to create the clinch check to be synchronized with the expansion, and I ask Align to expand 0.25 millimeters in the same time as my expansion, but that doesn't work. So if we need something, we can really use it for every patient. Do first your expansion, do first your MARPE, finish first the expansion. You see if we can achieve or not slow expansion or speed expansion. When we finish this, leave it for 1 month to have some relapse of the diastema, then start Invisalign without any problem, without any risk. Now, for some patients, I can achieve this expansion. So maybe for the patient less than 30 years old or for all women. For the man after 30 years old, I try first for 3 or 4 days to do this expansion. If I didn't achieve it, I move for the slow expansion. I do it only once a week in order to get for slow expansion, and you can get good result at the end. Absolutely. That's very good the question. That's mean, do we need to keep the expander during the first phase of Invisalign, during the 6 first months to stabilize, or should we remove the bands and do the scan? My protocol, I keep the expander only on the palate. That means I keep the 4 mini screw and the expander, I cut all the side, I remove the bands of the molars, and I move everything together. Because it doesn't make any sense. The good things, we have these mini screws, and we have the option to stabilize the expansion only with those 4 mini screws. So why we block your molars? That's other story. If we don't need to move the molars, in this case, yes. But if we need to move them, let's move them from day 1. As soon as we finish the 4 weeks after the expansion, cut and start. Thank you very much. And the day when we do the scan for Invisalign, immediately the patient will start wearing the S6 full time to maintain. And I ask to have the S6 with more retentive palate. Not only the normal S6 on the teeth. That means I have to have some extension of the palate. So I have strongest transversal treatment.
Sorry, do you use a Holy retainer instead of the normal VFRs, or?
The problem with the Holy retainer, that doesn't maintain the teeth. So I use thermoformed aligners, but these aligners, when I ask the technician to cut it, I leave some extension on the palate side. I don't cut it only on the teeth.
Thank you.
It's digital, it's actual mock-up. That means I export the STL file with the digital mock-up to my technician, and the technician creates this normal mock-up. The patient put it on his teeth, and he leave it for 2 days to show around him and to see how nice is it. And when he came, he said, look, doctors, I'm ready to start the treatment, and that's what I want. And I think that's the only chance we have as orthodontists to get this very nice feeling for our patient from day one. Because usually with ortho, we wait at least 1 year before to see the patient, the difference before and after. Here with these tools, we have first the video, second we have the photos, and third now we have these digital things, so the patient will be in our pocket. So the patient, when he see all those tools, he says, okay, why I need to wait more? The dentist is the difference. The dentist from day one, they used to deal with this with this patient very happy because they can do in 1 hour, they can do something. For us, it's very different, and thanks of my architect today, we are able to play with this kind of thing. So for this patient, on the upper, we advanced the upper jaw and we did surgical expansion. That means it was not SARPE. We did the full expansion during the surgery. Since the amount of the expansion was only 5 millimeters, we did it only in once. That means during the surgery, we moved the upper jaw forward, we expanded, and we correct the asymmetric of the lower. 3D surgery in same time.
Why do you prefer to start with surgery first, then orthodontic treatment with orthodontic cases? Is it general for your...
That's a very good question. So different reasons. First reason, so braces and aligners, I use these techniques. First reason, because the patients hate to have to wait to do the surgery. And mainly, you know, when we start the decompensation, the patient become worse and worse and worse for the surgery. And when we are ready to do the surgery by the patient, it's came very complex and become more complex than when he came. So that's the first reason. Second reason, because when we do the surgery, we have 4 months after the surgery of top, which is everything move very, very fast. And even the quality of the tooth movement after the surgery, it's much higher than how it was before. That means we can achieve in 4 months what we can achieve usually in 1 year. So that's why I use this RAP after the surgery. That's the second reason. Now the third reason, which is something very specific to the clear aligners, it's very hard, very, very hard to achieve full decompensation with the clear aligners. That means we cannot compare the quality of decompensation we have it with the braces than with quality of decompensation with the clear aligners. So we never had with the braces 2 hours perfectly neutral to go for the surgery. That's why I prefer to do first the skeletal correction, then I deal with the dental movement.
But you didn't come across where, for example, you had limitation of surgical correction because you didn't decompensate?
That's why we need really to do very accurate skeletal setup before to start. And if when we do our skeletal setup, that's from day one. If we see the surgery is not doable, we should continue the compensation. That means our decompensation, it's only in one objective, make the surgery doable. When the surgeon said, okay, now I can do the surgery, let's do it. Don't compromise with the quality of the surgery. That's why I take my time before. I try to be as short as I can, but if I need to add 2 or 3 more months, I will do it till the surgeon is completely happy with this.
Thank you very much, Doctor, for this insightful lecture.
Thank you very much.
Thank you.
Thank you very much.
This is a little appreciation from the KDA conference.
Thank you very much.